Myself. And Dr. Baker.
Present.
Dr. Johnson.
Here.
Dr. Gaither. Here. Dr. Augenstein. Dr. Foster. All right, we have quorum for MEC. Next will be the roll call for PMD. Right here. Dr. Connor is out of town. Brian Smith.
Present.
Chester Key.
Present.
Dr. Cass-Marin.
Present.
Dr. Gamer.
Present.
Heather Miller.
Present.
Dr. Johnson.
Here.
Dr. Gaither. Here. Mark Hansen.
I'm here.
Matt Schwab.
Present.
Dr. Dabrowski.
Here.
Dr. Hannah. And Dr. Bush. Here. All right, we have a quorum for both of you. All right, well, thank you, everyone. We appreciate your flexibility changing meeting spaces here, but this way we at least have a little bit more space as we spread out. A couple things, this is unique today. There's breakfast, coffee, there's also water and sodas in the back. We will have lunch coming around 11:45, so we will have food for lunch as well. Feel free to get up and take a break whenever you may need to. The bathrooms are just outside the door. What we are really trying to do today is to kind of get through all the TTTGs. We had kind of some little stop and go movement that slowed this process down. And so the group is really wanting to try to get this all done in one day, which is a pretty big lift. One of the key things is just to try to make this more efficient. We're going to go through each section, so general medicine, airway. The goal is to get all possible corrections or updates made in that section between the two committees. And then we will vote. PMD will vote first, and then MDC will vote. So the goal is to not vote in individual guidelines separately, and also not have further debate once we get to a vote. So let's try to get all of the discussion and any cleanup items taken care of in that discussion piece. The other key thing with this, Google Slides is a little bit tricky to work with. So any formatting things, spacing, hyphenating, anything like that, we will do that offline. This is only the medical content. So if there's medical content, like we need to move something to a different section, because we feel like it should be in an EMT section or AMT section, we can absolutely do this here. But in the interest of time, any formatting type issues, we will not cover that in this meeting today. We do have also a copy of Scope of Practice available, and also an Accesso Model EMS Clinical Guidelines if we need to reference that. And we can also pull up, I think on that screen, the current TTTGs. So if we want to look and see what it looks like currently. Any questions about that process? So we will follow the normal open meeting rules. So we'll need a motion to discuss, amend, and approve. So if I can get a motion, please.
So moved.
Thank you. Second. I see a second on the drum. All right. So the first one we are going to start with is universal care. I know we had covered some of these before, although some of them when they got from PMD to MDC, there were some questions and they got kicked back. So we will go ahead and look at universal care. Josh, did you have anything, or do you want me to cover it all?
Oh,
it's your section.
I'm sorry.
That's okay. I can also go through it if you'd like.
Go for it.
All right. The only update to the universal care one, this is adult and pediatrics, there's 2 pages, but at the top under EMT, there was added in determining for MCI triage, before triage. So that was really the only edit made to this guideline.
I came up with something at the bottom, which was under AMT, we use the abbreviation ETCO2. But it's explained lower down in the document, the last line of paramedic. So I propose that we use under AEMT, trade the wording. So at the bottom where it says consider waveform capnography and then explains the abbreviation, I suggest that we move that wording to the AEMT section and then only use and title ETCO2 abbreviation thereafter.
Before moving, since we're now including EMT, STRs, and then forms of STRs in here, seems to me like it would be appropriate to put that line about entitled CO2, and after it put STR for EMT up in the EMT section, as well as, and do away with that line in AMT, as well as move the IDIO access and initiate I fluids up into that section with the STR for EMT.
Except you can't move the IO up.
Or excuse me, with an
IO.
consider IO at the AMT level. And then there are a whole bunch of those things in here. So in the event of saving time, can I make a motion that we move all those things later on that's appropriate to move into that, and not
To do it every
not included on every single one of them that I have a note on here? There's a lot of them.
Great idea. Yeah.
So the motion on the floor is to move two items. The first is to move, entitled CO2 STR. Do motion. Oh, I'm sorry. So that will be to move entitled CO2 STR to the EMT section for the entire document,
IV
and then
fluid.
also move IV and IV fluids to as STR, entire document as well.
And then anywhere where it says IO, because some of them don't all say IO at the AMT level, but wherever it does, that may just because of the acuity of the patient that fits in that area. I didn't have time to like really compare that. But consider IO at the AMT level for all of those changes too.
And then can I add to it, because we could also move the EKG up as well for EMTs.
EKG acquired and transmitted.
Yeah, acquired, yeah, with it, yeah.
So ECG acquire and transmit to the EMT section, entire document, and then I heard consider IO at the AEMT level.
Yes.
Okay. Yes, so it'll be much more efficient if we do it in this format, so. So we will do two separate votes. So we will do the PMD vote first on this one. So everyone who is on PMD, anyone opposed to those changes, please say nay. Any abstentions? All those in favor say aye.
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 And then MDC. Any opposed, say nay. Any abstentions? All those in favor say aye. Thank you for that's a big housekeeping item, so thank you.
Initial minor edit under EMT I paramedic, the clause in the middle where it says where available, is that needed anymore throughout the state at a paramedic level?
For the 12-week
Yeah.
ECG.
I mean, is there anywhere in the state where we're concerned where paramedic level providers not have 12-week access?
But I do like wilderness medicine. That's the only thing, it's a stretch, but that's the only thing I can think of.
But in general, the concept of wilderness medicine is kind of, you know, there's some latitude of career there.
In 2009, that was totally true apparently, because I had put that in a previous revision, but whether that is still true today or not, I don't know.
I propose removing that then, removing that clause.
The next page of this is the pediatric assessment triangle. I don't think there's any updates.
You need a second on that?
So we're going to vote for this whole thing.
Sounds
We're gonna
great.
take it up. All right, syncopy and pre-syncopy, we had discussed this at, the previous, meeting. This is, I don't think we had any changes to that one.
Just a quick question for that one. On the first box, it's under exclusion, patients with trauma referred to TBI. Do we also need to say, and general trauma management, general trauma? Because on the next page, it says excludes, and then it mentions look at TBI and general trauma, just to make it consistent.
Under AEMT, first bullet, titrate to systolic blood pressure greater than 90. I propose that we extend that wording to titrate to maintain either MAP greater than 65 or SBP greater than 90.
Any thoughts on that from anyone else? Not greater than 65.
Can I make an amendment to that?
Sure.
Because there are some other places where there's MAP only, there's some places where there's SPP only, to, that's all of those as appropriate for the whole document.
With the caveat that there are some places in the document where we may need to add wording such as or age appropriate blood pressure.
Any further recommended edits from syncope?
Yes, just a small word change. The last bullet under paramedic, replace the word perform with acquire.
Any further discussion on syncope?
Should we say acquire and transmit? Sometimes we're not getting EKGs that we'd like
I've got
to
one
get.
agency in the entire northern region that can transmit a 12-lead EKG. The technology is not there to do it in many places.
Right. It's mostly a self-service issue.
And proprietariness between every monitor manufacturer on the planet to make stuff, to make that happen. At the EMT level, it was a very special deal because they can't interpret the EKG.
No, understood.
Yeah, so this one, I agree with Brian. It's appropriate to have it as, acquire and then an implied interpret for a paramedic scope of practice, as opposed to transmit, a mandatory transmit comment.
And we would just move that up, our standard.
Could you all,
You want me to?
Yes.
could you go ahead and do transmit where available also? I mean, you could acquire and transmit where applicable or where available and or interpret.
So I think the
I
interpretation is
fine.
fine,
Not everybody has that ability. We understand,
Yeah. Acquire and interpret. Acquire, interpret, and transmit when possible. I get the acquire and the interpretation as part of their scope of practice, but
I would suggest that interpret's implied.
Yeah, I think when we say the word, like in the previous one, in universal care, we say perform. So I think perform includes acquiring and interpreting and transmitting. So perform means all those things. So I think we could simplify all the paramedics to say perform, and all EMTs acquire and transmit. Yeah, I think performing it includes all those things where it's available.
I guess it doesn't always happen. That's why I'd rather be more explicit.
So just to clarify, then, are we gonna move up above? We will move the EKG, the acquired transmitted, just like the rest of the document, the EMT section, but we will keep it perform under paramedics. Is that correct? Yeah.
So do we need to do that though? Because this one in particular says universal care. It's already going to be in universal care, right?
I think
For the EMT level, particularly.
the discussion was just to make sure with syncope that it
Yeah.
reminds people that syncope is probably a good idea to do a 12 lead.
Yeah, okay.
Any further discussion about syncope? I agree.
Yeah, that's right. So, when possible.
Next, for suspected stroke and TIA, I had a couple, thoughts on this one. I think the last one we had discussed, we take off the term suspected and just start with stroke/TIA.
No, I'd actually like to go back and
Okay.
say, rather than perform, which is ambiguous, say acquire, interpret, and transmit when possible. Because we're not getting them all transmitted when possible. I understand some can't, but, and it's resulted in some, delay. So I think, no question they should inquire it and interpret it, but I think if they can transmit it, they should transmit it.
But that'll be blended into where we're doing it across document under the EMT scope of practice, acquire and transmit.
Right, but what I'm saying is, under the EMTI and paramedics, we're not getting them transmitted when we should. And if we don't explicitly state that as under medical direction, it's not going to be the criterion.
So you said like what she has there, just put when transmit when possible.
Yes.
Performing obligate
Yeah,
transmit.
yeah, and if you want to leave perform and it means, you know, an inquire, interpret, I can live with that, but I do want to include transmit when possible, yes, please. So.
Everyone good with that? All right, the next is stroke. The recommendation is to take off suspected. And then one of the things that under EMT section, use a validated pre-hospital lead stroke scale. I recommend using a pre-hospital stroke screening scale. Adding in the term screening.
So that is another wording change that I propose be carried across the entire document. There's several of those where currently it just is typed out pre-hospital stroke scale. And so I agree with you, the stroke screening scale, but that's a document by edit.
And then question I had was, we have ensure patient safety. I'm not quite sure why we have this document and this guidelines, but none of the others. I feel like we could take that line off.
Agreed.
What was that?
Ensure patient safety. I feel like that's a given. There we almost did the last time, but I feel like.
I don't know. Have you seen that video on those two entities in church with murder?
Oh, yeah. We all agree it's good, but it's explicit.
Yeah. Should be.
Yes, okay, so those are my two recommended edits.
Under excludes, the wording there is a little bit lacking some sophistication there. If trauma and GCS less than 14, especially since nowadays a lot of trauma triage is getting away from a complete GCS score and looking at GCS motor subscores. But I suggest we change the wording to excludes, patients with suspected head injury, comma, and then the rest as is.
Traumatic head injury or just head injury, either way.
That traumatic brain injury is, I think, currently that's a reference to link on to go to that guideline, which is what it's called.
Right. I just am recommending the edit to that first portion of that first incomplete clause on patients with suspected head injury or traumatic head injury.
We want to leave trauma on there because it is mentioning under include acute neurological deficit. So I'm just wondering, like, you know, they broke their arm, they've got deficit in their arm. Do we want to keep it like trauma and head injury, or do we think that's being a little redundant? Just kind of to the point that it says trauma and GCS. So I guess you're saying like trauma or head injury. That's kind of my one thought.
How about traumatic head injury?
Yeah.
So we say, patient with suspected traumatic head injury, and we're gonna take off NGCS from 14.
Yep.
I just would really refer to TBI.
You said inpatients with traumatic head injury, right? Right.
Under EMT bullet point, obtain blood glucose level. Can we stick a hyperlink to the hypoglycemia there?
Treat hypoglycemia as
With the hyperlink?
Yeah, that's on my notes.
Yeah.
This is Dan Spate. Just a couple things. One, traumatic brain injury probably makes sense to be used universally instead of traumatic head injury. And then the other point is, I think the verbiage that's being used in the guidelines is potential as opposed to suspected, because potential basically provides a lower threshold for being concerned about TBI. And since in Arizona, we found, amazingly enough, that literally 50% of the patients who ended up with major traumatic brain injury by anatomic brain scoring, literally 50% of them had an initial GCS of 15. So probably potential traumatic brain injury is probably the best way to state that, and that's consistent with the guidelines.
The patients with potential traumatic brain injury. And then the other edit.
That was it, just a change it from suspected to, oh, sorry, thanks.
Yes, we got it, thank you.
Just as it's keeping with the spirit of the last protocol where we explicitly remind obtaining a 12-lead ECG because it's that important for syncope. The SEMSO, if you refer back to it, makes it a point of really distilling this down, especially to an EMT scope of practice, both to treating hypoglycemia and also acquiring a 12-lead. And so my suggestion is that, again, in the spirit of sort of ironing down to the must not or the critical steps, I propose that those are all explicitly stated under the EMT scope of practice for this page. And for a matter of brevity, maybe we can just say, refer to other pages for wording consistency.
So we're going to add 12 ECG. We've got hypoglycemia and all the other ones.
With treatment, which we talked about, O2 monitoring.
So I have a thing about O2 on mine, but I have a question mark here about whether we use the AHA criteria of less than 94% in association with that.
I think this is going to be one of those where, as long as we're consistent across the document, because there's several of these where EMTs, we have comments about, escalate as appropriate, airway management, refer to airway management, you know what I'm saying? Just kind of, and then we can certainly look at that at the 94% cutoff. Yeah.
Rather than us getting into big AHA debate, because that was give them all 8 hours. I would simply not get into that the last 2 times around, and just essentially leave that up to discretion as a pre-hospital provider. So that would be my recommendation, just to use the same verbiage for those as we have throughout the rest of the document.
The only other thing I had on stroke was, we don't mention in here specifically for like IV or IO placement, but I know we did get requests specifically from our stroke centers to have IVs placed by EMS because it does facilitate them being able to get into the scanner a bit quicker. And it is mentioned in the SEMSO guidelines to establish access. It says in patient service for clinical deterioration, but it may be appropriate to specifically put IV access in here.
Right, with the STR for the EMTs. Yeah, I think it's a good idea, and rather than just doing a finger stick and not doing access. If they can't get access, I'll at least do a finger stick. Yeah.
Those 3 additions, yes, Brian?
So in EMT, we're putting the acquire a 12-lead transmit, right? There's no AMT and EMTI, and there's several areas where we should, even if we don't have anything, we should have the AMT and then the EMTI paramedics below it, even if they're empty, to show that it's still for those people. And then might it also be appropriate under EMTI and paramedics to go ahead if they're getting a 12 lead to do the same thing as we did in the previous one for perform a 12 lead.
Yeah, and it's just propagate that throughout, right, as you all have suggested. And maybe make those things changes everywhere. If it only just has EMT. Yeah.
There are some we will run into space issues where they are simply left off because there's no new treatment algorithms and there's just not enough space. So there might be a couple where it does get left off because there's just not physically outside of base and print too small. Anyway, physically fit those on. This one we certainly have run.
Hey, Dan, I understand, and I would always defer to you regarding traumatic brain injury terminology, but when we say excludes there, if we say traumatic brain injury, refer to traumatic brain injury, it's kind of redundant and not plain English. And, I don't want people overthinking it and say, well, they got a head injury, do they have a traumatic brain injury or not? So I defer to the wisdom of the group on that one, but
that's particularly clunky because those are hyperlinks. So, you know what I'm saying? Those are actually selectable hyperlinks.
no, exactly. So anyway, Dan, I know it's less precise to say potential head injury, but it may convey more than having two traumatic brain injury things in the same line.
So you're saying just kind of wordsmith the first clause?
Yeah, like you had it to begin with, Frank. So. Any thoughts on that, Dan? I don't want to water down head injury or To me, whatever is the clearest way to communicate to them that if the person has a potential traumatic brain injury, what we have seen is that it appears that the brain injury drives outcome, even in multi-system, even in our 2/3 of our Arizona TBIs that had multi-system injury with brain injury. What drives outcome is TBI. So whatever communicates best, a broad umbrella of switching to thinking TBI if the patient has a TBI, because it's very special and there will be some changes with the new guidelines out, et cetera. So whatever communicates that the best to the provider.
I would say that throughout the guideline, we have duplication like that everywhere, because it's just, that's how you do the hyperlink. So I think it's outside of trying to change every single one with that, because it's just the way that we have that reference to make sure people see, okay, I'm thinking about this, now they can click on a hyperlink. I think if we start changing this one, we may run into issues in other parts of the guideline.
I don't feel strongly about it, and I'm all for the hyperlink. It's just whether you want to have the two traumatic brain injury twice there, we got to have the hyperlink. I agree. No problem.
Okay.
I don't feel strongly about it.
And then the only other thing that Ms. Senso did add in their treatment and intervention section was notification of suspected large vessel occlusion stroke. I know we have that in our Southern Arizona guidelines, but we don't currently have it in this guideline. I don't know if it's regularly being performed here or matters as much.
Yeah, here
for us, we do make destination decisions based on it.
We're not making destination decisions here for it, so it's been de-emphasized.
Perfect. It's just
I think that's where you get added it, where it says per local protocol. You know.
Yeah.
And then on the pre-hospital stroke scale page, which is in the appendix section, we recommend adding a stroke screening scale.
To the heading of the top table.
Yes, having this would be FAST/Cincinnati stroke screening scale. And then for VAN, it should be VAN for large vessel occlusion screening tool. So we have acute stroke screening tool, but it's not really an acute stroke screening tool. It's screening tool for large vessel occlusion. Sorry, I said it out of order.
Just to go back to Amber's point for a second, if we don't reference large vessel occlusion anywhere in this document, why do we have it as a reference?
The ban table was a stakeholder request.
Right. I mean, I would support Amber's. I mean, this is important to recognize large vessel occlusion strokes. They have a different time window, and that you can manage them differently than other patients. So we use the VAN score in Southern Arizona. We use large vessel occlusion to transport to our facilities capable of clot retrieval.
Well, we send them to a different scanner too when they come in. If we think they've got a large vessel, we send them to a different scanner that's capable of doing different scans.
That's a hospital staff-based decision, right?
It is, but we base it off of the fact that EMS lets us know that they have an LVO.
So
we know.
So time is tissue.
Yeah, I think we don't. These are for the whole state, not for Phoenix. So if our rural providers who use these don't have access to this, that's kind of
maybe you can put a bullet below that transport one that says something like, consider large vessel occlusion with the hyperlink to this for alternative transport decisions or something like that.
The census says in there, it just says, the way they phrase it at least says, Really, I mean, it's not a bad idea though, because I mean, that's a direction we're looking anyway, get them to start thinking about it. So,
right.
you know, because when we finally do get there, at some point, there very well may be decision-making, you know, capabilities in the valley. But at least they're already including it in part of it and they're thinking about it. Whether it actually changes destination here right now, it may at some point, and it's an important to know, and even to transmit wherever they're going to whichever stroke center that they think the band is positive.
When we consider resource use, we'd rather not have to have, inter-facility transport if we can have a primary transport. And I know that's not our goal here. I know that's not what we're saying. Is large vessel occlusion, are the paramedics going to understand that? Are the medics going to understand that? Or should we use simpler language?
We do it in Southern Arizona. They actually say it to the hospital and
Okay,
the
great.
NI in the radio room goes,
Perfect.
oh, what?
Let's finish this part and then we can go back to the stroke one, the full stroke page. So we have on here, for some reason, there's a time that should be removed as well. I recommend removing that time frame that doesn't apply for band.
Yeah.
It's not part of the band screening. Yeah. That 4-hour component.
Yeah, I think the idea was that if you're within the regular treatment window, then it matters less that where you go. And so if you are greater than 4 hours, then your large vessel occlusion matters more in terms of making a destination decision. But yeah, that makes sense. But I'm trying to start there.
All right, so to this, we added, under Cincinnati stroke screening scale on VAN, just clarified screening tool for large vessel occlusion. Everyone good with that?
So, okay, so, sorry, Shelley, you're missing the change on the title of the top of the table. Just add the word screening between stroke and stroke themselves.
Here? Oh, here?
Right there, yeah. Stroke and then screening.
So these are, a lot of this we're not gonna be able to do real-time edits on here, so I have notes of the changes as well. Yes,
I believe B fast is considered more accurate than just simply the fast, so the balance and I is included. I don't know if that's something we use up in the northern area, but I don't know if that's something that other folks are using, but that's what our neurologists wanted to be used.
But the literature on that B part of it is not actually very good either. So
Yeah, fair enough.
From a state perspective, can you comment on if that would be widely applicable?
we don't, in the central region, I don't think it's used, so it could become, it may be difficult if we start putting that in there as the assumption, we can change the whole state. Okay, that's good discussion though.
and then
Oh, go ahead. And then back to the stroke one, the transport. Amber, did you have the verbiage of the
Oh,
LVO?
yeah, they just say when you, early hospital notification per local stroke plan, that should include suspected LVO or large vessel occlusion stroke. So I don't know if we say something about notification. Right now, we have notified receiving facility as soon as possible, and we could say
Early notification of receiving facility.
Per local stroke plan.
yeah, we say that in there.
For the potential of large vessel
As soon as
occlusion.
possible, including any suspected large vessel occlusion stroke.
Tested LVO, and then that would be a hyperlink.
To the LVO scale.
Okay.
To echo Dan's terminology, because if you say I didn't suspect it, but a potential would be a broader terminology. Would that be comfortable? Potential large vessel occlusion rather than suspected?
Sure, that's fine.
Including potential.
Yeah, and I'd suggest that throughout the document instead of suspected potential. Because we don't know what we don't know, we don't think about what we don't think about. Just a search and substitute.
should that link be blue, the screen?
Yeah, that
Oh, she'll make it blue, yeah.
She'll do all that later, yeah.
Offline.
I didn't hear that.
Making it cyanotic.
Any hyperlink formatting stuff that we will all do offline. All right, any further discussion on the stroke / TIA or pre-hospital stroke screening scale? Next is altered mental status. This one we had removed in the long term section because we have the referral to the opioid overdose. We also added in a link to poisoning/overdose for generalized, for general non-opioid overdose, so that was added in. And then we have here this pretty large fluid bolus. I'm not sure why we have this massive fluid bolus for an altered mental status. It seems no clue.
Yeah. It's just refer to shock as needed.
So just highlighted that.
Yeah, I saw that as well. I just put in my notes if it's desired to even keep this, because I don't think this is fluid boluses do not show up in the essential guideline for altered mental status. But if you desire to keep it, I would just refer to shock.
Yeah, you could say it's affected, or if in shock, refer to shock guidelines.
We already have that.
Do we have it covered with universal care?
Yeah.
To treat shock, and if we don't have
It doesn't
shock,
have to be amended.
okay.
Shock guidelines. Yeah, delete.
Yeah, keep going, get rid of them.
I would delete them.
And the AEMT one too?
Yeah, delete those more, and then maybe put in the IV and maintenance fluid as two up to the EMT, and then that would carry kind of through for everybody.
Leave that highlighted, and then also under AEMT as well.
Okay, so we're deleting any reference to the ID even up in the EMT, right? This is gonna go to the universal?
Yeah.
Okay.
Yeah.
Or shock.
Right.
Yes.
Just a question, and again, here I just suggest instead of suspected, potential overdose or potential non-opioid overdose. And I'm gonna speak against, my thoughts earlier, but if suspected opioid overdose, refer to opioid poisoning. We've got those two sorted out. Should we combine them into one, or?
I need to look and see what the
Yeah.
title is of that one.
Yeah.
I think we tried to match the title with.
Yeah. If we wanna keep them separate, I'm okay with that, but then we ought to say the potential opioid overdose, refer to opioid poisoning overdose, and the potential non-opioid overdose, refer to poisoning overdose. You could either combine them or separate them. I defer the wisdom of the group on that.
Any thoughts from the group? Should we combine the is suspected opioid overdose or non-opioid overdose and then refer to that in one line, or just keep them two separate lines? Well, they're two separate guidelines, right?
Yeah, I think they have to be two separate.
Yeah.
Okay, I'm fine with that, and then I just say a potential opioid overdose in the first clause of that one.
And then, if we're gonna make kind of a general change from suspected to potential, maybe you could get a motion on the floor for the whole document, but not one verbiage change.
So moved. Second.
Okay.
I'm there for it.
All right, we will do a PMD vote. We're gonna vote on that verbiage from suspected to potential. So anyone opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
Okay, and then
Aye.
any opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
All right, we will do a document word search for that. That way we don't have to cover it each time. Thank you. All right, anything further on altered mental status before we move on to the next one? Yes.
Just one thing, and I got a question mark, because this might be covered appropriately under universal care, but under paramedic, obtained a 12-lead EKG. Or not? Can you just leave it in universal care? Okay. That's fine.
All right, one more. The last two bullets are also included in the universal care guidelines, so I don't know if we need those last two bullets either.
Inventories of work.
Yep.
This, from my cognitive perspective and sort of my guide, guiding principles for these documents, this raises to the level of verbiage that's helpful to have right in front of me on this page as a critical action step. The only comment I would make is that, here we have a bullet where we're referring to a pediatric specific comment, and yet we're not splitting that to the right side of the page. And this happens a couple times in the document.
And should those move up above like glucose? Just in terms of
Order of priority.
order of importance?
That's a good point.
So I hear two different thoughts on the table. One is to delete those, the other is to keep them and move it up. So I need general consensus on that.
I agree with keeping an ABC approach for that and keeping it as a critical thinking step. I'm fine with that.
Sure. I'm okay with that too.
We're going to move maintain ventilator support and BBM line above the blood glucose and underneath universal care. And then split for the pediatric.
Do we really, is that really important since we're saying do it in the least invasive way possible anyway?
That was my question.
So I mean, just to play devil's advocate, we don't mention airway on any other guideline. So are we going to do it on everyone, or are we going to do it on none? I think to be consistent, we should probably make that decision. Because on everyone, it's said, right? If you're having a seizure, you should maintain airway.
And that's under universal care.
Like seizures,
So I'm-
airway support.
I'm okay with it.
Because I certainly don't want to change every other one to match that.
We need to have a little grace and latitude with this. There are pages where there's the physical room. The goal is to try to make the cognitive stress as least as possible. And so I'm not sure that this is one where we have to live or die by, we must do it all or we must never do it.
Can we standardize it and use the same phrasing that we use in the next page in seizures and just say provide airway support as needed?
I'm happy to keep it. I was wondering why here and not others. So we have a airway management algorithm. We could refer to that.
Can it initiate universal care and airway management algorithm as needed or something? You could combine the first bullet.
Care and
Refer to airway management.
refer to airway management as indicated.
And then you could propagate that throughout the whole document.
There's definitely going to be pages where there's not room.
Yeah, and that way we included it and saved things.
So we're going to take off, so then just to confirm, we're going to strike the maintain ventilatory support of BBM because we're going to cover that as refer airway management.
Yeah. Initiate universal care and airway management as needed. And airway management includes oxygenation and ventilation, not just airway management, right?
Yes.
Yeah. Okay.
Great innovation.
Yeah.
I want to correct them. Come on, man.
Okay, we're going to go on to teachers next. A couple small items that I saw kind of lower down under the dosing of magnesium. If you want to match the OB guidelines, says over 5 to 10 minutes for the magnesium. That matches in the sense so Lancia's terminology. So I just recommended that we do 5 to 10 minutes just for consistency. And then one other kind of safety thing to consider adding in a bullet at the end is, I'll read it first and see what the group saying. Patients requiring pharmacologic management for agitation and post-ictal state refer to agitation or violent patient/behavioral emergency. Ketamine is not indicated for post-ictal patients. I put this in there as a consideration because there's been patients who have been post-ictal, very agitated, and EMS is forgetting the seizure component and going to just the agitation and using ketamine for that agitation, which is probably not the best option in that clinical setting. So I wanted to see what the group thought about including that line.
I like that line. Good reminder. Yeah, I'm good with that.
States that patients requiring pharmacologic management for agitation in the post-ictal state. comma, refer to agitated or violent patient / behavioral emergency. So that would be the hyperlink to that guideline, and then period, ketamine is not indicated for post-psycho patients.
For post-signal patients with agitation.
I would just leave it simple.
Sounds good.
I don't want to give any of them.
Yep.
There's another, a couple other so matching comments that I'll make. Under EMTI paramedic, second to last bullet comment is it in third trimester. And the SEMSO dichotomizes that to greater than 20 weeks.
Good catch. It's greater than 20 weeks.
Yeah.
Gail, I wanted to understand the change. So on OB, it says, seizure management, 6 grams, magnesium sulfate over 5 to 10 minutes. Did you, I know you wanted to change the time interval to 5 to 10 minutes here. Did you also say 6 grams? Or do you want to leave it 4 grams?
It says, so the SEMSO breaks it down into seizure prophylaxis versus seizure management.
And that's the way it is in the OB. But here for seizure management, should we make it 6 grams then?
I think we had made it 4 because the required minimum was 4, right? Isn't that why we made that 4 last time?
Yeah, we don't have that much in the drug box.
Because we normally wouldn't carry 6 in the drug box.
And then if they want to, and then if they refer to the OB guideline and want to give an extra 2 and you have to have it, it's in the, it should be in the OB guidelines, I believe.
Yeah, I mean, we can make them consistent for sure. I agree with the consistency part, but the reason we made it 4 was because the drug box minimum.
But I would make them consistent, or I would say give the 4 grams over 5 minutes. If they're seasoned, there's no sure way to kill a brain than have it maximally metabolically active. So I wouldn't.
Max minimum is 5 grams.
That's 5.
Yeah.
That's the vial that it comes in.
Yeah.
Why don't we just say, to make them consistent on both pages then, 6 grams over 5 to 10 minutes, because this is a seizure management protocol and the OB seizure management is 6 grams over 5 to 10 minutes.
The minimum drug dose is like 5.
5 grams.
Okay, you guys want to change it to 5 to 10?
No, I mean, it's only 5, the minimum drug is 5 grams. Not
That's
a
all
thing.
they'll have in their
So they won't necessarily have that 6 grams.
Okay, should
Yeah.
we just change it to 5 grams, period?
Five is fine.
Yeah.
Because your folks are carrying 5 then?
I'm sure they are.
Okay,
Whatever the vial is, sure.
okay, so we'll change them all to 5 grams
We've
over.
got 10, but a lot of people aren't gonna do that.
Yeah.
Yeah.
Ours is for 5, and then we've got 5 left over for a drip if we want to establish that. But a lot of people aren't gonna do that. They're just gonna have the 5 grams.
I heard, we're gonna change it to 5 grams over 5 to 10 minutes. Okay. Anything further on the seizure one before we move on?
Yeah, one other matching the SEMSO. The sex pain bullet I called attention to last time. If unclear etiology, you may administer benzos simultaneously, and the SEMSO wording is benzodiazepines if not responsive to magnesium.
Yeah, we discussed this last
We
time.
just have to do the blank slide.
Yeah, because the response time to get there, they're already, if they're seizing upon EMS arrival, they've already been seizing.
In the AEMT, I think that if blood glucose less than 60 on both of those sides for the pediatric side, it already said check blood glucose and refer to hypoglycemia. So
Yeah,
you
I know.
get rid of those.
Merge, got it, thank you. Anything further? Okay. Next, hypoglycemia, we made some changes, and then after making the changes at PMDs in preparation for MBC, recognized that we are going to give basically pediatric patients way more dextrose than adult patients with the new verbiage. So I'm wondering if we should just go back to how we had it worded initially, because we spent a ton of time and created worse verbiage. We all spent a lot of time debating this, and the end product was resulted in inconsistencies. So
So this is old here?
I Is that the old one? I can't see, I can't see this well.
Yeah.
Is that the old, the current version?
Yeah, that's different than the current version. This one is different.
Okay. So someone can read that out loud, maybe, so for those of us who can't see.
If hypoglycemia, parentheses, glucose less than 60, and parentheses administered, dextrose 25 grams IVIO, and then first bullet D10, max dose 250 ml, titrate to effect, or next bullet D50, 50 ml, or next bullet glucagon 1 milligram IM, reassess vital signs, mental status, state glucose. And then on the ped side is if hypoglycemia less than 60, administered dextrose 0.5 grams per kilo, or D10 5 ml per kilo, or glucagon 1 milligram if they're over 20, and half a milligram if they are less than 20 kilos. Yeah. Nice, did really well.
So just wanted to,
So you're proposing going back to?
I would propose potentially going back to this, because we spent a lot of time debating this and rewording it. Between PMB and MBT, recognize that we had kids getting 5 times the dose of adults. So. And keeping the current TTT dextrose terminology.
I think this works.
Yeah.
Yeah.
I don't want to have to debate it. What dose of D10 should they give? It says titrate to effect, but what's the first dose?
So typically the way that I've taught it in for adults is you just run it in, and when they wake up, you can turn it off. So that's kind of the titrate to effect. So they get 50 ml in and they wake up an hour alert morning, you can turn it off. But if they are still older and you have to do the whole 250, then do the whole 250.
Yeah, we do a 1 milliliter per kilogram bolus. This is where we start. So it gives them a starting point and prevents the hyperglycemia and the associated rebound hypoglycemia. So that was the logic, I think, in doing that 1 mil per kilogram. But I'm not set on this by any structure. So.
I think if we had the team 5 ml per kilo, so then the question was, do we have adults getting 1 ml per kilo, and peds getting 5 ml per kilo? I think Dr. Augustine, I think I saw you on the line. So that was just the discrepancy between the two that results with that. I mean, we could certainly still include the 1 ml per kilo, but just recognizing that this doses are different. Yes.
The only thing maybe we should add then is if we want to do for the pediatric side, the max, we've all seen kiddos bigger than 50 kilograms. So just to kind of, to that same point, just keeping it consistent.
Well, like max dose 250. Because then that actually makes it, because if you do the D10 here, you're only going to give a maximum of, was it 2.5 per kilo? Versus the kid, who's, according to this, you're still giving 5 per kilo. So even in our old ones, there was a discrepancy.
We still need to get the max.
Right, because your max was 2.5 for an adult, and the kid was 5.
For the group. Brian, you know?
Mine's just a typo. We'll finish up that.
Could we continue the box, that if continued altered mental status and hypoglycemia, could we stretch that box across the piece as well?
Or is that across yet?
Yeah, because, I mean, really, I think your starting dose is important. If they can repeat it as necessary, you know what I mean? Like, and the starting dose is less of an issue. They just repeat it until they're awake.
Yes, okay, so we will run into that box part across. All right, I've heard 2 separate thoughts on the dextrose dosing. What is the overall preference of the group?
Do we want to add in the max of 250 ml, so it's consistent on both sides, or
Yes.
does anybody care?
Yep, I got that for the.
Okay.
Here's the pediatric, after the D10. 5 ml per kilo, common max dose.
Okay.
And then preferred, we should have preferred, so
You have a reference for that 5 milliliters per kilogram. I don't know where that dose comes from. It's not familiar.
I don't know why it's not the same as the adult.
Yeah, for our agencies, we do a milliliter per kilogram for everybody, right?
And then
math
repeat as needed.
Yeah.
Yeah, I don't remember where it came
So for,
And then we're gonna let the
E10,
kids.
the Femso actually has 2 to 4 ml per kilo. That's greater than 8, and then 5 to 10 ml for, so they have 5 to 10, and then they have 2 ml per kilo for newborn, so
Kind of all over the place.
it is definitely all over the place, which means it's probably not grade 5. And the 2 to 4 is actually for 25. Oh, yeah.
So is there any other specific reason to really have this at 5? Just do one, because you're gonna repeat it, and keep repeating it, right?
Yeah, so our logic in the southern Arizona region was doing math in the middle of the night is hard. Weight-based dosing is hard. Let's make this simple. 1 milliliter per kilogram and repeat it until they're weighted to a max of 250 for everybody, right? Obviously, you could do a max for a kid of different. That was our logic, but I'm very, very flexible. I don't really.
Have you had any problems with like the really little kids? Like, I'm thinking like less than a year old or anything like that? Okay.
And I think the biggest thing that I saw the discrepancy was just that we've got 5 ml per kilo for kids and 1 ml per kilo for adults, so it's a big difference, so.
Yeah, no, but totally understand the disconnection there, so I'm like I said, I'm good with whatever.
So I hear another proposal, which is 1 ml per kilo, max dose 250 for both adults and kids. That's another proposal on the table.
The Semso, all of them were a minimum of 2?
They do all the different ones.
Yeah.
Well, they do the D25 and the D10
Oh,
based on
okay.
ages and everything, I
Yeah.
think, so.
They also list a tube of cake icing in there.
What?
A tube of cake icing is also listed as acceptable forms of glucose.
They're not wrong.
Everybody, every kid's asking for it.
Yeah. As long as they can meet the state requirements.
So I would make a proposal that we change, the D10 to 1 ml per kilo for all age groups. We will still need the split bar because we've got the different glucagon dosing for the under age group. And then we'll still have the max 250. Change the number next to the word text. Pardon? Change the number on now. Or like, I guess, the 0.5 grams per kilogram. Do we need that, or do we want to just take that off? We're doing ml per kilo. I think it makes a few people that have the grams, so let's just take that off.
Do we need to add repeat as necessary under the D10?
So that's going to be the bottom part. We're going to move that across. That will be a possibility now. All right, any further discussion? Yes, Brian?
Is this gonna be a single motion, or we're gonna pass the whole thing later on? 'Cause I'll fix it. So up on the second box under EMT of hypoglycemia line, it says only alert level of conscious, and I think that's supposed to be altered on both sides.
Good catch.
No, this is saying they can only get PO if they're alert.
If they're awake enough to take the
Because you wouldn't want to give it if they're altered.
Oh, I got you. Oh, I got you. Okay, I get it.
All right, hyperglycemia. All right, so, under the AEMT section, the only recommended change is just under pediatrics, that we have not to exceed adult dose, added and highlighted there, just to make sure we're not giving more fluid than we're giving an adult. That's the only recommended change on that one.
I had, let's see, under the paramedic line, there's another time that we include this bullet about maintaining ventilatory support in the least invasive way possible, and then BVM is reasonable for pediatric patients.
So we'll just do initiate universal care and refer to airway management indicated at the top for EMT. Okay. Go ahead and link under EMT. Okay, let's take that off.
Is there anything different on these then? Can we combine everything here? Because everything else is about 12 weeks and hyperkalemia. Oh, those are
Yeah,
just, okay.
it's different. Yes, Ryan?
So I might have one question here down in, the drug treatment is about sodium bicarb. And maybe this got handled somewhere else because it is in the, native stem cell model for sodium bicarb. I think it was 1 to 2 MEQs per kg, but it might just be 1 MEQ per kg. I didn't write that down, but I did go look it up, and it is in the stem cell model too.
We had a long conversation about this the last time we went over these. There's no evidence to suggest sodium bicarb helps in the treatment of hyperkalemia. It's pure myth that's perpetuated in documents like that. Sorry.
So you're having feelings.
So this one under AMT, we're saying that not to exceed dosing. We said give 10 mL per kg IV bolus. Do we want to say it's like may repeat? So, because it's like,
I'm sorry, so they
it says 10 mL per kilogram. Do we want to say may repeat again? Because like on for the adult side, we say 20 mL per kg. I imagine in kiddos, after getting 10 mL per kg, if they're still showing signs of shock, they may need a second 10 mL per kg bolus.
So the pediatric community is really, has shown that there's been poor outcomes if kids get too much fluid up
Right.
with DKA, and so recommendations for the hospitals not to do too much fluid.
Okay, that's how they were saying 20 to 30 was what they're saying, don't go above that. So that's why we're doing 10 mL per kg, and then they're still showing signs of shock, and they repeat, but.
Because they can always patch for additional orders, but the concern is not having like a standard starting with that high fluid.
Okay.
Just to echo Franco's, we're going to change pre-hospital stroke scale to screening scale throughout.
Yes.
And then the 2 grams of calcium gluconate is not equivalent to the 1 gram of chloride, as we all know. It's a 3-to-1 ratio. So if we want it to be an equivalent, was it a dosage?
I think, because it has a full vial, and that's the issue.
They only have 2 vials?
Yeah, I think so, but we can check the box minimum requirement.
It's 2 grams per calcium gluconate.
Okay, so it's, so rather than equivalent dosing, it's just based on what they got. Okay, that's fine. I can live with that.
And then on the AMT, you have the transport to closest appropriate. That should probably actually go up under the EMT.
Good call.
And then, and I'm kind of ambivalent either way, but since they're giving fluids, is that technically under potentially an STR for EMT, or just leave it under AMT?
Well, that should get moved because it's a part of.
That's kind of what I'm thinking, like
to the EMT for
basically moving everything that's AEMT under EMT, but then having an STR for the fluids part of it.
There's also a dosing discrepancy between the adult calcium gluconate dose of 2 grams or 2,000 milligrams and the pediatric dose of 100 mg per kg. 2 grams, 2,000, if we assume an adult's a 50 kilo kid, we come out to 40 mg per kg. So that seems like a high dose to me. I don't know if that's what's in the NSMSO guidelines or. Check. Just on general principles, that was fine.
100 per kg, 1 ml per kg.
That's interesting. Yeah, it's definitely not equivalent dose. Thanks for checking.
I have just kind of a general format question. When the identical verbiage is mirrored on the left and the right side for peds and adults, are we merging them across the board? Because we have obtained 12 lead for peak T waves on both sides there. Do we need to mirror that or just stretch it? It occurs multiple times in the next document and the following.
First question, which was so under the sunset, it says for pediatrics, 50 mg per kg, max 2 grams. But the sunset has for that.
Yeah, I have 100 here.
Calcium gluconate.
Yeah.
We have 100.
I'm looking under the dialysis known hyperkalemic patient. Is it in a different spot somewhere else? Is it a different dose?
I'm under, I just searched for hyperkalemia. So it looks like it might be different. So I just looked at.
You have a cardiac one?
That would be a much higher yield, and a higher dose would be warranted in somebody who's dialysis patient who's Mr. Dialysis.
Yeah, I mean, this is for the hyperkalemic patient, not for cardiac.
What page is that
Is
on?
the recommendation
Amber,
for people?
Amber, what page are you on?
119.
So the recommendation to go with 50 mg per kg or 40 at lower dose?
Well, I mean, this is for hyperkalemia, right? This is not for cardiac arrest. So is the cardiac arrest one different dosing?
I think at some point we try to make this consistent anytime we're treating hyperkalemia throughout.
Exactly. And here we have, in our cardiac arrest, we also have 100 mg per kg. So we have it consistent in ours, but you're saying the SEMSO does not?
It looks like there's not, no.
Okay. Oh yeah, pediatric, 50 mg per kg, and that's in the crush injury. That's interesting. We have 60 mg per kg in the calcium channel blocker poisoning. And we have 50. No, that's by card.
So in the chat from Dr. Woolridge, I endorse max dose in the presence of EKG changes as stated in the algorithm. So keep it as is at the 100 mg per kg. Okay.
With EKG change.
Okay. This is based for pre-hospital provider. They have no lab, so this is EKG findings is what's the base in that treatment option.
Yeah.
Is the group good with that? Is our pediatric expert on the line?
I'll defer to Dale. And again, I was just ballparking at it, looked high. And it looks like the preferences suggest that too.
What, 100?
Oh, no, I mean, it's varied between 50 and 100, so.
Okay.
All right, we're gonna go.
Happy to defer to Dale.
Yeah, I'd optimize the dosing, particularly in the presence of ECG changes. I mean, the dosing range is 50 to 100. But if you have EKG changes, I would optimize it.
Great.
Thank you. Yes, Ryan?
On pediatric under paramedic, maintain ventilatory support and least
We're scratching
with,
that.
we scratched that
Already
already.
on, yes.
Then in the past, and maybe this isn't going to work out because these things I think are a little more complicated than when we first started in this format about the taking 12 lead thing. Initially, when we started these, there were going to be things on this side that would also pass over to this side that were appropriate, and we were only writing pediatric specific items rather than trying to stretch that box out across. So I don't know, just from a formatting issue.
I think it's merged away from that because it was more confusing to some providers. We'll make sure it's most consistent, but I think we've kind of, the way this has evolved, I think we have less of those issues where everything, I think people are reading it as it's on the left, it's adults, it's on the right, it's peds. So stretching it across that applies for both is how I think people are starting to. So I'm going to kind of push us through on some of this because we are about an hour behind schedule already, but we did start a few minutes late. So I'm going to go to anaphylaxis next unless someone sees something else pressing on that. So for anaphylaxis, a couple things that are on here I wanted to point out. So the epinephrine dose, if you could scroll down a little bit under EMT section, I put in red, sorry, go up. I put in red what I would recommend the dose be. Instead of the arbitrary less than 25 or greater than 25 kilo child. This was a recommendation from the pediatric specialist that said you will underdose some kids in anaphylaxis if you use this breakdown, this breakpoint. And so just to do the weight-based dosing. So that is the recommendation that is in red above for the verbiage. So Peds, Epi, IM, what Shelley is highlighting there.
The yellow is what it currently says.
Correct.
And it seems like that really came down because of pediatric, the auto injectors, maybe.
And so one of the questions that then comes up is that we do have, so we have the auto injector as an STR for EMTs, but they can also draw up. And so we have here prepared kits for epinephrine. My understanding from the few entities that are using this for anaphylaxis for EMT SDR that they are not using an auto injector. So it's
right. I think that this just proceeded down from that previously, and it's not appropriate anymore. So,
but we use the standard auto injector dose guidelines for the prepared kits and not making them calculate.
And what we have on ours is we actually had them by syringes that you can either pull it up to 0.15 or 0.3. There's only two increments. There's no other increments.
I think I went and looked in the training though the other day, and the training has the 0.01 milligrams per kg in the training.
On the state training?
In the state training on it. I think I went and looked that up. I did, and I have a note per training. So that was my note for the training guidelines.
So maybe what we would do then is, so hearing that for the EMT, this might be the appropriate verbiage for the EMT section, but maybe what we should do is add to the AMT and below, add a new bullet for those two sections with the right dosing. Yeah. You know, it's the Epi 1 ml, 0.01 milligram per kilogram, IM, max dose 0.3.
But if you do that, then you're not picking up the 0.01, or when we go back and look at the training and, because it's not going to match the training now.
The training is separate because agencies don't have to use that. It's totally optional. They use that training. So I think we should focus on what we want our guidelines to look at as the primary focus.
Yeah.
May I make a suggestion? Because this page is tight in terms of real estate, I suggest that we consider the removal of the steroids because it's not consistent with the SENSO, to make it, at least make room for any other edits that you're about to make in the middle of the page.
There will be some room when that's merged, it looks like.
Could we just merge the adult and peds for the auto injector? Or that box that we have separated under EMT for the, it really is the same for adult and peds.
So the dosing is different though for we've got P specific doses there, the highlight in yellow, but I think but it would apply to both. You know what I mean? And if you want to save space, because an adult ought to be greater than 25 kilos, so you're going to reach that same dose. The other part is at the bottom, those are identical, there's nothing different. So actually that's an easier way to probably just merge those two, because that's the bottom section. The entire paramedic section is a duplicate, so that can be merged. So we will merge that part, and then we're going to add in under the AEMT section, we will add epinephrine, 1 milligram per ml, 0.3 milligram IM. And then we will do the pediatric dose on the right.
Another question this might be one for Dale, but on the nebulized epinephrine, would it not be appropriate just to make the P's 5 milligrams, like instead of having the range?
I mean, I'm just trying to familiarize myself with the algorithm, but we tend to not do 5 milligram nebs under 20 kilos. How that would extrapolate. I would. Oh, I'm sorry. I was thinking albuterol there.
No, of epinephrine. I thought we had before had a really low dose, and Dale had said that they generally use more, but I don't remember now.
We just talked about it. I mean, for, we talked about the P stuff too. First driver and. I think we debated this dosing quite a bit last time too. So,
Hey, Dale, this is Dan Spate. Don't they tend to self-dose because their minute ventilation is basically size associated?
Yeah.
So don't they tend to self-dose? So does that make it we could keep it simple? Because they obviously at that age they're taking in much smaller dose just by virtue of their tidal volume.
Oh yeah, absolutely. Anecdotally, that is absolutely true. I'm not really necessarily sure that the literature essentially supports a broader dose based on that premise, but you're 100% right. I think it creates it allows some degree of maximizing the dose that way, but I'm struggling with trying to remember any literature to support that.
The SIMSO says 5 for P's, 5 milligrams at nebulized epinephrine for bronchiolitis and P.
Without an age.
Yeah.
Or mass or size.
It says nebulized epinephrine should be administered to children in severe respiratory distress and bronchiolitis in pre-hospital setting.
So recommendation is just to switch the 2 to 5 milligrams, which should just be 5 ml.
Which means we can merge with the adult.
Right. Yep. Just to merge that one across the pond.
Everyone good with that?
Yep.
Okay. All right, any further discussion on that one?
Yeah, so on that, so are we now merging the AEMT sections?
We won't be able to merge all of it, no, we still have different doses.
So then the wait a minute, we do? We just said it.
No, not the, yeah, we have to do the IM dosing because we.
Oh, gotcha, okay.
That.
So then on the left-hand side, we have 2 separate lines, both say the same dose for epinephrine on the adult side. One is for respiratory distress and wheezing, the other is for stridor. Can we just say for severe respiratory distress and combine those 2 bullets?
Yes.
And then finally, again, I'll bring back up to the group that considerations of beating steroids to be consistent with the SIMSO.
What was the last part? I'm sorry about the steroids?
The leading the steroid section, the SIMSO is pretty clear on its no scientific support for pre-hospital use in anaphylaxis specifically, in the rescuing of the anaphylactic patient.
Yeah, we use it in delivery. My only question was going to be, where's that max dose 16 coming from? Is that just something I missed?
Oh, yes, people are in now.
I'm just trying to look it up for this.
Yeah, I always gave the 10 milligram vial. Yeah,
right.
Yeah, I would give 10, but all of our residents now are using 16 because they read something somewhere. So I feel like that's where I initially thought. I was like, why did you give that patient 60 milligrams a day? I'm like, that's what you're supposed to do. I was like, oh.
I used to be that, you know.
Yeah.
So we're doing away with it,
All right, so we do need just vote on this. So the question would be, number 1, do we include the steroids or not? It is not in the SIMSO guidelines. So we do need to have, I think, 1 vote for removal, 1 vote for keeping. So I need to get a feel for the rest of the groups. We know which.
Do we have to consider long transports or not?
Well, I mean, I think what's clear in the body of the SIMSO work, which is again our guiding principle,
right.
our constitutional work, is that, you know, here, this particular page is about rescuing the anaphylactic patients. This is time-sensitive illness and injury with a high mortality. And so to me, this is like medics getting distracted giving Narcan for the patient in cardiac arrest. If this doesn't have a scientific basis, if it's not the focus of that first rescue maneuver, why have it on there?
I think it's because we do have agencies with long transport times who give it prior to.
But this body of work is our sort of state, sort of base layer, right?
Sure, it's quite a base layer, but you have to consider things that are specific to
you guys
Arizona,
get
like
long transports,
rural areas
too.
with hour-long transports. I mean, I think those patients should definitely appropriately get steroids if they were rescued from anaphylaxis and you have an hour drive, they should get steroids.
And phrasing right now says if available, right, consider, which I think is appropriate in the sense to your point to focusing the other stuff. Now you saved their life. Sweet. Now if available, consider the following.
Well, and it really shouldn't be if available because you have to have one of those drugs in the drug box. It's not
Is it appropriate?
as necessary, as necessary.
So, or we can just say consider.
There you go.
And it's clear that we're giving epi first, right?
Yeah.
I mean, that's the main point that you're making, Franco, and I think that's important, but.
All right, any further discussion on that before we move on to shock?
Yeah, I was just gonna weigh in if I could. I mean, outcome data supports early dosing of steroids. I totally agree with the comment that it's not gonna be the rescue component, but if there's time and opportunity, if the verbiage supports that, and here it says if available, consider, I think that's a reasonable recommendation to keep, because I think it improves outcome.
So we're gonna just start with consider. So you good with that?
Yeah, right.
All right, next on to shock.
Look for two of us here.
So shock is added in some push dose epi, which we did not have in the previous version. To give a little bit of frame of reference, the Central Region has used push dose epi in the guidelines now for about 3 years. And have had pretty good success with that. I think we've seen really agencies go from no vasopressor use for hypotensive patients not responsive to fluids to now routinely getting patients getting fluids and then getting push dose epi as indicated. So I just wanted to, we do have kind of instructions on how to mix this in here. So that is the yellow highlight I wanted to point out to the group. The other discussion piece that we recognize between TMD and MDC is that patient assist was removed from scope of practice at the national level. There is still hydrocortisone, which is not in the pre-hospital drug box, so this would be a patient's own medication, and we have listed assist with patient's own hydrocortisone. So the question is, since that is no longer in the scope of practice, do we just scratch that line? We still do have the option to give steroids with the methylprednisolone. I know that's not the ideal steroid of choice for this clinical entity, but there is still the option to give it.
Do they get in trouble pushing a drug that's not within their scope of practice?
It's supposed to be assist the patient.
Right, but I mean, they could be assisting the patient with whatever, you know, that's what.
So, I mean,
So
technically, if there was an adverse outcome, they're operating outside of scope of practice and also administering medication that's not in their drug box.
Right, and that's kind of where I was getting at.
Twofold issue, yes.
So we do have, but right now on the drug box list, we have hydrocortisone with a asterisk on it, which goes up and authorized to assist patient in self-administration, no, only on hydrocortisone.
And that was because when we updated scope of practice, we removed patient assist from scope of practice.
Right.
So it's one of those things that I think as we kind of get each document cleaned up, just to point out that was removed from national scope of practice and removed from state scope of practice. So patient assist is no longer in scope of practice in the state.
So my thought is if they could potentially get in trouble for giving it if there is ever a bad outcome, you know, would then now the state and the rest of us be liable because we said that they're allowed to give it? Because it's a contradiction between what's in scope and what we're saying they're authorized to do.
How does the group feel about this, about decoupling the concept of assisting with patient's own medication versus administered hydrocortisone if it's available? So if the patient has ownership over the drug, but the paramedic is trained on the drug and trained on its administration, if the paramedic giving it on their own accord, not
Right, then we have to add it to the drug box list.
Well,
Or add it to the.
Is it not on?
As an option.
Not on the.
Yeah,
It's on as assisting the patient only. I think the other problem with that is, you know, we've got other rules that say we only have drugs that are obtained from a pharmacy, and I don't know that implies that the patient who has their own cortisone fits into that, because we don't know anything about it.
And then Dale, did I see your hand up there?
Yeah, and forgive me for not knowing the broader protocol, but do we have another algorithm that discusses a refractive shock and a role for dexamethasone? Because I'm a little confused as, you know, adrenal insufficiency, they just need glucocorticoid replacement. Why aren't we just giving them dexamethasone and avoiding this issue of stocking or non-stocking and whether or not we have the capacity to give hydrocortisone? Because they just really need glucocorticoid replacement, and this is just essentially the same as or refractive shock. Do we have another algorithm that uses DEX in that role?
We do not, but that is a great point, and Frank has his hand up, so maybe he can tack on
Sure.
that as well.
If you look at the relative mineralocorticoid to glucocorticoid potency for hydrocortisone, it's 1-to-1. So we all think of it as a pure glucocorticoid, but it's not. And that's why we're giving it, obviously, in shock, because it has that equipotent, or equipose with mineralocorticoid. When you look at methylprednisolone, it's got 5 times the glucocorticoid potency versus hydrocortisone, and it's got half the mineralocorticoid. If you give 2 mg per kg, you're giving way more than you would with 100 milligrams of hydrocortisone IM. So I think for simplicity, if they're carrying methylprednisolone, give it, and we'll take care of the rest of it at the hospital and forget about this hydrocortisone stuff. If we can't do it, we can't do it.
What about the dexamethasone? Because that's also now an option we've added to the drug box list, which we'd have to consider here as well.
Yeah, so we
The
can add,
dexamethasone has no mineralocorticoid effect.
So we should not put it on here.
I would.
Okay, that was my question.
I'll defer to accepted protocols or what's current practice. But mineralocorticoid effect has no immediate benefit. It takes a couple days for the kidneys to catch up on electrolytes. So as long as we're giving them glucocorticoid effect, that's the resuscitation they need. And I'll echo Frank's comments that you'll get that with methylprednisone as well as the hydrocortisone. Dex is purely glucocorticoid.
Yeah, you know, you're exactly right, Jill. We're kind of skype in the middle here, or threading the needle here.
And I think we should make a specific comment against using dexamethasone on here.
I think if it's not on there,
You don't think people will ask? I think people will say, well, I think it'll generate questions.
okay, we could do. So just to clarify, we're gonna strike the assist the patient's own hydrocortisone. We're gonna take that off.
Because we can't do it anyway, right? And
We
then,
can't do it anymore.
And then jump right underneath
And
it.
then we're gonna take off the patient's hydrocortisone and go.
We're paying dex.
We're gonna do methylprednisolone. This can be merged, not in same dose.
That's what I'm saying.
Right.
But I mean, some
It's up to you guys. And
No,
then
but the
we can
question
put
is,
a
if we
bullet,
had a bullet, dexamethasone is
not indicated.
Yeah, because I think if some agencies are switching, let's say they're saying, well, we're gonna switch to dexamethasone from methylprednisolone because now there's an option, oh, well, we'll just substitute it in here and not understand that it's not effective for that.
We're gonna say, so we'll merge those two shots, we'll say dexamethasone is not indicated for adrenal insufficiency.
Right.
Perfect. We're good with that?
Yep.
Okay.
Another very quick.
This is Dan. Hey, Dan Spate. I'd like to point out that we have just spent 20 minutes arguing about something that there is not and there never will be any randomized controlled trials done in the EMS over this. I think it should be incredibly simple. I go back to the comments that the more shiny objects we give them, the more likely it is they're going to be thinking about other things than the things we need. If you use the TBI data, which is probably longer because many of the patients bypass local hospitals and the trauma centers, the median time spent with EMS personnel before arrival at the hospital is 32 minutes. And 90% of patients had transport intervals less than 20 minutes. So to me, the issue of arguing all about these steroids and so forth doesn't make sense. So whatever we do, I would be really simple And we're not going to have these answers because nobody's ever going to study this.
Thank you. Phil, did you have something else to show?
Yeah, very briefly, under AEMT, are we expecting our EMTs to assess for hepatomegaly? And if not, can you just stretch the dosage column? And I believe, unless my med school memory is bad, RALs and crackles are the same thing. So can we do RALs / crackles or respiratory distress?
We should use phone. You're right, and we should use a lot of terminology, crap.
Yeah.
Yeah, I would just leave it as crack.
The hepatomegaly part is a big piece of it, so I know that they're probably, I mean, unless you're an infant, it's probably not, so it is rather than that. But we can still merge it and it'd be simpler, for sure.
And that's gonna go up into the EMT anyway, with the exception of consider IO for the AMT.
So we're gonna merge that and take off hepatomegaly, is that correct? And then just
And we
keeping,
accepted the epinephrine push dose.
Yes. Wait, just one other thing. We have pushed those epi below epi drip, just as a, if they're going like, they're looking at it sequentially at all, we should do epi drip, or epi, push dose before epi drip, just to flip them.
Agreed. Order preference.
Well, let's just get you where you want to.
For the paramedic section, for the P section, are we trying to say unresponsive to fluid to be consistent with the adult side, or just unresponsive? I'm just trying to clarify.
Good catch, unresponsive to IV fluid.
Cool, okay, thank you.
And then we're using a
That's very
full
true.
method, so is that an AMT training, process or?
Go to alternate.
I think there was a feeling, I think we discussed quite a bit, people felt like this wasn't a terminology most EMS providers understood, or the only way for it to was the push-pull method, the push-pull method.
Oh,
That was just giving all that, no.
We use it for, keep pushing up.
All right, anything further on shock before we move on? That's the only, this small thing, it's scroll down in box 3. Just on the pediatric side, we should have findings of shock above that, those 3 bullets. So that's just a quick clarification thing.
Was there a reason we had 20 of fluids here versus 30? 30 in the shock. I don't know. I don't have strong feelings about it, just
to keep it consistent.
Yeah.
She needs a heading, underlined, no bullet to match the left side.
Thoughts on that, but, Amber's recommendation is there a reason this is 20 mLs per kilo versus 30 mLs per kilo?
I don't care. I just doesn't match the shock. If we refer to shock treatment afterwards.
Let's do 30 match it, yeah. Sure. And then I would actually take that whole thing from AEMT and just put it all into EMT. And then you could put your last 2 bullets, like Bright was, not crying and saying like AMT and paramedic, just leaving a blank.
Well, I'll have,
Because everything there except for the IO you can do under EMT with an STR.
well, you'll just have to consider the IO at the EMT level.
Anytime we will move that, that would be part of our general edit.
Okay.
So, all right, so just confirming everyone wants 30 mLs per kilo?
Sure.
Okay. Anything further on that one? All right, next, nausea, vomiting, we have no recommended changes to this one.
EMT combined, adult and baby.
We have different fluid bowls there.
That's, yes, can we consider that? Because we have this 500 to start, and then, but then we say advocate up to that 30 ml per kilo at the top. Can we just pick a number and combine those for simplicity? Like make it all consider 10 to 20 and then go from there.
I think the only reason they had that on here is because the nausea vomiting, the concern for DKA and giving too much fluid, so going up to 30 per kilo.
That's what I'm saying. Like we can pick the bottom side. We can pick the peds 10 to 20
mils per kilo. Yeah.
and just bring it across the adult side and then unify it.
So the kids would just be considered 10 mils per kilo?
Yeah.
about DKA.
And then would you have to, if you're gonna merge them, then you'd have to take out max dose of 30 or just leave it?
Yeah, take out max dose 30.
I would got max dose 30 and then merge everything the same.
Caveat is, if you don't take out the 30 mil per kg, you're gonna give up to 40 mils per kg to a kid.
Oh, because you'd have to take out maybe repeat.
Yeah, so I would leave may repeat as indicated to a max of 30 and just do your initial 10 to 20.
Oh, I see. Oh, yeah, that works.
All right, any,
And then do we want to add IM for the Adaptatron?
I am.
Or, I just had a note from somebody that said that, I was like, huh? Yeah. Okay, I'm just making sure.
Yeah, that'll be an IO. All right, any further? So we're gonna scratch the AEMT section on the adult side. It'll be consider 10 to 20 ml per kilo bolus. May repeat as indicated to a max of 30 ml per kilo. This will be merged and we'll go under EMT section.
You can, there is IM dosing for it though.
Right, because they use it in the hospital.
You can get it IM. I mean, you could, so I'm just saying that there's, it's listed as IVIM.
You can get Zofran pretty much anyway.
Yeah.
Yeah.
Yeah, we've got it as an alternate if they can't get an IV.
Right.
Some people don't tolerate the ODTs either.
Right.
You want to add IM? Got it. Okay. Take it as a plausible route. All right. Any further discussion on those?
Doesn't Adaptatron need to say max of 4 under the right side, repeat?
Yes, it looks like we last time. I am max dose of 4 milligrams.
Might take a minute.
Yes. All right. Any further discussion on general plan before we take a vote? That's section 1.
Just an hour over.
Hour and a half. That's okay. So we're going to do.
That flies when you're having fun.
So PMD vote first. Anyone opposed to the recommended amendments to general medicine, say nay. Any abstentions? All those in favor say aye.
Aye.
All right, MDC vote. Anyone opposed, say nay. Any abstentions? All those in favor say aye.
Aye.
All right. Thank you. All right, next. Airway management. So we did go through this quite a bit. I'm gonna, for one, we did not spend as much time with the airway management. So if we can scroll just a little bit. One thing that I was recommending, which will also give us more space in the EMT section, is we should change it to use BDM ventilation with appropriate size mask, because really for any patient, you should have an appropriate size mask, and then that would get us just one universal section and don't use it across.
Now say that again.
So use BDM ventilation with appropriate size mask in the setting of respiratory failure or arrest.
And then that way,
Get rid of the.
gets rid of the feedback.
Yeah, that's a good idea.
So
That would actually bring up some space.
next time, bring us up space.
Faces and beards are not created equal.
And what, and so where does the space come from?
Because when you take it out.
Oh, gotcha.
All right, and then under AEMT, the same thing with also, we should be using least invasive means of airway management for all age groups. So that should go in that bullet should go across, and then expand merge adult and peds as well. Yes, Brian?
So there may be other areas where this fits. So any other area where this fits. CPAP and supraglottic airways are STRs for EMTs. So we should move that line up, and in the second bullet for EMT right now, it says consider oropharyngeal airway, OPA, nasopharyngeal airway, NPA, or supraglottic airway, STR, which makes it seem like it's some, acronym for that. Change that to STR for EMT.
And do that with
And everywhere it fits in here, and then we need to move NIPPV, or we might want to say CPAP and then just add BiPAP down in the paramedic
So
one.
we do have BiPAP down there, so we have it split down already. We just need to move, we have BiPAP down under paramedic.
Oh, gotcha, okay.
Yep,
And
it's already split.
so we just need to move that up as an STR for EMT.
And if we can do that across anywhere that's supraglottic, because was that a previous motion to move anywhere that's supraglottic?
No, that was just for IVs and
Right.
IVIO.
So can we just do one, like a motion to say anything that's STR that was previous can all be moved up into EMT, or do we need to do it specifically?
Did we do that already?
We did it for specific, so we need to do each individual piece, just so that when Shelley and I try to piece this all together and capture what the groups actually voted for, so we can't just do all STRs, which is, I would say, we've covered NO2, IV fluids, and ECG. If we want to do supraglottic airways, we could do a motion to move that, and then also we could do a motion with that and CPAP, if that's the group's strength.
Yeah, I'll motion it.
Second.
Okay, so it's first and second. For PMD, anyone opposed? Any abstentions? All those in favor say aye.
Aye.
And MVC, any opposed? Any abstentions? All those in favor say aye.
Aye. Under paramedic where it says BiPAP, do we want to add the high flow nasal cannula also? So I believe that's added in the pulmonary edema section too.
Yes, that's a high flow nasal cannula.
We've decided the high flow path.
No, it's got not. No, it's got about the type that we can change that. Yeah. All right, and then kind of looking at some of the things that are on here, we have like gastric decompression is kind of to the left, but it should really be used for all age groups. If we can scroll down just a tiny bit further, just to get that whole paramedic section. All right, and then like endotracheal intubation should be considered with less invasive that have failed. That should be again everyone. Top to endotracheal tube. And you said everyone now. I guess the question is the only thing that looks like it's pediatric specific is the cripe. So it seems like everything else can be merged across, and then we could just do the adult P separate for cripe and the needle cripe, adult P.
Good idea.
So we will merge, we will not be able to do that real time. So we will merge all those pieces and then just have a break the bottom for adult P to the section. Yes, Brian?
The section where it says BiPAP needs to say paramedic only because it's not in the EMTI scope.
Okay, thank you. And that'll be for high flow nasal cannula as well.
What about needle cripe? Cricothyrotomies are in.
Needle cripe, I think you were.
Cricothyrotomy is paramedics only too.
Yeah, we have it for paramedics. We have it for regular surgical cripe, but not needle cripe.
Oh, yeah.
And Christmas is here.
It's there.
Yeah.
It's there.
Oh, gotcha.
Yeah, so that will be paramedic only.
Do we want to put it as an SDR, right? Oh, it is there.
Should have kept it in.
It's not
Check it out here.
What?
It's a
not
check mark.
SDR.
Yeah, it's a
I
check mark.
thought it was an SDR. Wasn't it?
No, it's not. I got good scope as well. Right.
Right.
SDR.
There was a point in time where these were separated out, and I think it said surgical, specifically surgical cricothyrotomy in a previous version of this, and it was an SDR. But when we combined it up just to cricothyrotomy,
It became a
then
check
it
mark?
just became a check mark. Because some of them were check marks and some of them weren't.
Oh, okay. I must have been looking at it all.
Right, because like the old albuterol used to be STR now
Right.
for everybody.
All right, so just to summarize, we'll quickly, and then we'll move to the next one. We're going to move the CPAP and that supraglottic airway as SDR to the EMT section. We're going to do appropriate size masks for all age groups, merge that across. At the bottom, the EMT paramedic, we will add high flow nasal cannula, paramedic only for both BiPAP and high flow nasal cannula. We're going to merge those, all the boxes together except for cripe on the left for adults, paramedic only, and needle cripe on the right for peds, paramedic involved. Everyone's good with that? Okay. Next is the care of patients with notice of highly infectious airborne respiratory illness. This is kind of an adapted COVID guideline, from the, this was kind of taken of what our state COVID guideline was, and taking out the term COVID and really saying anytime you have suspected infectious airborne respiratory illness. We spent quite a bit of time on this previously. Yes, Ryan?
Go ahead and finish what you're saying about spending a lot of time on this before.
I know, I just said, if you want to spend more time with it, we can, so go ahead.
Well, here's my question. I asked you this at a meeting when all the emergency waivers and stuff went away. Does that mean alterations in our care of patients, because there were specific stuff in there related that goes away with that emergency order? You kind of implied yes, that, and there's a lot of alterations in care that are really based off of COVID guidelines, and this is not in our current format, and there's stuff with CPAP and BiPAP down there. All kinds of stuff is going to have to get moved around, since it's not in our standard format for a guideline. Either that or rebuild it into, if we're going to leave it there. But my question, other than the format, is how does this fit into that kind of thinking about big alterations? Because
well, we got rid of most of the more concerning elements. There's really not, you're still giving fluids, you're still getting SBN, you're still doing positive pressure ventilation, you're still giving oxygen. There's no limitation on those interventions. The only thing which is, if you have a highly infectious airborne illness, that you're just using caution if you move someone to the hospital hallway and around other individuals.
But I think I like this. I like it not formatted like the normal one, because it highlights that this is not normal. This is something that's different. And it uses our latest version of the COVID protocol, which did return to all of the normal standards of care. There aren't really crisis standards of care left in here that, at least I, as a medical director, would say, oh, that's not appropriate care. So.
Well, but here's my question: is use CPAP or BiPAP when necessary, and discontinue prior to entry into a public space, including hospital hallways. And my understanding is, A, it's not good necessarily to break CPAP once you have it established. That was, one of the big ones. But, and we don't have the breakdowns in the scope of practice for the different areas when it's felt like this, either. But that, I don't know, maybe thinking around CPAP from when we first implemented it, but my understanding was that, like with a nitro issue, once you put a person on CPAP with pulmonary edema, are you breaking that all the time to put a nitro filter under their tongue or whatever? So.
Yeah, I think the mechanism of why we use it for respiratory illness is a little different. So yes, you're helping to recruit, and that's part of the CPAP, obviously, but I don't think that the risk of breaking it is the same as we're talking about patients with pulmonary collapse due to like massive alveolar edema. So, I don't think there's the same risk there of breaking it, but, I do think that we should continue to be cautious about aerosolizing infectious diseases in the hospital hallways. I still think that should be something that we continue to care about as pre-hospital providers, to make sure that our folks are being responsible and maintaining good practices, even though technically the emergency orders have ended. I still think it's good practice.
We need to preserve our pre-hospital personnel resources and our intra-hospital personnel resources. This is really sort of almost a public health perspective. It's an occupational health perspective. And then, like you say, there's probably somebody's not going to come to a bad end because of it.
I agree with Josh. I actually like it in this format because it makes it stand out, so it gets people's attention.
Brian, to speak to your point, it does talk about, we're worried about them pulling off a CPAP and BiPAP. It talks about coordinating with the pursuing facility. So if there's a protocol in place there for whatever they have, they can discuss it then then too, if you're not gonna be able to take that patient off.
And this was adjusted to really get much closer to standard of care. It does give the option of still going in and implemented and pending respiratory failure. That's in this version. It's definitely been softened down significantly from the original COVID guidelines.
It may also help somebody get a room quicker instead of being stuck in the hall too.
I hear the general consensus to keep this in this format, even though it's not necessarily matched or TTBG. Is that correct?
I'm guessing we're gonna remove the updated on 3/30/2022.
Yeah.
And then
All right, next for bronchospasm, we removed, patient assist, and that was just, yeah, we all appropriate listed. And then the only other, thing just to point out, because there was some question, magnesium, we do have 40 mg per kg at the bottom. This matches the sensitive dose, but, just pointing that out. Otherwise, I don't, think there's anything significant that we need to change or adjust at this one unless anyone feels there's anything else there. If you look at the drug, it's listed as inactive.
I have ibuprofen deleted for some reason, and I'm not really sure why, if it's hiding somewhere else down here. The other thing is on methylprednisolone. After that, it might be good to put in or in between methylprednisolone and dexamethasone, have it work. It looks like you do both of them.
Yeah. Thank you, good catch.
Shelley, or methylprednisolone, IVIM, comma, Axo. And then, instead of or after 125 milligrams.
And then deleting, well, we're gonna be moving all that stuff for AEM, except for the epinephrine. Oh, the epinephrine can't go up, but medium ventilation is reasonable for pediatric patients, which we have deleted from other areas. And it's in. Oh, well, wait a minute. Or when non-invasive positive pressure ventilation is not available.
So we just need to move that bullet up under the EMT section.
Oh, yeah, the epinephrine is going to need to stay
at
the AEMT level. All the rest of them move up, and unfortunately, I did not make a note about that. Oh, I think I deleted the long run because that NIPPV and CPAP, there, if we move all the rest of that stuff up, then those two lines can go away because they're just duplicating. That's probably what I meant.
And clarification for your grammatical checklist. Anytime we have several different formats across the body of the document when we have or. Sometimes we capitalize it, sometimes we put it in brackets. So just recommending that you pick one.
All right. Anything further on bronchospasm?
There's no Ronchi on here, are there? They're just wheezes. Yeah, fill it.
All right, pulmonary edema. So I highlighted, we had approved this at PMD and then recognized there were a couple issues. I think we've probably addressed this. The EMT section, we had performed 12-lead and transmit.
Acquire.
Yeah, so we just need to make sure that it's the consistent terminology, and then refer to Chesney ACS STEMI. And then something came up with, are we asking them to interpret, because that's not part of scope of practice for EMT, they can, so, like, pardon?
So I would change that to the others.
Right.
Yeah.
Everything could be self-consistent across all
Yeah,
that.
so I think if we take, I don't think we would need to refer them to the ATS STEMI, because they're gonna be doing that based on potentially interpreting this as a STEMI or an STEMI.
So you can put that down,
That's not the
paramedic
scope of
if you want
practice,
to.
so we're just gonna take this part
earlier on that acquired 12 lead EKG and transmit at the EMT level if available. Did we have that?
Yeah.
We had that on there, right? I just want to
Yeah.
make sure it was in there, because I had that as a note that.
And then we have moved, NIPBB and CPAP up here, we didn't clarify below the. So we just need to add high flow nasal cannula as well under the paramedic.
Paramedic. Be like 5 half, comma, high flow nasal cannula, or whatever.
All right, any,
I have one more. So I propose that we copy a little bit more closely. When you look at the chest pain algorithm, I had proposed matching the Nasemso verbiage a little closer with the warning about nitroglycerin contraindications. They not only emphasize the erectile dysfunction medicines, but also pulmonary hypertension medications. And so I made those changes on the chest pain page. I wonder if we shouldn't carry that over to this page. Oh, it is.
It's under the copy.
That's a good idea.
Someone else agrees with you already.
Yeah.
anything further on that one? Okay, next, our assignment for the new one, I think I've clarified quite a bit. My only recommendation, which does mess a little bit with the formatting, I know, is that we take EMTI out of this part, because this is only for a paramedic. This is SDR for paramedics only. I think we should take out of the pinkish bar the EMTI.
So do we take out EMT also?
So since this is at the top an STR, could we define their STRs for paramedics and then just delete the EMT and EMT in this case?
STR for paramedics, that's a good idea in the title, and then, I would move the initiate universal care, we should just put under paramedics. Really, there's no EMT interventions for this.
There'd be no white under you.
That we're not changing that.
And then also, we keep the OR formatting under the sedation meds, but it's totally missing under the post-intubation package.
We will not have space for or between each one, so let's say choose one of the following. You go or use one of the following.
You could put orders at the end.
At the end, yeah. I mean, we just have, so again, from a consistency, it might be better to just say, it says use lower dose, and then after TBI period, use one of the following.
Do you want to use one, or do you want to, they have different pharmacological functions. When we're doing it in hospital, we're going to use an opioid and a benzodiazepine, or propofol. I know that we don't have propofol in the field, but they have different functions.
Yeah, for this scenario, it was always meant to be or, so I think it would be, just try to get them to not start mixing 4 or 5 different meds in the pre-hospital setting.
Okay. Yeah, I'm okay either way. Choose one of the following, or put ORs as Boolean operators at the end.
Is there anybody left that uses my Dazolam RSI?
Yeah.
No? Huh?
Well, this is post-intubation. This is.
Oh, that's
post-intubation.
Yeah, okay,
Yeah.
sorry. Yeah.
Third world.
Oh, I said down here at the bottom, okay.
Yeah.
I was looking.
New lines on the course.
I don't know if this is so, you guys.
However you want to format.
Yeah, whatever you want to do.
Whatever you want to format it.
Yeah, I totally agree.
Yeah.
But just format it however you need.
Yeah.
Okay.
Yeah.
So there's really, we're not seeing any clinical piece of that, so.
Right. Whatever you need to make it.
Yeah. Choose one of the following if you like, that's fine.
Okay,
You're the director.
all right. So any further discussion on this one? Yes, Brian?
After rocuronium requires agency medical director approval, well, that's inherent in the document since it's an STR. Can we just scratch that? And then I had another question on here. post-innovation, place patient on mechanical ventilator. So does everybody who's doing RSI in the state put them on a ventilator, or is anybody bagging them?
There's plenty there, right?
We don't do the rest.
If available, if available.
Yeah, sure.
Yeah. Or ensure adequate ventilation. You can bag valve mask them, you can put them on the vent if you got it, whatever.
Sorry, one more thing after that, when you're done. Pre-oxygenate. I don't think everybody, but at least we don't pre-oxygenate with bag valve mask for everybody, so I'd say maybe throw in there high flow oxygen by non-rebreather plus nasal cannula or BPM ventilation.
Or should you just say optimize oxygenation prior to intubation? Yeah. Or provide nitrogen washout.
You could actually probably combine the pre-oxygen and apneic oxygenation into, it's all pre-oxygen.
Yeah, but apneic oxygenation, you know, theoretically is left on during the procedure.
That's true.
All right, so the recommendation on pre-oxygenation, you're gonna reword, what would you recommend is the, so I also don't think in the pre-hospital setting, they're doing 4 to 5 minutes of watching someone before they do this, so that's not realistic either. So,
Why don't we say, provide high flow oxygen by, bag valve mask ventilation, 100% oxygen or non-rebreather plus nasal cannula at high flow. Or whatever, somewhat.
Do both, high flow, medium.
Okay.
Or non-rebreather mask plus nasal cannula. Yeah.
And there's a question in the back here, yes.
Well, I would maybe gonna just recommend you use nasal cannula 100% of the time with one of those other sources. That way it's there for your apneic oxygenation. So nasal cannula plus non-rebreather, BVM, CPAP, whatever else you use. But that way it's there for apneic oxygenation.
Are people how are they doing it? Are they having 2D cylinders? Okay, because you got it, because there are different flow rates. You can't use it. Okay, everybody's got 2D cylinders on their ambulances? If there are.
There's at least more than, there should be at least more than one cylinder, period.
Okay,
So,
okay,
yeah,
great.
they have. Of some size.
Whether or not they bring both.
That's not a requirement. There's just a minimum amount of oxygen that's available. It doesn't say anything about multiple cylinder types or anything.
You're making me feel better about my question.
Yeah. So I guess the question is are they doing that?
So back to just the guideline here, making sure that we capture the verbiage to provide high flow oxygen by nasal cannula plus BPM with 100% oxygen or non-rebreather. And do you want to do 100% or high flow?
High flow would be my preference.
So nasal cannula plus BPM with high flow oxygen or non-rebreather and high flow oxygen.
Would they understand to be high flow for non-rebreather greater than 15 liters a minute? We don't have to specify. Okay.
They may put it at 15.
15 or greater.
Do you want to try it?
Well, some aren't going to go above 15.
Just some might on the training.
Some aren't going to go above 15.
And it depends on their transport time and how much oxygen they're carrying.
Right.
No, I get it. But it's got to be at least 15.
Yeah.
Any further recommended edits to that?
I'm gonna hold off my rock already.
I think we debated that one.
We did. But I'm still passionate.
All right. Any further, do you have any airway section?
So there's one comment in.
Yeah.
On caution for pulmonary embolism. Under the caution part, it says for PD5 inhibitors with parentheses for echo plus pulmonary hypertension.
comma, or epiprostinol, or treprostinol for pulmonary hypertension, right, the doll add-on, right, because they're two separate. So after hypertension, down there.
Got it. Thank you.
Just for,
Yes.
medical clarification.
All right. Any further discussion on the airway section? All right, we will do PMD vote on that section. Anyone opposed to the amendment to airway section, please say nay. Any abstentions? All those in favor say aye.
Aye.
All right, MDC, anyone opposed to the airway section update discussed, say nay. Any abstentions? All those in favor say aye.
Aye.
All right, the airway section is passed.
You know, I'm sorry, there's just a thought on these cautions that just made me look at it. There are more than sildenafil and tadalafil. Should we say, for example, e.g., because, you know, there are at least 2 other drugs in that class. Or you could, I think e.g. shorter than such as. They're taking the other 2 and they give this, because I don't know if most will understand phosphodiesterase, you know, PDE5 inhibitors.
All right, we will, that's an amendment step, so you'll need to re-vote on that.
I'm sorry.
No, that's fine, we just gotta make sure we re-vote on that then.
I'll make that motion.
Okay, second, okay. PMD vote, any opposed? Any abstentions? All those in favor say aye.
Aye.
MDC vote, any opposed? Any abstentions? All those in favor say aye.
Aye.
Okay, and then the verbiage is gonna be, EG is added, all right?
Yep.
Thank you.
Thank you.
All right, next up for, cardiac arrest. So one of the things that I wanted to kind of propose to the group, that Amber and I had talked about was, both Southern Arizona and Central Region have moved to a combined adult and pediatric cardiac arrest algorithm, which is probably a little bit easier, to do. So one of the things that I wanted to, kind of propose to the group to consider, do we want to do that, or do we want to keep these as 2 separate ones for now? So that's kind of the first, point of discussion. You guys have your version that's set out, but Central Region does have a, like, kind of a TTDG format, adult peds combined. I think the main difference is the epi dosing between Southern Arizona and the Central Region now. So we just wanted to see the feeling from the group on a preference on all ages, but except for newborn, or still splitting them adult peds.
I think combining them is appropriate.
Is it appropriate?
Yeah.
Okay, yeah, so I guess I agree.
Kind of a problem, but, yeah.
So,
Down to what age does it go?
age.
Oh, that's right there.
Well, actually, it's all ages, except for
Yeah,
newborn.
all ages.
It's everything
Okay.
except for neonate.
Okay.
The newly born, there's like a neonatal resuscitation, and then everybody else gets the same CPR.
So regardless of age, everybody's getting MICRs.
No, but you can build that in, so that's why I'll show you what the Central Region did, and then see if the group wants to try to adapt that to the TTDG in that format. Figure it'd be easier that way than trying to real-time do edits on this. But just wanted to first see if the group was kind of okay with combining it. It sounds like a good half the state is already doing that combined guideline format. So, general resuscitation.
Oh, I see, okay.
The VDA down a little. Okay, good. Right there. Up, down one, up one. Okay. Okay. And for some reason, it's making this blue on here, so we can try to make that a little bit bigger, and then we will look at this.
Yeah, when I looked through this yesterday, Gail, it is entirely consistent with what we do in the Southern Region, other than we limit our pediatric epi dosing. That's the only difference. And our dosing limit in general too. And my other suggestion for this one, just because it is so busy, Gail,
Yeah.
if we're going to go to this, I would keep this, but there are a couple things that I think you could strike, like ensure adequate recoil. Some of that stuff that I think is more instructional, and I don't think they're reading that to perform this. So you could potentially shorten it somewhat by taking out some of the stuff at least that's really entirely instructional, but those are just my only comments.
So the question about the MICR, so the airway management piece here, this is where it kind of delineates between age groups, so 1 through 8, and if you have like a perspective, if you have like an overdose or trauma or drowning, then you go straight to positive pressure ventilation versus passive oxygenation. So the other part that I would describe to this is the defibrillation. We have hyperlinks in the central one to the individual monitors. I would just take this out of the state one. That's just for that section one. Agreed. So Amber is recommending ensuring adequate recoil, that we take that second bullet under initiate chest compressions out.
Yeah.
That's page from. Yeah, page from. Okay. I'm capturing on my chicken scratch, and then
I'm sorry, Dr. Bailey, just to clarify, so for peds, you're not doing 30 to 2 or 15 to 2, you're doing just
up constantly.
I'm just trying to clarify, that's all.
In the base of my existence, there's no advanced airway at all.
Yeah.
And you're just doing back valve method. My crews are getting very frustrated with that as far as synchronous or asynchronous ventilations.
We do asynchronous ventilations for everything.
With the BBM?
Even with the BBM.
Okay.
And we don't run into any specific.
So the question is, do we put that in print? Because it's just every time they go through their ACLS renewal.
We can't, we have it in ours. We say asynchronous ventilation specifically for ours. And we still get questions, and if a medic did 30 to 2, would I say anything about it? Probably not, but we just try to keep everything consistent so that we're not creating a cognitive load to remember different numbers for different things, but there's a little bit of evidence, and there's been like one retrospective review of rock data that looks at 30 to 2 versus asynchronous, and maybe there's a difference, but there's no randomized control data that one's better than the other. So I think the limitation is that the providers say, well, I can't see chest rides while I'm doing compressions. I'm like, well, are you really using that as your, like in general, are you really using that as your, are you really looking for chest rides, or are you going based on how it feels? I don't think they're usually looking for chest rides, but I think that's the limitation. But
so the recommendation, so between the bullets, we've got the underlying bullet, initiate chest compression and airway ventilation. Maybe you can put underlying bullet. What verbiage do you guys use there about the asynchronous?
Oh,
we could just add that bullet in there. So put an enter about airway, and then we'll add it there. And then we'll, if they're looking at right now, that's what their verbiage is.
Can I ask another question while you're looking that up? So for adults or for peds, is it still essentially MICR if it's only cardiac, only suspected cardiac, or if it's trauma and they're in arrest? Are you?
Well,
I'm just trying to clarify.
I'm going to give you the background. So this MICR concept, it became incredibly confusing for our providers because they used to say MICR, continuous chest compressions, AHA CPR. They're very confused. So we've gotten rid of that terminology altogether and just say do chest compressions at 200 a minute, or 200, yeah, 200 every 2 minutes.
Yeah.
Yeah.
And that's
regardless of what potentially caused the.
Regardless. And then we say if you have a likely cardiac, you delay your airway for 8 minutes.
yeah, we say
If you are a child or likely respiratory, unwitnessed, then you do immediate airway.
we say if unwitnessed arrest or respiratory, hypoxic arrest, pediatric, or trauma, immediately begin airway management, positive pressure ventilation at a rate of 10 breaths per minute.
An even simpler way to say that is witnessed arrest, they get past it. Everyone else gets an active.
But yeah, I guess I don't have asynchronous, I must have taken the wording out of here for asynchronous ventilation, but we basically say if it's unwitnessed arrest, respiratory, hypoxic, pediatric trauma, those immediately get immediate airway management and positive pressure ventilation versus passive airway for everyone else gets a 15-liter non-rub breather
start. Is that in any of the MICR stuff at the state level, whether about unwitnessed? Because I don't
So we,
recall that originally being a part of it. Ours doesn't.
so initially, the reason we worded it like this is initially, we had in the algorithm that if they were unwitnessed and they had, there's multiple reasons for this, but they used to do the charging the pump kind of thing. If they're unwitnessed, you're priming the pump, and in practice, everyone got at least 100 compressions before the pads were on and ready to shock anyway. So it didn't really, in practice, matter. And I think in our region, we had noticed that we had a lot of folks with unwitnessed arrest because they were presumed cardiac. They were getting passive oxygenation for a really, really long time before they ever got any active airway management. And so we wanted to make sure that those that were, if they were unwitnessed and you didn't know that they had a short downtime, then they needed earlier airway management than patients that had, like, were a witnessed arrest and VFib arrest. And so we were just noticing that we said presumed cardiac causes get passive airway, but we were having passive airways done on patients with unwitnessed arrest and been down a long time and were like in slow PEA already, needed airway management, but weren't getting it. So we just drew the line as unwitnessed versus witnessed to make it simple, and try to capture most of those that would benefit from passive oxygenation being the witnessed arrest. And because the data is much more clear for VFib arrest than it is for all comers. So VFib arrest, short downtime, there's definitely probably benefit. There wasn't a statistically significant difference, although a trend towards survival in those with, all comers, all rhythms. And so that's where we made that line, just to make it simple.
Well, and this one does say it's not for witness arrest, but that's not, which is fine.
This is Dan Spate. Hey, our shared data, no question, supports what is in the world literature, which is anybody who wants to split hairs about what you do in unwitnessed arrest, you can feel free to split hairs, but the reality is they have an incredibly low likelihood of surviving no matter what you do. And that has definitely emerged from what are now 40,000 cases in the share database. So the reality is, theoretically, it makes sense that if it was unwitnessed, the likelihood that they will not, that they will need oxygenation makes sense. So that branch point is supported by our data, both because it makes sense and because in Arizona, if you have unwitnessed arrest, the likelihood you'll survive no matter what happens is incredibly low. So it is supported by the Arizona data, even though that's correct. In the original MICR evaluations, that was not a branch point, but it makes a lot of sense.
And it already said that on top of this. So are we modifying this one to add in
Yes, so.
these elements? Because I'll have some other comments on this.
So the,
I think Gail has up the version that's not in our packet.
Correct.
yes.
And that's what it's going to become, or are we putting stuff?
We're not, no, there's no way to edit these ones because it's too messy to try to do this. So the ones in the packet, you're gonna need to go with this to match. But the only thing that's different is just the AET section. That bar is there. So, but first, let's do the EMT section first. So let's make sure we capture what we discussed as the recommended verbiage for the airway management. So for airway ventilation, we have bullets 2 and 3 are essentially saying virtually the same thing. In Southern Arizona, you also add in unwitnessed. So we could say if unwitnessed, comma, suspected respiratory overdose, trauma drowning, comma, pediatric patients less than 8, immediately begin manual ventilation at a rate of 10 breaths per minute, right?
Below Shelley, under airway ventilation.
Oh, yeah.
Yeah, it's okay.
So if suspected, with the second bullet down, it's suspected.
Suspected will be changed if those,
Potential.
Okay, this is Dan. I understand where that went, but immediately, does that imply first? Because I agree with Amber that the reality is regardless of why somebody's down, the first thing that happens, because anybody on the team can do it, and you don't have to get out any stuff, or turn anything on or do anything or get a widget, they start compressions. So does the immediately create confusion there? Because it immediately tends to imply that's the first thing you do, which isn't the first thing you do.
But initiate chest compression does come first on the list.
Yeah.
Yeah.
I think, yeah.
Right.
We'll take our word for it, right?
It's in the front row.
I have new glasses coming today.
All right, so,
Which record?
okay, so let's,
This record.
so just to kind of look at this, the way to summarize this that matches, it kind of simplifies this is the patient was greater than 8. The question is, do we, and witness, or just saying witness cardiac, because we have like if unwitnessed, suspected respiratory overdose, trauma, drowning, or P plus 8, immediate DVM, or cerebrotic at a rate of 10 per minute. And then for the section above, when we have the passive oxygenation, should we have the age cutoff, or should we just have, so witness and patient is greater than 8, correct? Witness cardiac arrest and patient.
Witness cardiac arrest in patients.
In patients, thank you. Yeah. And we would get rid of the age appropriate, which says now third bullet, yeah, just the age appropriate rate, you would get rid of that because we looked it up.
So then can we tuck in as the last bullet under airway management should not interrupt chest compressions, et cetera, add another bullet that says, all ventilations, to be administered asynchronous. All ventilatory support to be administered asynchronously.
We can. I mean, I think that there's not a ton of evidence to say that that's better than 30 to 2. I mean, I think that the literature currently is sort of equivalent-ish between the two things.
I guess just to stop the questions.
Yeah, I mean,
every 2 years.
It would stop
every
questions.
class.
But I get you. Yeah. But it would be not based on a ton of evidence. That's what I got.
In the phrasing here, it's mentioned if unwitnessed, suspected respiratory overdose, trauma. And question for this other region, do you also have trauma in that protocol, or do you have a separate system that you're doing for your trauma?
Separate trauma.
Okay, so that's what I was wondering if in here, because we similarly just have a separate protocol together for trauma arrest. So I don't know if people wanted to keep the phrasing obvious trauma or not obvious as trauma in here as well. I don't know if that's something people had a feeling about.
Asynchronously.
Yeah.
Can be.
Yeah. I think it's good. They're good steps over here.
And then we have line under maybe.
And then, the question about the epinephrine doses. So this one is a little different. This was, I know Southern Arizona does 2 milligrams max. The central region, kind of they were comfortable with doing 3 milligrams max in adults, but kids less than 15, they weren't comfortable having a max dose 4. So just want to bring up that there's no great data on any of that, but I think we just need to make sure we make a decision on that piece.
So Gail, could you state the question specifically again?
Yes, just pointing out, so the southern region has a 2 milligram maximum epinephrine dose for all age groups. The central region, the group did not feel comfortable having that low of a dose, so adults have a maximum of 3 milligrams, and pediatrics, for anyone less than 18, there was no maximum dose. So just pointing out that there's quite a bit of variation in epinephrine dosing in the state, without a lot of evidence.
Yeah, there are others that can too. The apologetic from the southern region would be, we know that too much epi is really bad. The that happened 25 years ago. We knew that. The second issue is we don't know epi after 50 years of trying and searching and hoping we could find a outcome difference with epi. We really still do not have an answer. So the randomized trials, it's always a secondary analysis that can find some little subgroup that falls out into statistically significant. So it's important for us to know. Probably, we don't know if it helps, but what the reality is, the literature has emerged with is before they have return of spontaneous circulation, epi is really good. And then as soon as they get return of spontaneous circulation, most of the time we wish we could take it back. but the problem is our ability to block, there's nothing good yet, and even on the horizon, that could be the equivalent of taking it back, because everything you give to block it does other things that don't help. So with all that going on, and knowing for sure that 5 milligrams is harmful, very harmful, that making sure that there's at least a max makes a lot of sense. And so that's why we ended up with 2, because we don't know if any makes a difference. And that's where we ended up. So I'm not making I'm not really even saying it really should be 2 versus 3, because nobody knows. But what we know is 5 is bad, and we're not sure any makes a difference. So that's where the literature stands.
So thoughts and recommendations for the group. I know cutting down to 3 in the central region has been tough for EMS crews, especially when they go to some hospitals, or hospitals are like, why did you stop giving them to 3? That being said, the data doesn't show that when we give them 20 milligrams of epi that we are helping the patient's outcomes. So I think we need to fix something in this group and then decide what we're going to move forward with.
I feel very comfortable coming up with a number, and I agree with the concept of the max dosing for all age groups.
Halfway there, Franco.
Except for that number.
If that 5 is absolutely deleterious, so maybe stop at 5.
So I've got a question for you, Dan. If you say 5 is bad in an adult, should we stop at 4? So we have an integer that's not bad, or 5 is the maximum that's okay?
Frank, that's a good question that nobody knows, but what happened after the Chuck Brown's studies, which were very informative, and every one of those studies got stopped at the interim analysis for harm. So I think that if you get the cults on both ends out of the picture, and don't just look at the editorials, the reality is we don't know if any makes a difference. 0, ultimately, 50 years from now, we may be giving no epi at all, or we may be getting some amount of epi with some super fancy, as yet not discovered way to functionally take the bad parts back and keep the good parts. But since we're nowhere near that, the question is, why are we giving any epi in the absence of evidence that it makes a difference? That's the real question. So since we know 5 is so harmful that they couldn't even make it through the study without the data safety monitoring boards stopping the study for harm, the question is, why would we even get close in adults to 5? Because we know that actually killed patients in the randomized arm to 5. So that's why I like being as far away from 5 as we can, since 0 may actually be the answer in the long run. So I don't like 4 because it's close to 5. I don't like 3 because it's closer to 5 than it is to 0. And we all may have to live with the reality that in the long run, we were doing with epi what we did with bicarb and what we did with, we saved a lot of people with isoproterenol, didn't we? It's just, that's the thought.
I think some of the data that Franco, you had pulled showed that some regions, like in adults, that over 3, you definitely started to see worsening outcomes, which is why the central region stopped at 3. Now, this was an adult-only study, which is why the group did not feel comfortable extrapolating that to kids. So let's narrow this down to 2 to 3, and we have a max for peds.
Can you tell me your guys' decision to go to 2 for peds?
So the decision was based on, admittedly, weak evidence. The evidence shows two things. One, the earlier you give it, the more likely you are to get ROSC. And the theory was, get ROSC early better, right? So we want to give one immediately. So we prioritize IO at the immediately. The second dose was purely non-evidence based because they didn't want to just do one.
For all the same reasons.
That's when we drop the airway.
Yeah, okay. And then we just make it consistent with our adult protocol, so everyone kind of gets the same treatment and there's no.
I like that. I was just curious.
Yeah.
I would raise it. So
Sure.
It's in the Phoenix study, the same question that I gave to Dan, is it 5 or greater is worse, or is it 3 or greater?
So they looked at 1 through 10 doses. It was 1 survivor at the 10th dose, so that was ruled out. And you still had multiple survivors up to 3, and then 0 after 3 in adults only.
Neurologically intact survival or just?
Correct. Neurologically intact survival to discharge.
Okay. So it's 3 or less was good.
3 is futile, not bad, futile.
Okay.
Yeah.
So less than.
was 3 then. I think it was the London EMS study, maybe one of the paramedic trials.
Yeah. So my main thought on this is like, you already know, let's get rid of epi, sure, but we're not there yet. The only thought is if we choose 3 is because I know a lot of hospitals have protocols for refractory B-fib and they all start at 3 doses of epi. So that'd be my one reason to choose 3 for the adults, just so, like you were mentioning, we don't have our medics getting in trouble when they arrive at other facilities. I agree with Fate. I think we're in the trajectory of we'll get rid of epinephrine eventually, but in the meantime, that's my one thought about making it for adults 3 doses, just to help our paramedics not get in trouble when they arrive outside facilities for these types of situations. Because we all have that refractory B-fib patient. In the ED, we never get to see good neurological outcome. We just see ROSC. So sometimes we have to make sure we keep that in mind too.
So I hear a couple votes for 3 milligrams for this, and then anyone thought the T?
I would add a max. And yeah, same dose.
And that max would be also 3?
I would go for 3. Okay.
Maximum doses.
Have you all published the study yet, Franco?
What's that?
Have you published that data?
As far as what's taken place with survival here in Central Arizona? Respectfully, I don't know that Central Arizona has at least at an agency level this sophistication or resources to do that study.
Okay, but I mean it's good. It's good to know. So,
And then
yeah, that's good.
So we'll do, and then under lidocaine, we don't have neither the current TTGs or this one has a max dose for lidocaine. So that should be a max dose of 100 milligrams.
What?
Per dose?
Well, it's 1 to 1.5, but your max total dose is 3 mg per kg.
Yeah, but per dose. So I think there's, most people have gone to 1 mg per kg because it's easier.
It's simpler.
It's simpler than doing 1 to 1.5, then you're coming to range. So if you do one max, lidocaine 1 mg per kg, max dose 100 milligrams, and then you have your repeat. Plus that,
So are you going to give your average adult 70 or 100? Yeah, they're all 100.
They're all 100.
No. No, exactly. And I never want somebody partially paralyzed.
So basically, it would be give 1 dose and 2 success, doses after that, and that's your max dose,
so.
theoretically.
So that's. So there were 2 people speaking over each other there.
I have a question for the experts in the room. Another question that keeps coming up is timing of amiodarones, which I've always answered. There are no data to really answer that, and so I'm good with some of the soft wording, such as consider and not attaching any timing. Is that consistent consistent with what you're doing.
So we have here, may repeat it at 5 minutes, let's give it time, a time frame.
Frame, yeah.
Yeah.
But as far as starting antiemetic therapy.
Yeah, it's not on here.
And then generally speaking, throughout the document, when there are multiple options for the same indication, if there are data to support it, we always put an order in preference. Is everybody cool with the preference implied on amiodarone greater than lidocaine?
I mean,
Doesn't matter.
you guys all saw the most recent evidence that says that lidocaine may be a little better. It's a random order to me. We stick with amiodarone because people are familiar with it and it's in the boxes. If we run out of amiodarone, do I have any heartache to change into lidocaine? Nope.
And you know, back to your question, I'm okay with 1 to 1.5 mg per kg on the lido. Yeah, I don't think it hurts us in any way. Because people are going to get 100 milligrams. And so then people are going to say, well, why'd you give them an overdose of lidocaine? It's just practical. A 70-kilo person, maybe there's no 70-kilo people left. I speak for myself.
The other thing that there's some more recent evidence, although definitely not in an essential model guidelines, is like vector change for shock refractory B fibs. I don't know, I didn't have strong feelings, but.
Starts doing like dual synchronous.
Yeah, I don't think most people are getting that far, but I mean, considering pad changes and things like that, just as like as a treatment option, but it's somewhat educational, I guess.
And there, but the data's looking worse and worse.
Yeah, we've done it a handful of times and we've never had that.
The double.
Not that that's, yeah.
Oh, yeah, we don't do that.
Not that that's.
Yeah, I just mean more like, pad changes, especially in like obese patients.
Right.
Any further discussion on this one? Yes, Brian?
Did we decide on 2 or 3 milligrams?
Three.
And then we're.
Yeah, well, no AMP that's gonna be IO access. Consider IO access. And then there's no EMTI aligned with paramedic, which is gonna give us drugs down there that are gonna get paramedic only. So can I make a motion that we'll come back and rather than spending time right now, we can get together and come back and put those back in the right spot and with the correct level of certifications.
Yes, we'll just put paramedic only next to the ones that are paramedic only. That'll be consistent, because that's what we've done with everywhere else.
Well, that's what I mean, but we'll come back and.
We don't need, we can just say that now. On the
Okay,
record,
so it needs to have the AEMT line added in with consider IO, and then amio and mag sulfate are paramedic only. And then is there anything down below these consider possible causes there at the bottom of it?
We haven't gotten there yet, I don't think, but I have thoughts on that, if you want to talk about that.
I thought we were finishing up the guidelines.
The page froze.
Pardon?
Or page froze. But you can't scroll down.
Because we should, whatever is appropriate, we should put a refer with to whatever other, hyperlink. Hyperlink.
Yeah, no, I think those are great ideas, Brian, and you're ahead where I was.
I thought we were finishing that.
I guess.
For those other ones, we don't have, so there's hyperkalemia, which is treated below. Hypovolemia, I mean, I don't know that there's any of those actually would have hyperlinks that come to any of those.
The one would you put in parentheses shock?
Shock.
We don't need to use H's and T's here,
Yeah, that's what we take.
so you could put shock if you want, hyperkalemia if you want, get rid of that whole, box below then.
We don't have a page dedicated to hyperkalemia.
Okay, sorry.
What's that?
There's no page that exists for hyperkalemia only. So we had to show the treatment
Okay.
explicitly.
Okay, thank you.
Then hypothermia, the adult, other thing I would maybe throw one in there.
I would agree. And then the tricyclic antidepressant overdose is so specific and really an old, not only an old drug, but just an old portion of the mnemonic. And so I would say almost any overdose, right, by definition, they're all acute, sort of reversible situations. And I mean, it's opioids, it's what have you. Right. So TCA is way too specific. If you look at like published H&Ts that we're all aware of, they use the word toxin, but that's really a misnomer. Toxins are toxic metabolic products of living organisms. So I might just say overdoses or poisoning, whatever the group thinks is conveys that.
I mean, because your overdose could be taking opiates and you're giving Narcan or something. So if you just leave it as just take out tricyclic antidepressant, just leave overdose.
Yeah, I'm good with that. Thank you.
The one question is, if you're resuscitating someone and they are an opioid overdose, you're managing the air rate, you're doing compression.
There's no rule.
There's no rule when actually if you give them Narcan, you suddenly reverse that and you did have Rob, you now may have someone who's actively vomiting or agitated. Is there more harm than benefit?
I don't know, I mean, the guidelines, the AHA guidelines currently recommend it's reasonable to give it if you have opioid overdose, but there are, like California takes it out of their guidelines because the treatment is oxygenation, not reversal.
Yeah. And the only reason I'm saying overdose is not because I'm saying give Narcan.
Right. Just consider other things.
We're just saying reversible cause. Sure. That's all. And it's
Which overdoses are reversible? In the So while they're thinking about that, on that bottom box, because we're gonna have a referral to hyperkalemia, can we just take out the bottom box then?
We don't have a hyperkalemia guideline.
Yeah, we have.
That is a hyperlink though to the ECG changes.
Yeah.
So there is a page to the dedicated not photographs, but diagrams of what an EKG would look like, but there's not a page dedicated to hyperkalemia.
Because there's some other places in this document that refer to the ECG changes, but that's what this is.
That's what that means.
Okay, never mind.
there are sodium channel poisons, which include cyclic antidepressants and other things.
But you're not going to get the EKG if someone in cardiac arrest, though. You're not going to get a 12 lead.
Right. No, I'm not saying that. But if they have Versaz, what have you, I might consider other things.
Right, and to your point, right, consider reversible causes. This is now we're just getting into, you should be taking a history from what you can, right? So if patient's like, oh, he was depressed, okay, then maybe you should consider that. So if people are bored, I think we should just switch it to overdoses and people can extrapolate from that as they will.
Right, yeah. I'm not saying you got to give this or you got to give that. Right. And to everybody's point, supportive care is critical for cranial.
All right, so we are going to add in the hypothermia with a link to that guideline.
And then we were saying like take out tricyclic antidepressant, yes. Just leave overdose.
Yeah.
Just leave overdose.
Yeah.
Exactly opposite.
All right. Anything further on that one?
You know, other H's are hypoxia, but we're already treating it, and hypokalemia we're not going to treat in the field. Hypothermia we added. Cardiac tamponade, we're not going to do anything in the field, and neither thrombosis or thrombosis.
And then the next page is we've always historically had that old school MICR guidelines when we that's when we first started out in the state. This is Southern Arizona's version, and it's really, I think, kind of just talks about what we have in the guidelines. As just witness cardiac.
I don't think we have to have this in there. People just wanted it sent over to look
at.
But,
and I think this matches what the other one is. So it's just again another format for cardiac arrest.
I like the graphics.
Well, I'm sorry, it doesn't really fit on the display very well.
Turning it to the side.
we have it in our packet.
Yeah.
The only thing I'll bring up with it, if they look at it though, they may get confused because the epi in Southern Arizona is you're only giving 2 and you're 8 minutes in, right? And if we're saying you're giving 3 and we're giving a guideline of 3 to 5, then it's not gonna match.
So we could say,
That'd be the only problem I would see with it, somebody just glancing at it, looking at it as a timeline.
So we could put in the, above the amnio sort of indicated, we could just do repeat epinephrine times 2, 3 to 5 minutes, and then take it out of that third box. Does that address that?
Say it one more time.
Under considered.
Yeah, I put it above
That
consider.
would be above, that would be,
Above
yeah,
consider, yes.
that'd be repeat at the times 2, and then there'd be consider. And then the next box, you would just take monitoring title. You take out that.
I'd request that we strike naloxone off that considered list.
I have no heartache over it. I don't know if people cry about it when I take it off. There. People cried about it, and I didn't want to hear the tears anymore.
As a toxicologist, I'm okay with it or without it.
So hard.
Again, going back to what Dr. Spade and others have said, you know, again, trying to live by some guiding light, and I think that one of the things we all agree on is try to keep things as cognitively unloaded as possible. And I think that this falls squarely on that.
And I do think that if you do get rocks and you give naloxone as the opioid overdose that caused that, there really is potential for harm.
I'm fine with that. I mean, basically, they already had the cardiac arrest, they're already apneic, and they need ventilation and oxygenation.
So we're getting rid of one of those boxes? I don't know if I can remake it for Shelley.
No, we are, so we're moving repeat epi times 2 above the consider amnio.
Okay, with that.
We're scratching out the naloxone under consider. And then the third box is just going to be monitor and title CO2. Yes, Brian?
So this is gonna go in the line of, the actual algorithms in this, rather than like, maybe this would be good to reference in the appendix rather than.
This is just replacing what we always had, the 2 versions. We had Dr. Barbara's old original version with the cardiac arrest one, and the group had wanted to include that.
And it is in the current treatment guidelines.
What is
This flow chart,
not in this format. This is a slightly different, this is an updated version of that.
because we're describing this in the, a bunch of this stuff in the treatment guidelines, right? And this is a CPR timeline. It's not necessarily a treatment algorithm.
And we have it in the current version. It's just the old, like, yeah, sure you can't see my phone.
Yeah.
This is basically an updated version of what's currently in the TCG.
It's just a visual.
It's a visual guide.
Of the guidelines.
Visual display. Can we change the medic to paramedic also? If we can make that happen.
Yeah. Gail, you were
Okay,
saying for that,
that's fine.
That third box, what did you say on the third box? Because for Central Arizona, or for, they would have that third as either.
it's just saying it's repeat every time too. It's just.
Oh, times 2 here, okay.
Yeah.
And then little nitpicky things, rather administer addition, just additional.
Oh, yeah, I think that's already.
Cool, thank you.
So are they going to do the amiodarone, consider amiodarone and or lidocaine, or just the amiodarone in that box as your antiarrhythmic?
Yep. Thank you for catching that. All right. So next is the post-cardiac arrest one. We've scrolled down a little bit. We had got back and forth to realize what was added and highlighted was a little confusing. Above we have transport to cardiac receiving center when feasible and resources are available. That is the very general term to apply the whole state. And then basically transport to the closest appropriate to any of the following. So basically, you know, any other circumstance where you're potentially just transporting whatever scenario is going on.
Is there a reason this is adult only?
No, so that was something that Central Region added adult fatigue. This time. Yes, and then. The question is just for the respiratory rate, this is 8, if we're doing adult repeating, should we make that 10?
Yeah.
I think that's 10. For the rate.
And then is there a reason to add, I'm guessing all the cardiac receiving centers are, well, I don't know if they're definitely not. In our region, we would transport these to a pediatric capable facility. But I don't know if that's necessary.
I think,
How that works.
I mean, like, I think for a lot of the states, there's no pediatric capable, and even like some regions, even though they are, the transfer time might be 5 minutes versus 40 minutes.
Yeah.
So they would just go to the closest okay. Transporting and get transferred.
Two things here.
Yes.
Do we need to obtain and transmit an EKG for EMTs? And secondarily, I'm not sure what the if transport to CRC will add greater than 15 additional minutes to transport time, then comma.
So these were kind of, if any of the following apply, so there's 4, does that fix that piece?
Oh, yeah.
So basically,
Yeah. Or just release, delete. Oh, I see. Or any that work.
Yeah.
Yes, that's.
The or is needed. And then the EMT, yes, the opinion transfer 12 leads. So that should be, where do we want to fix this?
Before notify receiving facility. Or maybe after notify, like maybe notify them first and then transmit your ECG.
Whatever.
Required transmit.
Safe verbiage.
In the backfield.
I just had a question on the ongoing CPR without Ross. Is that just if they decide to transport, or do they have to transport?
And then one consideration, a couple things to consider with this, that I think you guys had done in Southern Arizona that we added was really in the post-rock state, like if you get bradycardia, that you don't go to pacing those patients. I think that is probably something that is worthwhile calling out specifically on here. Because I think that definitely sometimes occurs where foods will start pacing someone and then not recognize that that patient is in a re-arrest state. So something to consider adding in specific verbiage. But since we're now, because we did not have a pediatric one, we obviously do want to get rocks. We want to make sure we have the appropriate outpatient treatment for them as well. The central region has some very specific verbiage. I can read it and then see with the group if you like that. It just like it comes from a lot of what you guys have in Southern region. Maintain hemodynamic stability and prepare for potential re-arrest. Keep finger on pulse to detect loss of pulses and monitor end-tidal CO2. Treat shock with IV fluid and push dose epi for shock guidelines. And then re-arrest, resume chest compressions and treat underlying rhythm. If PEA likely due to shock, resume chest compressions, treat shock, IV fluids, push dose epi, and if VFBT, defibrillate and resume compression. So those are some of the things that because what we recognize is people were struggling with the limiting epi, but then you restart your, okay, now they're rearrested, you go back to giving 1, 2, 3 more doses of the epi versus very clearly delineating, no, depending on your rhythm, you're either shocking and back compressions, or if you're PEA, presumed shock, and then you're treating shock, which is fluids and push dose epi. So just kind of putting that out there for discussion. I think we just need to make sure we somehow address that in this post-rock state.
I agree with that. So with the further early practical matter, we doing presence of radial pulse or any pulse?
I don't think we're specified for pulse. Your own.
As long as it's not yours.
All right, so, do you want me to read that again?
No, I'm going to make that one section.
So the maintain hemodynamic stability, we're going to expand that.
it is under the AUT section. So that would be expanded and add in our rearrest section. And I thought we had added here, but I think we should say, what is group thoughts for saying specifically, do not treat bradycardia with transcutaneous pacing? Any thoughts?
And that's in the AEMT, because they don't pace.
Well,
Where appropriate.
but just, I'm just saying in general, separate question from that. So just to maintain, if we're looking at talking about bradycardia in a post-cross state, we want to allow people to essentially,
Yeah,
I think put a bullet on there somewhere.
I agree with that.
You mentioned preparing a presser of some sort in that.
Yeah, I mean, could we give them a little better guidance of what to do then?
Yeah.
So in post-ROS bradycardia, check for pulse. If pulse is present, administer epinephrine. Push those up.
So,
Preferred over.
yeah, we have to move a bunch of that IV stuff up to the EMT section, right? As an STR, and then down in the paramedic, because that's the level that can get pushed those EPIs specifically. Mention that and the pacing down in the paramedic.
I think we can do that all post.
Yeah.
We can take care of that afterwards.
And do we still have, is there a reason that this advanced airway is listed as esophageal, which I don't recall seeing anywhere else? Glottic slash esophageal for advanced airway is indicated?
Yeah, we're just,
And just
airway, can we just
Advanced airway is
reference
indicated, yeah.
yeah, for airway algorithm?
Yeah.
Yeah.
Airway algorithm.
Yeah, and then just refer to airway guidelines.
Yeah.
And that whole section's gonna get EMT anyway at the end.
I know what you're getting at. So for the persistent, if we're putting in the blurb for the maintain hemodynamic stability up there, do we need the shock part down lower? Because won't that be included?
Yeah, I agree, remove that.
Say that again.
So we're already addressing hypotension, persistent hypotension above that. We will probably have to have the epi down there, but as far as, I don't think we need to restate that for persistent hypotension, we need that.
Oh, yeah, because that should come from up higher anyway. And we can just focus on whatever other specific things. And
Committed.
We added the what to do with bradycardia.
I don't think we have to.
I don't think we got into it, but that would be a bullet in the, right.
So, in the central Arizona one, which I think was trying to have people use the pressure, was basically saying, so I think, there's a rearrest section, which is resume chest compression, straight underlying rhythm, in PEA likely due to shock. So the question before rearrest, we add a bullet that says, if we want to be specific, that treats bradycardia and find a potential rearrest, initiate pressors.
We say in ours, we put, administer push dose epinephrine if heart rate and blood pressure downtrending or patient in shock.
you add into that comma avoid cardiac pacing and their hospital.
Yeah.
Can you read that again, Amber?
We just say prepare push dose epi, and monitor for shock, administer push dose epinephrine. We have it for 14 years or older because we don't have the push dose pressors for kids without medical direction. But we say administer push dose epinephrine if heart rate and blood pressure downtrending significantly or patient in shock.
And then avoid spacing, add that on. So administer push dose epi for blood pressure and heart rate downtrending or signs of shock, period. Avoid transcutaneous spacing, period. And that would be pure medic section only.
And you can either put, like, you have it split for shock and peds saying call for medical direction, or you can maybe put it in here, less than 14 years, call for medical direction.
We need to parenthetically say avoid pacing for bradycardia. Because I mentioned that if the EKG shows heart block, right, then I would, and they're ventricularly bradycardic, I would anticipate they would need pacing. Like an inferior STEMI.
In general, though.
So,
Right, but if they're an inferior STEMI, knock out their.
And should that be heart rate or BP downtrending?
yes. Yeah, I think the one concern is, having seen several cases where, EMS, the T bradycardia was dropped, and they started pacing, and then it would have missed that patient being in a re-arrest rhythm. So kind of missed first benefit of.
Sure. Thank you.
Just a question, so for, like, I think Central Arizona does have push dose epi for peds.
Yes.
With 14, I mean, is that gonna?
Well, any region can still delineate further. So the question is, what's the group's thoughts on having an age limit for push dose epi for?
And you just have it in the shock tier currently? No.
We have it in regular shock for push dose epi for peds. Yeah, so it's just as their standard to do push dose. So 10 mic boluses titrated to age just, yeah. Without medical direction, so that was the.
Yeah, but in the TPCC for shock, or TCC,
It's not in there? Yeah, that was the question.
Any other recommended changes to this one? Yes.
As opposed to, would this be push those pressures as opposed to starting infusion as the only option in the post-sterile state? You can have that for infusion.
I think most of the time, I mean, it doesn't really matter. I mean, we switched from an infusion to push dose just because we keep one or the other. I mean, most agencies don't have both. They would do one or the other. But
We pulled the data, when we finished the added push dose epi, we pulled the data on dopamine and epinephrine infusions for the state, so all comers over like a 2-year period. I think there were 5 epi drips over that time frame, and they were all air medical, assuming that there's no there. And the dopamine infusion rates were, for the entire state over 2 years, very low, like less than 100. And of those, we couldn't tell if they were even started, something that looked like the dose was 0 next to it, so that they maybe pulled it up and mixed it, but they used for a number of encounters very low.
Yeah, when we changed ours we didn't change ours to push dose epi for the past year. And last year, we changed our protocol to state that you must hang the dopamine for every post-ROS patient just because it never got used. Like literally never got used. And so we required them to hang it on every post-ROS patient and then open it if they got bradycardic. So we increased our use in our agencies significantly, but then decided to go to push dose this year just because of simplicity. To only have one pressure on board.
And then, as part of my ignorance with the avoiding transcutaneous pacing, I still have cardiologists tell me, it's like, oh, well, you can pace until the cath lab. Is there, can someone please just send the data my way so I can look at it myself too?
For post-rock?
Yeah.
Them to the cath.
Again, we have some interesting people, so I just want to make sure that I'm all on the same page.
I'm sorry, here's the question of data about not pacing.
Not pacing post-ROS.
It's because you miss rearrest, not because necessarily you can't do it, but the tendency is that they start pacing and they miss a rearrest. And so we don't want them to miss the rearrest by starting pacing, because they start pacing and then they forget about it. And so we treat preferentially with pressors for that reason. Just to say, it's a post-rock heart, you still need some sort of, you know, ionotropy to help the heart, even if they're bradycardic. So in that short term, we just don't want to risk the rearrest, which is 50% of patients that ROSC are going to rearrest. And so we start pacing all those, you're going to miss the rearrest in a whole bunch of patients. So that's, it's not, I think necessarily that it can't work. It's just.
No, I hear you. So I'm just trying to understand if there's something about that.
Functionally, the providers will miss rearrest.
And I think in the pre-hospital setting, that moving the ambulance, trying to like tell them to help stop it, because I think in this environment in the hospital, a little different. So, but that's true.
Also, you said your cardiologist take people to cath lab?
Yeah, yeah. Tell me more
Not
about
all
that.
of them. There is one. And you only work a few days a week.
All right, anything further on this one before we move on? All right, obvious and apparent death. I don't think there was any recommended edits to this one. The resuscitate advanced directive, I think the one thing we added was the, pre-hospital medical care directive. It should be slashed, either in parentheses or slashed, do not resuscitate for. So I think we added pre-hospital medical care directive because we realized that was not on there. We added that in.
That's the actual name of it.
That's the name of the form, yeah.
And the statute.
Yeah, so that's what we just, sorry, orange form should be added. Yeah, just pre-hospital medical care directive, yeah, slash do not resuscitate, order. And then that's it.
Is that gonna ultimately though be confusing? Because I hear people, they call in and they say DNR because it's just the name you use, and the pre-hospital medical care directive is a very special deal, and it's a DNR, but people throw the term DNR around for lots of different documents.
And the hospital folks don't know that the DNR is the orange form.
Right.
No. You don't think so?
No, I don't think so.
I'm doing something else.
I don't think they all do.
Orange is the new
Even the
one.
orange
Yeah.
form, we had nursing facilities a number of years ago trying to copy their advanced directives over onto an orange form and then try to get us to take it. We had to go out and do a bunch of education to get them to stop doing that, because there's a statute that says how the form is supposed to be designed when other healthcare directives don't have any prescription in statute. They were just trying to copy it over onto orange forms and make it work. And
I would leave it how you have it now.
Before, we didn't even list pre-hospital medical care directive, we just had a, DNR form. My concern would be if we take that out, I don't think most pre-hospital providers will know, they do not know it's pre-hospital medical care.
no, I wanted to take the do not resuscitate out.
But that's what they don't,
Right.
that's what,
But they don't.
yeah, that's what reason, that's what they call it, it's the orange DNR form.
Right.
They call it an orange form,
Same
or they
with
call
ours,
it,
yes.
Yeah.
they would never say the pre-hospital medical care directive.
I wonder if we ought to put orange form first in bold, because I think that's what many people call it, orange form, pre-hospital medical care directive, do not resuscitate. Shorter. That'd be my suggestion. And then I hate to do this, I've done it once before, but I want to go back when you say we can to reinsert consider naloxone. And I'm looking at a study by Favreau, and others here on naloxone. I was co-author too, so. And Dan Spate was too. So Dan, I know you're on the phone too. But, since all we're saying is consider, I'd say consider naloxone. I'm thinking of patients in a few too, Gail, but, our study says, you know, these patients do better. There's some data. It's just in the discussion. It's not great
Which
data.
guideline are we talking about?
This, really pretty one
Okay.
where we took out, naloxone. And even though I had the toxicologist said I agree. And we say, well, naloxone may play a role in positive outcomes, high quality TPR remains the foundation. So I just like to stick naloxone back in. Dan, any thoughts on that? Since you're a co-author too.
Well, first, let me state my conflict of interest. I'm a co-author on that paper. The question to me still remains is, so this is in cardiac arrest, right? We're going back to cardiac arrest.
Yeah, it's just we took out consider naloxone and then we put. I would suggest to put it back in. I don't know why we're given naloxone after arrest, because the reality is if we get ROS, essentially all of them have their airway, and if they're hypotensive, as you know, Narcan doesn't reverse the hypotensive effects of opiates and opioids, because those are a direct effect on the smooth muscle in the arterioles and the venials. It's not receptor mediated. So anything that, frankly, I'd be happy if we took all the drugs, including Epi off, because the first do no harm, we've left far behind. So anything that adds to their idea, but my concern about having Narcan on it is it's hard to get them to, if they come on scene and a person's arrested and it's apparent that it is an overdose, it's really hard for them to knock themselves off of the diagnosis, if you will, in quotes, of overdose, because now they are a cardiac arrest. They're 100% cardiac arrest. Why they arrested is completely inconsequential. Right.
So I like simplicity and getting rid of everything that we don't know works. And I would say in the setting of, if after you've arrested, I don't think Narcan is a part of the resuscitation personally. So in opposition to my paper,
and that's
I like taking it out. I like taking it out for simplicity, because we have zero evidence it helps.
And that's why I agreed, but I'm looking at this now and reconsidering. We definitely have people have much better outcomes that are overdose-related cardiac arrest, even though they have non-shockable rhythms initially that you'd anticipate. And I'm sure most of them got naloxone. And we raised the question here. We can't answer it in the paper, Dan, but I don't want to. I mean,
it sounds like this is something we can just roll with.
Yeah, I don't think. Yeah, I don't think it's going to cause. You know, I would just suggest leaving it in. And just
again, I reiterate Dan's important point, which is, you know, cognitive loading, focusing on what matters. It's one of the core principles of what drives our protocol design, and I think this falls squarely in line with that. It's keeping its removal. I think that there is I think that there is potential for harming certain patients because of this cognitive load issue, because of distraction and diagnostic anchoring. It's something that I see in our practice all the time. It comes up in CE and case reviews all the time, and it has been the case for my 15 years experience here. This comes up constantly, and it leads folks astray.
They're doing bad MICR because they're focused on naloxone.
Correct. Just as a practical matter, what do I see in the practice day to day?
I'll defer to the wisdom of the group, and Dan, I wanted to bring you in because you were a co-author on it too. So, okay, we'll leave it as it is.
All right. Next, non-traumatic termination resuscitation. Were there any recommended edits to this one?
Can I ask a super quick question on the last one that we just kind of skipped over, the DNR page? Do we have it through under the EMT section? We recommend comfort measures should still be offered. Are those defined anywhere as things that they're allowed to do? Should we like hyperlink to pain or something else, or is that just something we are leaving up for education? More of a general question.
It's a good question. I don't think we have covered that, and I don't know, I mean, it does say come from measures, what does that mean?
Yeah.
I don't know fundamentally that we've ever talked about, are we giving payment to the state population now? I see Josh shaking his head no.
Not in the EMT section, that's for sure.
It's a very deep, dark hole that I would recommend you keep neutral from this.
I need to just strike that.
I would support striking that too.
Yeah.
Actual measures.
It's very
It's just
vague.
ambiguous and it leads to more questions.
And it's a
We can't
dangerous
answer.
spot, right? Especially at the EMT level.
There is a line below that that says if there's a valid DNR and there are signs of life, EMS providers should provide standard appropriate treatment, which is the first line in the next box under existing protocols.
They do still recommend.
I don't know what, I think that's the better
If this
response.
is their guidelines, say that
It's
it's
like one of the measures will be offered, so that's.
Yeah.
forget, it does not say, the very low level evidence.
All right, next is the non-traumatic termination of resuscitation. Yes.
Down in, EMTI and paramedic, it says greater than 30-minute downtime and pulseless greater than 60 seconds. I think that's, I don't get what that means. I think that's probably supposed to be something else. Pulseless greater than 60 seconds. It seems like greater than 30-minute downtime, slash non-shockable rhythm PA assistally or
I think what it was trying to say was like, if one of these options, so like, if was greater than 30-minute downtime, or there's still pulses greater than 60 seconds, or non-shockable rhythm. I think that, I remember the conversation, so like, if you're checking a pulse, there's no pulse for 60 seconds, but they don't somehow need that. The point is.
Okay.
Is good, that it's unclear, probably just be stricken.
Yeah.
So we want to remove those.
No, before you delete it, let's just talk about.
I mean, I don't think those are necessarily bad to have those off ramps. It's just a phonetic, well, not phonetic, but like a verb, grammar thing that needs cleanup.
Maybe.
I'm still not following it. Yeah, I'm unclear about the pulseless for 60 seconds.
So you're checking for 60 seconds and there's no pulse during that, like no detectable pulse at all.
So, okay, so greater than 30 minutes downtime, no palpable pulse greater than 30 seconds, or non-shockable, or
The non-shockable.
and non-shockable. Should be and, shouldn't it? Really? Greater than 30-minute downtime, no palpable pulses greater than 60 seconds,
Kind of
maybe better than pulseless. I don't
think it's and.
I think what you really.
And then and non-shockable.
Yeah,
I think it's
get rid of the 60 seconds, right? You're fine, right? 30-minute downtime, pulseless, non-shockable rhythm.
Yeah.
You're dead.
Right.
Yeah, I'm fine with that.
The pulseless. This is,
Mike, I guess I have just a question about that. Is based on this phrasing, you're saying you got a patch and the family's saying they've been down for 2 hours and you show up, you feel no pulse, you're calling it based on this phrasing? Because like, you know, I'm sure you've all had the same discussions. Downtime does not equal death time. They may have died only 1 second before you arrived. So I'm a little uncomfortable with the way I'm reading it, and please correct me, English is my second language. Am I misunderstanding what's going on over there? Are we saying that right now we're telling paramedics, patient had a downtime of greater than 30 minutes and you don't feel a pulse, you can call it? Is that what that phrasing is
They're
saying?
non-shockable. And they're PE areas.
But this is termination of resuscitation, not dead on scene, correct?
Same thing.
Well,
Well, that's what I'm wondering here. Are we saying that don't even initiate resuscitation? Is that what that's saying then?
no, because you're doing all of your termination. This is saying like, if they don't meet your initial termination or resuscitation, and now you're keep going down here, it's in addition to the above termination.
Okay, no, thank you. And this is why I was getting confused by the phrasing here.
So in addition to the above criteria of termination, consider termination if greater than 30 minutes downtime, comma, pulseless, and then take off to 60 seconds. Pulseless, comma, and then non-shockable rhythm.
Or you've had 20 minutes of resuscitation and a witness arrest.
Because really, if you've got someone who's had no resuscitation for 30 minutes plus, prior to EMS getting there.
No, but, and to that point though, is we have individuals who say like, he's been down, but you touch him and have a pulse, right? So the idea of what does this downtime mean? I get the concept, you touch them, they're pulseless. This is one thing that we a lot of times teach is you don't know when they actually died, right? That's all you know is what you have at that moment. So again, if everyone feels differently, so be it, right? This is the beauty of this. We can have an overarching theme, then you can all do your own thing. I just wanted to make sure I understood what was phrased.
Yeah, I think the word downtime is what is a little,
Right.
it's very specific to our system, and we all assume downtime to mean time from loss of pulses to you got there.
No, for
So
sure.
you could rephrase this to be greater than 30 minutes of assumed pulseless cardiac arrest.
Yeah.
Yeah. But I think for this format, our providers know the term downtime very, and I don't think we need to change it unless the group feels like downtime is not a specific enough term.
Leave them in, there you go. Yeah.
Just looking at the document, though, you're telling the EMTs to initiate resuscitation. And in addition to the criteria for termination of resuscitation, doesn't mean that you're gonna run a resuscitation for 30 minutes. So to Eve's point, I think people could just say, hey, they meet these criteria, we're done.
Right.
Exactly.
Yeah.
Well, but this isn't a withholding.
Yeah, no, I.
It's termination. So you gotta meet this other stuff up here, right?
Well, it only says the EMT's got to do that.
No, because everything starts at the top and works its way down. So everybody starts at the top and works their way down to the appropriate level is the way it's designed. And that says that in the prelude,
Okay,
to this.
as long as they're doing that, that's fine.
We still have in here the terminology CCR and ICR, ACLS. We need to rehash that out. That's a
Yeah.
couple 4 rounds of chest compression.
So to kind of clarify, the paramedic person that we were just talking about, is it then greater than 30-minute downtime, 8 minutes of resuscitation, pulseless and non-shockable rhythm? Because that's assumed if we're following the EMT 4 rounds, right? If we're following kind of the order of this, they're doing 4 rounds, then considering TOR.
So there's another one down for patient people. I would make sure to do a word search for CPR and ICR. I'll make that thing to mention that. So to Philip's point, do we need to clarify under that bullet? It sounds like we're all kind of interpreting this differently, which is a good discussion that in the field, this is probably meaning different things to different people, so we need to clean it up. So what is our actual intent of that section? And if that intent is, we're not really sure, let's have it in my street.
So I think you could use that paramedic line for the EMTs and just replace TEA asystole with non-shock. That's how, I like the termination resuscitation. It's very complicated up above. I don't know why we would initiate CPR in someone who's been down for more than 30 minutes.
But that's how they use the central region, right?
But you don't know when they lost. You don't know when they lost.
Right, they may just be unconscious.
They may just be unconscious.
Hypoperfusion.
You gotta do the resuscitation. So here's my question. Because when you look at the BLS side on this termination and resuscitation, it's got 4 rounds of CPR, which is about 8 minutes. And then consider termination if the following criteria are met: not witness, no shockable, non-shock IED, and no ROS. But in that Canadian study where this information came from, it actually says 20 minutes.
This is not from Canadian studies, this is from all the data go back to 2006, and the national position statement, and confirmed by the Japanese.
Okay.
So it's the BLS termination resuscitation rule.
So I just want to make sure I'm following the logic here, because maybe I've gotten off the path. I'm an EMT. I show up on scene, and they've been down for 2 hours. But they don't have any of the obvious death criteria. Right? They're not triggered, they're not. Right. I have to start CPR on someone and do CPR for 8 minutes, then I can check a rhythm with my AED, and if it says not shockable, I can consider terminating.
No, they're doing the AED through those 8 minutes.
Right, yeah.
But if you were a paramedic, you'd have to do CPR for 30 minutes.
I wouldn't have to do CPR at all, because it's been down for 2 hours.
But it's in addition to the above criteria, and you don't know when they lost pulses in that 2 hours.
I would argue you do most of the time, right? But they were last seen 5 hours ago, and you found them on their floor. It was probably sometime 5 hours ago.
I think that's just kind of a very courageous thing, and I get where you're coming from, don't get me wrong, most of the time, sure, but it's, I don't know, we've definitely had cases where that's absolutely not the case, so that's why I'm a little reluctant.
Given the gravity of, we've been wrong. And I mean, we've all been confused, I mean, to quote Gail, you know, this is confusing to all of us.
So you would advocate, Josh, that a paramedic could start a resuscitation, but prior to concluding the first 8 minutes of CCR, they can make a decision?
We wouldn't start. So if you've been down to, this is how our guideline reads. If you haven't assumed we use prolonged downtime, 30 minutes, you do not initiate resuscitation. You check a rhythm and a pulse, and if they're pulseless and in PEA or asystole, you don't start resuscitation of the patient.
Does the rate of PEA make a difference?
In our trauma, yes. In our medical, no.
Again, I'm looking at the same study, and we had a higher likelihood of survival in non-shockable rhythm patients that were overdose patients than you would anticipate. So and you have to depend on the history too. How good is the history from the people you're getting at? Well, they've been down for this long, or they've been down for that long.
I don't know, we have great outcomes in others. So I don't think
But
we're killing people.
But I'm not there. I'm not saying you are.
I know.
I'm not saying you are. I'm happy living in that system and working in that system. But they're coming for you. Yeah, but I mean, we're talking about 8 additional minutes.
Well, so, and here's, I have no problem with a medic or an EMT starting resuscitation, but if they've been down for 2 to 3 hours, why?
I guess the problem is, what does down for 2 to 3 hours actually mean? I think is that the spirit of what you're getting at?
Sure, yeah. Like, I get what your words are saying, you know, like I think we're just interpreting the definition of one word differently here. And if people are coming
so this is Dan. This is Dan. Could I interject something here? I wonder. I'm thinking. The reality is, I think almost everyone uses the unwitnessed arrest branch point operationally as they've been down a long time, right? Because there would be very few systems in Arizona where, first of all, there's going to be very few arrests where a person literally says, well, you know, they stopped breathing 30 minutes ago, but then I waited for about 20 minutes to call 911. And you guys got here 10 minutes later, so they've been down 30 minutes, right? That's not how we determine downtime of, say, 30 minutes or greater. The reality is if they're witnessed, we have a decent estimate. And if they're witnessed, we essentially always work them unless we couldn't get to them for a half an hour, which is truly rare. So we're talking about almost all unwitnessed arrests here, right? If we estimate greater than 30 minutes, probably the person found them not breathing. And the reality is, if you look at our data, again, now like 40,000 cases, it is incredibly rare for an unwitnessed cardiac arrest to go home alive, neurologically intact from the hospital. It's just incredibly rare. So if there's heartburn over this, should we use that branch point? Because I think greater than 30 minutes is frankly just a surrogate for the patient was found down. And when patients are found down already, we don't save them. So that's a possibility if there's angst about the concept of the 30 minutes and when the pulse went away.
Let's do it.
Are we not also seeing other signs on the patient themselves that they could be down longer than that? I mean, pulling, rigor, things like that we should be evaluating.
Those are notoriously bad. Yeah, those are notoriously bad. For instance, you can find lividity, in patients in the ICU who've been in shock, right? So those are notoriously bad. It seems to me what we're talking about here, because if the wife, typically, what is it? It's a relatively middle-aged or elderly man. Wife finds them at home down. If the wife sees them collapse, we work them, right? Because they see them collapse, somebody calls 911, and we get there within 15 minutes, and we work them. It seems to me we're talking about unwitnessed arrest, and the world literature and our literature shows we don't save unwitnessed arrest. We just don't. So I don't know, that I wouldn't argue about that at all. If you meet those criteria, down, unwitnessed arrest, pulseless, and non-shockable rhythm, we're not going to save them. We just don't.
Okay, so then building on what Dr. Spade is pointing out, then I propose using that entire bullet point and simply moving it up in the EMT box before the perform 4 rounds then? Would that?
But that should go to withholding resuscitation and get that criteria defined in there, wouldn't it?
It does. But I mean, looking at it just from this page and thinking about it as far as the easiest editing, I'm trying to capture what the U of A contingent is saying. But then
we shouldn't reference this down here then, or up here if it's unwitnessed. Because we're not terminating resuscitation because we haven't started it. To me, it seems if we're going to take that criteria and withhold resuscitation, we should take that criteria and put it that way, regardless, outside of rigor mortis and lividity and asystole and more than one lead, blah, blah, blah. We move that criteria to it, and that becomes withholding resuscitation rather than termination.
Okay. And I think the way that we've got it down south is we have this under our dead on scene, which we don't have in our death criteria here. We have a non-traumatic unwitnessed arrest, prolonged downtime, PEA, or asystole.
And you have that in your withholding resuscitation.
It's already on our dead on scene.
Rather than termination of.
But we have a reference up above in the exclusion, obvious apparent death, so we can add that.
Right, that's exactly my point. So if we want to do that, we would add it through the obvious apparent death criteria, prolonged downtime, PA or asystole, and then we solve it.
But then how do we edit this page, which is I already started, what's my off ramp?
So I think then you put it under wherever, if at any time you suspect prolonged downtime, have a PA or asystole and pulseless, may withdraw resuscitation.
We don't make that distinction just because, if you get more evidence that puts them in a different category, we just say, once you've gotten that evidence, then you can stop. That we don't state explicitly, but, right?
Again, I'm looking at this paper out of this Bureau of EMS, and at least in the drug-related deaths, about almost 1,000 out of about 28,000. 3/4 weren't witnessed. Shockable rhythm was only 7%, and about 19% survived, almost 1 out of 5. So I hear what you're saying, Dan, when you look at 40,000 all-comers cardiac arrest, but this is an exceptional area. So I would say, we can parse this however we want, but I would not just say 30 minutes of downtime based on what even others are saying too. To not start resuscitation.
I would say we do not touch anything that considers termination resuscitation. That is standard, very national verbatim. I think the heartache where people are having some confusion, let's just go back to the bottom of the guideline, because it sounds like that's the section that people are interpreting differently that we need to address. So rather than trying to reword things that are based on very standardized international data, let's just look at the part that people are having some heartache with, which is the last 2 bullets on that page. and see what we need to do those two bullets. And do cross your eyes. So, does anyone have any, so let's look at the bottom bullet. Does the bottom bullet make sense to everyone? 'Cause that might be, so in addition to the above, consider if.
So that means you've done 30 minutes of CPR, or no, I'm sorry, they've just been down for 30 minutes.
No. So this is or, the bottom bullet. We're only with the bottom bullet right now. So this is someone you've done 8 minutes on.
Oh, okay.
But just say they had one shock of a rhythm or they were witnessed, but now you have like 20 minutes for resuscitation. They're no longer shock or rhythm.
I think it can be simplified. Witnessed arrest, 20 minutes of resuscitation, end title less than 10, non-shockable rhythm.
You just get rid of the second bullet above the last bullet?
Yeah, get rid of the, after 20 minutes of resuscitation, get rid of with PEA. Replace that with a comma. And then and remove the and.
Oh, you don't want the and on there on top?
I do comma there and then and after the end title.
Yep.
And then comma, and non-shockable rhythm?
Right.
Yeah, I'm good with that. And then get rid of the bullet above it?
Well,
oh, I see, and then you can pick up the and
before the end title. Yeah.
Are you saying get rid of the bullet above it? That's causing everybody pain, Philip?
I think that would maybe just.
I think that would really.
Really what we're talking about, if for whatever reason you're doing resuscitation.
And you can still have it in your, not you should start resuscitation protocol in itself, right?
We don't use this.
No, and I understand.
So let me just throw this out.
And
I'm happy to share my entire 1 hour lecture I put together on this topic with anyone who wants to know. If you do this, which is 8 minutes, there's no evidence behind 8 minutes. If you look at the time cutoffs for survival, you don't get 0% survival until you do 30 minutes of CPR.
Are you looking at the Japan study one?
This is, I have to pull out
No,
the
no worries.
slide,
I was just
but,
curious.
a random 8 minutes doesn't help. You have to decide when you're going to start CPR and when you're not going to start CPR. That's the question. And this guideline, as currently written, does not address that question. It says you start CPR in everybody who does not have a rigor mortis or lividity.
So, but again, we can, so with the term apparent death, we could, I mean, that seems fluid enough to be able to get to what you're talking about on a separate page. Because there's obvious, which are the physiologic signs of decay, and then there's apparent, which could be the more dynamic wording, shall we say, and then we can get into the nitty-gritty of what you're talking about on that protocol.
So adding to the obvious healthcare test protocol.
Yeah, that's what Philip was suggesting, which works for me. Yeah.
I agree with that. And then it becomes a training piece, because at least here in Central Arizona, this is the thing that cheese me.
All right, so we're going to take, so just to clarify this one, and then we will go back to the obvious apparent death one. And then, yeah, we did. So the only thing we're changing is the very bottom. We're taking off the one bullet, and we're clarifying witness arrest, greater than 20 minutes for resuscitation, and Title II to less than 10, and non-hospital. Does that make sense? So,
you want to say 30 minutes there, Joe?
No.
So this is, for some reason, you're on scene, and it's going to be hard to get the patient moved, you're resuscitating them, and you've been working them for 25 minutes, but it's going to be, you're taking them down 4 flights of stairs, and you don't have any, mechanical people, or like giving people instead of 45-minute transport to the hospital.
So how we handle this with our agency is once you start CPR, you continue CPR for 20 minutes. At the end of 20 minutes, you get an end-tidal CO2, and if their end-tidal CO2 is less than 20 and they're in PDA or systemically, you can terminate. If at any point in that resuscitation, you determine the patient has the obvious death criteria, you just stop mid, right? So if I've done 2 minutes of CPR and the wife comes back and says, oh, you know what, I heard them hit the floor an hour and a half ago. I just didn't go in to check on them until now, and I was panicking when you got here. And so that's been down for an hour and a half. And if they're in asystole at that point, we don't do anything else. So that's how we manage it. So the 30 minutes is and I don't advocate for doing anything for 30 minutes. That's a lot of CPR to mandate people doing. Like, if you want 100% success, that's 29.9 minutes is the time.
All right, so any heartache with this before we adjust the, does this make sense of what you're saying? Does it say, like, if they've done this, whatever reason they were doing, 20-minute mark, still happens on the rod? That at least gives them an opportunity.
We use an entitle of 20. I don't know if that matters.
I think we can use it in, yeah, we don't, our entitles are within about the delta 20, 25, the line number.
Sorry, is that a 10 or 20 for both?
Whoever gets one, that's
20.
Well, I think, you know, that 10 is from some stuff that came out a number of years ago. And I think one of the things is that it excludes really high quality CPR systems, because we routinely have patients in PDA and asystole for 25 plus minutes and still have entitled CO2s of 25 and are, you know, are dead. So.
But that's during compressions, right? So
During
compressions,
during
you're
compressions.
using entitled CO2 as a surrogate marker of perfusion.
Right.
And so, yes, while you're perfusing the patient, you're gonna get perfusion markers that show that you're perfusing them. It's when you stop compression and look at what the entitled CO2 is to see if it's, are they generating perfusion to generate an entitled CO2, or are they not? Because I don't think that during compressions, you can say that your entitled is whatever, you know, like, yes, while you're doing compressions, you should have an entitled greater than 20. You absolutely should. It's when you stop compressions and you look to see if their PEA rhythm is actually generating pseudo perfusion or
Just clarify that then.
I don't know.
Yeah, our protocols have a different and termination for PEA versus asystole. PEA, we need an entitle. Asystole, it doesn't matter what their entitle is. So they can have a higher entitle.
Yeah, I don't care what your entitle is.
Right.
You have no.
If you've done anything else in the process.
We need to, let's get the meeting back up. We are now 2 hours, 2.5 hours in our schedule. So all joking aside, we really do need to get this done today. So, we're getting into a lot of like weeds and philosophical stuff. So there's good things one way or the other, where someone says, let's put out verbiage. So we need a definitive verbiage. So if we want the platform with yes or no, so we need to clarify. I see a yes on this.
I think the way it's phrased looks great and appropriate in this case.
Okay, love it.
We just need to put the 20 entitled CO2 back in.
Yeah, it's in there.
Well, she removed entitled CO2.
No,
There was that is
And that's
20.
Okay, I'm sorry. Yeah.
All right, so now we need to go back to the obvious and apparent stuff, because there was a question. No, it's not. We already did it.
Because we breezed through it.
So we need to just clarify then, because that is to Josh's point of kind of figuring out who we start with the station on. So we have we need to, it looks like, add something in here.
Above the decapitation grouping.
Yes. So if you have verbiage that you use that you'd like to recommend, that we could try putting in there.
So I would recommend presumed pulseless time of greater than 30 minutes. Non-shockable rhythm. Pulseless on evaluation.
And then so presumed pulseless time greater than 30 minutes, non-shockable rhythm.
And maybe to reorder, currently pulseless, comma, presumed pulseless time greater than 30 minutes, comma, or and non-shockable.
And then the assumption is no resuscitation indicated. Right. And then are we saying we do or do not want cardiac monitor? So I think that was one of the things.
You have to put one on there to figure out if they're shocked or not.
Well, non-shockable for EMTs or PEA assistance.
What about, unwitnessed?
Doesn't matter. You're doing your best guess, and this is why we don't put in 30 minutes, because we realize you don't actually know. To your guys' point from flight staff, right? You don't actually know.
I mean, we routinely start resuscitations on folks with that are unwitnessed, and who knows how long they were down for, but if there's like a definite indication this person's been down a very long time, but they don't quite meet the criteria, but they're pulseless and they're apneic and they have no rhythm on the monitor, then we don't make them start 8 minutes of CPR on those.
No, I agree. And I think
But if there's not a great indication that they've been down a long, long time, they start resuscitations on those.
and to your point, this is like my main quote unquote gripe about it, right? Like, if you have a good, like this is, you know, we all have these lectures we teach our medics and so forth. Common sense sounds obvious, very difficult, right? So if it's obviously they've been dead for days, sure, one thing. But it's like, right, we'll just use our example. We all have a lot of people on the reservation, and they're like, my cousin uncle's been down for 3 hours. I haven't checked on him, but he was just on a binge. For us, that is not a pulseless time of 3 hours. So I totally hear what you guys are saying. So when we're saying like, your verbiage is also a little bit different too, saying, right, we have a good account that patient's been pulseless for 30 minutes. Oh, heck yeah, totally support like that kind of decision making. For me, I'm just, I have like, I know it's an entirely emotional response. So part of me, right, going and saying downtime for X time, I hate that phrasing of downtime, just because we've seen that really work terribly. And so that's what, I get what you're coming from. That's where I'm coming from.
Do we want and in there somewhere?
No resuscitation is redundant there also, since this is a no resuscitation guideline.
I think we should still clarify though.
I think that could go under bullet point or subheading whatever 2 for these conditions. Documentation of pulseless and apneic state is required, and then just move that.
That was going to be my suggestion too. Thank you.
No resuscitation required, and then all of those bullets
Glad
on
you supported
feedback.
this.
Yeah, so like it would be one of the dependent validity, rigor mortis, injuries and survival.
It would be the last bullet. It would be the last additional bullet under there.
Do you see what I mean?
I don't think it'd be the last bullet. I think it'd be the first bullet about all 3 of those sections then, right? 'Cause
Sure,
we're saying-
or that one, yeah.
You can.
Otherwise, people are gonna go, I'm not going down to deck, what do I do with
Fine.
this category?
Sure.
So go back to what you said. So it's the no resuscitation indicated, colon. And then we've got 1, 2, 3 options, but not right now. I would say these are, you already say that in the top. So-
Yeah, no, I think what Philip is saying is, for these conditions, documentation of pulseless and apneic state is required. And then you want it under there, right, Philip?
Yeah.
So it'll be below the second underlined portion, Shelley. Yeah, there you go. There, that's it.
Oh, tuck it all in there?
Yep, yeah, because you've documented their pulseless and apneic already.
Got it. That makes sense.
So if you want to put it somewhere, that would be Philip's nice finish.
I don't know what's going on here, and I totally lost.
I wouldn't put it down
Yeah,
there.
let's go back up, because we're missing some stuff typed above, so.
So I would delete the no resuscitation indicated, both of those,
Yeah.
and then just copy.
Yeah, I mean, I'm
pulseless,
quoting a paper from
pulseless
this.
time, all that sentence right
No,
there.
and, no, I know where it
No, no,
Right, that whole line,
I grew up in
just
Dakota.
cut that away, and paste it down, and put it in there.
No, I'm totally there. And if you were going to say hypothermia.
There we go.
Yeah.
And then you can remove the no resuscitation indicated from the.
You already said at the top.
Yeah,
Sure.
Right there, clean all that up.
yeah, you can just delete those 3 and all that.
And it was a triage.
I know.
No, you don't need it, it's already in the top, that's what.
Hypothermia, trauma, and intoxication concurrently, right?
Okay, so let's take a look at this, written version.
we're good with no, online medical direction, right?
We don't, unless, of course, they don't meet these criteria, then they can call us.
Or they feel uncomfortable for some reason or whatever.
Might be family assistance or.
The family just.
Just transport them. Yeah.
All right, any further discussion on that one?
I think that was worth debate. I think that really adds a lot of quality to the document. Thank you.
All right, any further discussion on the resuscitation section?
And then it would be non-shockable rhythm. It's lunchtime.
Any further discussion on the resuscitation section? All right, TMD vote, anyone opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
All right, NBC vote, anyone opposed, please say nay. Any abstentions? All those in favor say aye. All right, food is here. What's the group thought that we take maybe 10 minutes if people use the bathroom, get food, and then we work through lunch here? So I'm kind of good. For those of you online, welcome to, we will be back after running by
There's so much talking in the room, we weren't able to hear the announcement about when we're supposed to come back on.
12:15. Thank you for clarifying. We'll put it in the chat
All right.
as well.
See you at 12:15.
Thank you.
I took. Invested.
All right, grab food. Someone's gonna break in.
Right. Long time no see.
Yeah.
Except we're on campus or something.
Yeah, no, it's with the TMB.
started here.
I love you. I know.
Mic is back on, just so everyone is aware. We are going to go now to the cardiac section. We will pull that up and you will see the recommended edits in red as soon as people flag clock break.
So I did this section, the edits in red. The big one that I think warrants attention is the inclusion criteria. I just felt like a lot of this gets lost in teaching. It's just consistently taught, and I wanted to make it a little closer to what's listed explicitly in the ASEMSO guidelines. Everything else I think is pretty non-controversial. I wanted to add some hyperlinks to the EMT section of importance. And then again, ASEMSO makes it a point of actually addressing the classic teaching of location of infarct and nitroglycerin concerns.
And we need to do for equal like we did for pulmonary edema. So we need to go antihypertensive medication, EG or whatever we did before on the other one when the pulmonary hypertensive medication was. Just to keep it uniform.
Like the EG, for example.
Whatever, yeah, but for the other one. I think we're shattering, but.
I like that broader inclusion criteria, and those atypical signs are often ignored or forgotten, so.
I agree with you, Matt, and Chronicle. The only suggestion I'd have would be E period, G period, comma, arm, jaw, epigastrum. This could be other places, and like interscapular, upper back, you know, some people think upper back, chest, some people don't. And the same would be for sympathomimetics, cocaine, for example, cocaine, amphetamine. There are others too. And it's not just methamphetamine. Methamphetamine would be a very specific amphetamine. So I just say amphetamines plural.
Especially now with more party drugs going on, so.
Yeah, exactly. Have any party drugs up there at ADU?
No.
They're very studious.
That's only one.
So specifically, we're recommending to loosen up the verbiage with the anatomy.
Yep, EG, period, comma, and you don't have to put in any other thing. But I don't want it exclusive. You know, if other people think we ought to say back, that's fine.
And then in front of cocaine, same thing, and then remove meth.
Yep, exactly, perfect. Thank you.
And then we had the medication, under caution, hypertension.
And we have that in 2 places.
Yes.
We need it in 2 places, put it in one place or the other, either put it down with the nitroglycerin and take it out up above. Because EMTs don't give nitroglycerin, or take it out from down below in the AMT section. Just taking up room.
Just keep it in the AMT section.
Yeah, and then if we take it out up there, then everything could get moved up.
That makes sense. So we just remove it from the top box
Yeah, that's fine.
and just keep it in AMT. And within part of the medication names, we'll just put EG for both.
Yep, for the sildenafil and tadalafil, and I'd also say maybe EG for the other 2, the other pulmonary meds too, and they're already are.
And then I'll have another comment at the AMT level. It says for STEMI, consider treating chest pain unresponsive to nitrates, and it has morphine. And then down below there it says morphine should be used with caution in unstable angina and non-STEMI. I guess my question is, how do AEMTs know that? Because they don't do ECG interpretation. So they're either given nitro and morphine if it doesn't resolve, that we just have to decide that morphine is appropriate for them at that level or not. It is in their scope of practice, but they're not going to know about STEMI or non-STEMI and so on without 12-lead interpretation skills.
Move that down to the ADHS paramedic then.
And then remove any opioids.
Yeah. Because if they're not able to interpret this, I think it was the wrong patient population.
That's true.
I like that Gail's viewpoint on that.
Usually that whole for studies only.
That thing will get moved down, including, there's a missing bullet that gets deleted somewhere. But in the morning section, there was another bullet under that. Oh, it got moved, okay. Back another one. Another one. Okay, so that whole study section, including that.
Yeah.
That whole section.
And then just to clarify, we're fixing the 12-lead terminology up there for you people.
Anything else on that one?
So we need to massage this. So, and we will get something above morphine under the 4-STEMI only. I would delete that. That's redundant now. So then, and I apologize when I said delete that, probably what we should do is keep that. Here, I have it right here. You're going to just keep take away the 4-STEMI only.
They're taking it out of that.
Only other suggestion is change nitrates under paramedics to nitroglycerin. We've only got the one.
And then the indentation and fentanyl and morphine should match.
Go back to the lab. Out of order, out of order. All right. Any further edits to this one? There are none, we'll go into the next guideline. Question that's in here is a discussion of the bradycardia. Let's hold on a little bit.
question on this one is about IV fluid boluses under AEMT for bradycardia. That's not in the discussion guidelines. It's immediate here. So it does seem like, especially if you've got an elderly cardiac patient with fast heart, probably not give the treatment that they need. Everyone give us a lead in that. We've got the updated dosing falling down for the atropine. Should we switch the order of push dose, epi and epi drip?
I think you're much likely, it's much faster to start a push dose than it is to take an epi drip. So
I think your mind categorizes it 1, 2, 3.
Yeah.
So.
I'm gonna say 4 between us, so flip the order and add the 4.
I would push before drip.
Yeah.
So pushes get you where you want, drips keep you where you want.
Yeah.
And then we had moved away from the use of the term sedation and had gone to pharmacologic management. I would imagine it's for the national guidelines, so should we take out sedation? I thought we meant for that, or we must have missed it in this one and change sedation to pharmacologic management. The other thing to consider, do we want to consider fentanyl as an option, especially from a hypertensive? As an option for pharmacologic management, we have midazolam or lorazepam.
We're changing sedation to the term of.
The pharmacologic management.
Yeah, absolutely. Good with that.
Yeah,
Could you just change the pain management guidelines?
yeah, we do have pain management, yeah.
Yeah.
Can you just reference pain management guidelines?
Yeah, the pain management, I think, does not have midazolam or lorazepam.
Right, I'm just saying,
Oh.
your bullet down there is midazolam, lorazepam, comma, pain management guidelines.
Or refer to pain management. That's the third bullet, right?
Yeah,
Yeah.
refer to.
As a new third bullet.
Yeah. And that could be on both sides, adult and
I guess you have that already. The pacing is performed, consider sedation or pain control for management of acute pain.
oh, we do have it there, yeah. Yep.
Yeah.
Those are helpful.
I guess you could then delete that line or whichever, wherever you want to put it ultimately.
So, yeah, and then it's just, there's the sedation for project management.
So, same thing for utilize end-tidal CO2 is available for all patients receiving pharmacological.
Oh, no, my question on that is, do we keep the words if available, or is that now universally available? Can that be assumed that it's available in all regions?
No. No. Yeah, and several probably old cardiac monitors that don't.
And so then the SEMSO is pharmacologic management, a very vague general term.
Kind of the update that came out of kind of the NHMSP, the SEMSO was getting away from sedation.
Just because of the anesthesiology, procedural sedation thing. Can we just say benzodiazepines instead of pharmacological management? Because pain controls pharmacological management too. Or we can go along with the general vagueness.
I think we had tried to put in other areas pharmacologic management, so I think we just, it got missed on this one somehow.
Yeah.
So we'll make sure we word search. Yeah.
many people using Valium or diazepam? Like, just out of curiosity, yeah.
It's on the list. I don't know if you can even get it.
Well, I don't either, that's why.
I don't know if you can, it was like backward, and I don't know how much it ever came out again.
Yeah, that's what I was curious. I'm not using it, I was just curious if there was somebody else outside of groups that would need it.
Any other thoughts from bradycardia?
Oh, yes. Did we cast the titrate to math greater than 65 without the addition of SBP? I think we got that somewhere else earlier on, SB or SBP greater than whatever, 90.
So then more, Shelley. So then the pediatric wording should be, for age appropriate.
For age appropriate.
So that propagates throughout all the documents as you suggested initially.
P5, scale age. For bradycardia, they do have, and some stuff does have transcutaneous limiting patients perform considered sedation or control. That's something the timing of when this got published versus the national state. Okay, this came out, that changed over. I've got the blood pressure parameters on my so. Okay, so it's gonna be titrate to MAP greater than 65 or solid blood pressure greater than 90. On the adult side, and P side is titrate to MAP greater than 65 or age appropriate BP. All right, anything else for bradycardia? All right, next up for implantable ventricular assist devices.
I like it.
Yeah. Same. That's a straight across, include everything in red then? Yeah.
I will say, there's no perform 12 leaf there, it's much higher.
Yeah, so we probably say
Comprehensive meetings to do all this with us.
Well, there's what now?
Don't worry, it's all taken care of.
Philip likes to think it's all right.
Then we have to don't happy with them too. The total artificial heart. I think these are.
that's good too, as well.
All right, next, tachycardia.
So again, this is my edit. If I could have just a moment of your time to kind of lay out some of what's been my guiding principle on this. So for me, this has also been an area that's come up a lot during quality management processes over 15 years of working with EMS professionals. I think that there's a discrepancy with what shows up in AHA guidelines and what generally has come across as expert consensus, especially with what's taught to emergency physicians over time. But it really comes down to this question of regular wide complex tachycardias in patients who are stable. And I'm going to borrow from something that Dan Spade said over the phone here a minute ago with epinephrine, which is this, a couple of guiding principles of, what are we doing that actually makes a clinical difference, especially when it comes down to there not being a good science-based consensus on this. So when it comes down, the question in front of the paramedic is coming down to trying to differentiate VT versus some kind of SVT with aberrancy. Of the very complicated algorithms that exist for emergency providers and cardiologists, even the best of these differentiators are quoted to be 90% sensitive, which means that there's a 10% chance of error. Another major pitfall is using clinical information such as assumptions about age, whether or not you know the patient has coronary artery disease. Here, the U of A protocol talks about, whether there's a history of prior conversion with adenosine. These are known to be unreliable based on available research. And then also instability in these cases is extremely subjective and is also pretty reliant on a lot of substantial clinical experience which not every paramedic has. There's also a toxicology differential diagnosis in these entities such as sodium channel poisoning, hyperkalemia. And then even if you don't buy into any of those arguments in terms of what role adenosine plays for these patients, adenosine is a trigger for misdiagnosis and diagnostic anchoring. There are VT entities that respond to adenosine. This can lead up to some anchoring and some misdisposition once the patient arrives at the emergency department. This is more often true in younger patients and misleads the treatment team at the hospital. It adds diagnostic confusion to what is essentially a deadly disease in VTAC. And it's akin to, Amalma 2 describes this as sort of being exactly like why we don't rely on GI cocktails to make a difference with chest pain. So my argument is it should be removed. We're talking about a patient who's being identified as stable. Why are we applying a medication that has potential to harm to a patient that is not undergoing harm at that time? Electricity has a safer profile in patients who are deemed unstable, so there's an alternate and safer treatment choice. So my advocacy here is to have it removed. I think it lives up to the guiding principle of simplifying for paramedics in a disease entity that's traditionally been tough to teach and tough to manage from a quality perspective. And so that's why I advocate its removal. I understand that it's on the CENSO, just like it's on AAC and the AHA, but I think this is where a practical approach warrants priority. And if that's not suitable to this audience, then at the very least on the left-hand side, it should be third line below amiodarone and lidocaine. But I strongly advocate that this group approve removing it on both sides of the line for all age groups.
I'm fine with that.
So let me just clarify for a second. We're talking about the red strike through here?
Yes.
Oh,
Not one for students, yeah.
So
That's what I was doing.
eliminating the guideline,
Okay, still there, okay.
eliminating the guideline, I would be hesitant to do, but striking through the strike through totally support.
Yep, sounds good. And then should we add EKG to the EMTs at the top?
Acquire and
Acquire and transmit. Acquire and transmit. Just because it's not under the standard.
Although I would say, what do they do with that? We're talking about paramedic treatment intervention. There's not a single EMT treatment intervention.
True. Okay. Would you like to know at the hospital that it's coming?
If they're an EMT only unit, they're not going to be able to transmit it.
Well, actually, I think, let me offer a counter example. Our Sonoya Elgin group has EMTs get 12 leads, send them to us, and then we make the decision to fly or not.
Yes.
They have to,
So-
okay.
Yeah, and if they can transmit, and then the other thing is, if they're having this arrhythmia and you capture it in the EKG and then they convert en route, by the time they get there, now they're at normal sinus. You don't know what the original one was. Yeah.
Okay, we'll add the EKG, acquire and transmit to the EMT section. And then this was something we added in the central region as kind of a hyperlink. Because what we were finding is the paramedics' interpretation of what cardio verse versus what we in the hospital cardio verse is very different. And so we created it kind of makes people think about like, we cardio very little clinical tachycardic equivalence in the ED. We're usually kind of looking for the underlying source or the medication. So just having chest pain, calling that a reason to shop for them. So this is something being added in central region. I would stop by for that.
And where it would appear is here, if you go back to the original protocol page, all unstable tachycardias, the word unstable becomes a hyperlink and takes you to this page. I like that. Especially for like AFibs, where the AFib is a compensatory mechanism and something you yank it away from the patient. sepsis, AFib, that sort of stuff.
Do you wanna, for low systolic blood pressure, do you wanna say low systolic or blood pressure or MAP?
Sure.
Since we've got MAP, that's systolic also. And do you wanna specify them or not? Like we have
Blood pressure less than 90 for MAP,
just to be self-consistent.
Yeah.
All right, so just to confirm, on the packet party, we've deleted adenosine. We're adding ECG acquire and transmit to the EMT box, and then we're adding in the stoplight, low systolic blood pressure, or MAP less than 65.
Yeah, or systolic blood pressure less than 90 and MAP less than 65, whatever we've done everywhere else.
Got it. Systolic BP or, okay. And then why don't we, since that is the last of the actual cardiac section, why don't we vote on those, and then we'll just do the separate informed consent, which is for that one. So, Dr. Grauski,
This is Dan Spate. On the question of MAP, why are we entering mean arterial pressure at all? There's no pre-hospital data whatsoever. It requires a calculation. It's only estimated. We're never talking here people with art lines. It gives us two numbers to remember. You have to rely on the machine. You can't get one with palpable blood pressure, et cetera. So, and some of that's driven from the TBI. Now that we have found in the Arizona data that, amazingly enough, in 20,000 patients, there's essentially perfect unison between the predictive value for mortality with systolic and the mean arterial pressure. If you put the XY plots over each other of sensitivity, specificity, they're incredibly tight confidence intervals, and the lines look identical. So, is there any reason not to simplify to just do systolic blood pressure?
So, Dr. Spade, this is Franco here. So I did a look through when I did a trauma update from my agencies on automated blood pressure measurements with our cardiac monitors. And what I found was that the mean arterial pressure accuracy is even higher than the systolic blood pressures, which are often extrapolated with how the oscillatory automatic blood pressure cuffs operate. And so, and not only that, but the trauma side of vital sign management is leaning more on things like shock index and mean arterial pressures. And so, but the way the oscillatory machines measure blood pressure, the point of maximal oscillations that corresponds to a MAP almost as accurately as an ARD line. But the systolic blood pressures are almost completely extrapolated.
Yeah, I still don't understand why we go with the two. I mean, notwithstanding that, I just don't. I think it's just more numbers to remember. But in any case, I'll if nobody else cares, I'll leave it alone.
I mean, nowadays with the monitors, it's given to you. It doesn't require calculation.
Right.
So.
And it's an or, right? We're saying this or that.
Yeah, but otherwise, when you look at the oscillatory machines, the systolic blood pressure point of all of those parameters is the least accurate of everything that the machine is telling you.
All right, so we're going to keep going here. So we need to vote with cardiac section. So any PMD vote first. Anyone opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
MDC vote. Any opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
We will next do separately the informed consent on treatment of transport. This is just kind of the new refusal guideline, the new naming it. So one thing to consider by certain people who are searching for this, they have asked to add refusal into the title. They said it's really hard when there's they're looking for this actual guideline to look for it when it's not labeled as such. So since we already have like the flashes in there, can we add a flash for refusal? And I think there was just a highlighted shade, addition, just clarifying what is in the statute already. And those, I think those are the only changes, correct? Correct. Any further discussion on that?
What was the point about the highlight here?
Just that was added in.
Okay, thank you.
P&D votes, anyone opposed to the updated document, say nay. Any abstentions? All those in favor say aye.
Aye.
NBC votes, anyone opposed say nay. Any abstentions? All those in favor say aye. I don't know how you're doing time-wise, we can switch.
I got the rest of the day.
Okay, perfect. I just
I mean, you ready to slow things down a little bit?
So we have lots of debate, a lot of our section that previously.
Yeah.
And so we got way off task, and hopefully we had kind of got ourselves back on track. We will do pediatric only one. So I think this is,
Airway stuff can move, can we move it? Does it need to be intermittent? All the yellow minutes.
So looking at that, the advanced airway would only apply for MPI and paramedic. The other three bullets would actually apply to all of them. So we should make it possible for severe respiratory distress to refer to airways.
You could do supraglottic for an advanced unless you're considering if you want to break them out as far as ED2 versus supraglottic.
So one of the things that we could do is initiate universal care, and I think we use the terminology refer to airway management as indicated at the top, and that kind of accomplishes a lot of that.
And then there was one piece with that about, so, and then keeping the paramedic hypolonasal cannula would be the only piece of advanced airway stuff there.
You move the airway, you move the basically out.
And then we talked about, we got the 2 to 5 on the epi on here. The SEMSO's 5 for nebulized.
Yeah, the 5 in the other protocol.
So we changed it to 5 on the other protocol, so do we want to keep it just 5? Right?
Yeah.
Under epinephrine, and under AMT, instead of doing 2 to 5 and milligram or 2 to 5 mL, we're just going to do 5 milligram, 5 mL.
And that's it, so we're included anyway.
And then at the bottom, do you want to keep the airway should be managed in the least invasive way possible? Should we do that, pull it up?
You've already got it up higher, don't you? It's already up higher, right, in the EMT section?
It wasn't unless it got moved.
Or no, I thought we moved it.
Yeah, no, but
I think you got deleted off of this. I want to make sure that we are moving, not deleting.
It is in your airway management protocol.
Yeah.
You need to say that.
I think it was stressed in it just because they wanted to make sure that they weren't progressing it along without, like, just more of a reminder of please don't do this if you don't need to.
So we can do away with lines 1, 3, and 4 in the IMT and paramedics, and then And then move the do not delay administration of medication up to AEMT.
That's when I can use high flow.
So Brian, you're saying do not delay.
So do not delay administration of medication up to the AEMT line,
Above the epi.
above the epi.
So after entitled PhD, that line, that's a bullet. And then it's there. Entitled should go up by ENT, right? That they were already entitled by, under the pulse ox and, entitled already. We have it there already. This is one where, because it's the STR, we have it in both. They're feeling like, as a medic who doesn't, they don't, the STR don't really apply to them, are they gonna convince that, as opposed to just calling it out? That's what the last typical everybody wants.
Is there a reason why we have an upper limit on the oxygen saturation for respiratory distress patient history?
I think it was, it was just taken out of the census. I don't know if I looked at the actual research behind it. That was their recommendation on the, I don't think I looked at the, I don't think I pulled the articles behind it.
What if I had a kid in respiratory distress?
You would just put them out.
So off of my earlier motion a long time ago at the beginning is this entitled CO2 goes up there, right? The IV's going up there away from AEMT. And so it has entitled CO2. We weren't leaving unless we're going to change to make another motion to keep entitled CO2 at the AEMT level and the rest.
This was just for the airway one, but that was going to be in both. There was a feeling on both. I mean, we've already moved it up. We've got the SDR. This one we already had the long debate about. Here is a secondary reminder. Just right. Yes. Yeah. So the question is after the full oximetry, so I think the point is, escalate nasal cannula, face oxygen, non-mercury breather as needed, period, and then
You can stay above 94%.
Yeah.
Or 94 and above, or whatever. Yeah.
then you have.
Greater than or equal to. Greater than or equal to, yeah, that's what I was trying to think of.
So as needed to maintain oxygen saturation greater than or equal to 94%. Yeah.
You got the word normal.
Yeah, to maintain oxygenation. And then for the paramedic one, moving in this row on, consider high flow nasal cannulas available, or with, I don't know how to word it prior when they get to.
Shelley, for the bullet you're on, we'll take out the word normal. And then greater than or equal to 94%.
And then would we want ECG monitoring at the paramedic level?
For bronchiolitis, under universal care, less important probably, with the airway management pieces. And then I heard for under paramedic, also, and maybe above that actually should be, consider high flow nasal cannula if available.
It's for severe, when available for severe respiratory distress. Because we have it for, it should be under the CPAP, but here's just the one under the.
So we will add to the EMT section, if you want just a reminder there, another bullet, add CPAP STR verbiage. Yes.
So a lot of indication or contraindications for CPAP, at least have been less than 10 years old. And this is for less than 2 years old.
We regularly use CPAP and ED for infants.
Because like the portal vent, the yellow portal vent, that was a contraindication to the use for that device. Now they don't make it anymore. There's lots of other things, but I'm just bringing it up because that's the way.
I think as long as they have to appropriately size mask for the size child, that should be fine.
I think that was kind of the old initial teaching that most of us were trained under, but I think my all done. So again, it's gonna be if you even have the equipment. If you don't have the appropriate size equipment, you're not gonna use it anyhow.
It definitely prevents a lot of intubations in small children.
Anything further on that one? Okay. Next on Strider. So I feel like this should match the EMT box should match what will be on the bronchiolitis box. Yeah. I'm just gonna say match bronchiolitis. And then the epi will update it to 5 milligrams and 5 mLs again. That'll match that.
I mean, for the,
So we don't have a.
yes, sorry. For the dexamethasone, is the max 10 or 16?
16 down there, well, but I'm just saying, the most that they carry is 10, but.
Right, but on the other.
No, that's the minimum.
I'm sorry, minimum, yeah.
No, it's not 4 milligrams.
Max is
It's 4
right,
milligrams.
if it's reactive
Yeah,
airway
max should
disease,
be
so versus the next is right.
Yeah, the
That's
max
weird,
should be
doesn't, so like obstructive disease is 16, unless,
Okay, the disease is still recommended then.
at least that's what our pharmacist recommended right now.
For this repeat.
So,
Bronchiolitis, yeah. All right, and then.
Yeah, I mean,
And then what I'm gonna say is this whole highlighted yellow section, that we will match the bronchiolitis, getting those in the right section.
Okay.
The question is that,
And then the oxygen again, I would.
And the oxygen thing, right.
yeah, so that, yeah, that whole section will match the bronchiolitis one. The question on this one, which is proof for Strider, do you want to use the hypoflow cannula in this patient population eventually? Because they talk about this one not exacerbating them, you know, it's a little bit different than a bronchiolitis. Agreed.
And this one is not, I mean, at least it sounds so didn't have that down for Strider, for proof.
So that would be the only thing. So the question is, do we add CPAP to the EMT and the FDR? I would say no. So match it without CPAP. And then at the bottom, match the same, the yellow highlighted will match again, but we will not add the hypo in cannula. So essentially, these will look pretty identical outside of those two differences. Everyone get a note?
Do we want to add, no, never mind.
All right. Next, the pediatric result unexplained event. We didn't change it. We had a lot of talk about this. We didn't change it much because prior to going through it the second time, you guys had just gone through it. If I remember correctly, you made those.
We just need a sunset policy.
Yeah, that's
Yeah,
the only way
right.
to take for the
That needed, right, that needed to go away, but as far as the actual guideline, I don't believe.
All right, anything else in that one?
Yeah, in those, move severe respiratory distress, refer to airway management, up high in the EMT right after whatever is appropriate, and then, IVs as a, however we want to word, initiate an IV, for SPR for EMT with that note up there rather than down here at the AMT.
I don't know that I would for EMT doing an IV and an OT, like a flu patient less than one. This is a very specific patient. I don't know that their expertise and experience doing IVs in that age group.
Yeah, what are they gonna do with it?
Yeah.
Right.
I kind of think that about the entire concept of EMTs having IVs. Not that I've never mentioned that before, but.
So at the bottom, we've removed the severe respiratory distress, and then it's under EMT, initiate universal care and refer to airway management and mitigation. So that's right. Okay.
Yeah.
Neonatal resuscitation, Charlotte, were there any recommended changes for this one?
So the only thing that they, and there wasn't really much. Was this does this one reflect all the stuff we went through? Because I hadn't grabbed, yeah, so.
You looked at the fund,
Yeah, that was, they've gone through it already.
So the only recommended thought is there's under waiting 30 to 60 seconds before planting the board. There's a lot of data showing you wait at least 60 seconds. So.
Where is that?
Warm, dry, stimulate baby for 30 seconds, and there's more data.
So this was a 2-pager, so I don't think we made much to the, oh, the question at the bottom, we had taken out endotracheal tubes as a route of drug administration from all of our other guidelines, the very bottom of page 1 of this. Should we take it out here?
We had, that's been somewhere else already, hasn't it? I think I saw it in 2 places. Was it in cardiac arrest?
We took out the P cardiac arrest one, so it shouldn't be in there anymore.
Okay. A whole new one.
I thought I saw 2 of them that I had comments I couldn't remember. And since we're going to be moving supraglottic airways up to the top and IVs up to the top, the first bullet point in the EMTI paramedic section should get moved up above where supraglottic airways are noted in the EMT section. Advanced airway is recommended prior to beginning chest compressions.
I have a question about neonatal resuscitation and using supraglottic airways. Is that commonly done?
What's that?
Supraglottic airways in the newly born
Right.
Is one small enough?
I don't know.
Size,
I mean, I don't know.
It depends on the size of the newborn.
I don't see why you would ever not be able to bag a newborn.
No, and I agree, and they got that big floppy epiglottis.
Especially for an EMT, like I just don't know.
I don't think I would set up the EMT section.
Okay. Fine.
And then my other question was the ventilation rate. I know that it's written in there to be 40 to 60 breaths per minute, but when you're bagging a patient that's not intubated, I think 40 to 60 breaths per minute is probably not possible. But I know that those recommendations usually come from the fact that in NRP, we're talking about intubated neonates typically in the hospital. In the pre-hospital setting, and they're probably never going to be intubated when you start resuscitating them, I think 40 to 60 breaths per minute is a lot. If you can actually do that with a VDL.
Recommended different number.
We went to 10 or something like that.
Does this kind of collide with the merit badge course guy? Because that comes up a lot.
I don't think most people are doing.
I think most people are doing NRP or
PALS are doing this as their ongoing.
It doesn't fall under PALS.
I mean, we haven't followed PALS anyways, because PALS is 20 per minute based on in-hospital data on intubated children also, so that's why most CMS agencies have not changed to 20, as PALS recently recommended. So I don't know. It's just more of a philosophical question for me, that I just don't think that that's possible or practical.
30 breaths, so 30 per minute is what they were. I'm not sure how they got 40 to 60 on, so they were recommending for, if it was 100, it was higher. So BVM with room air at 40 to 60 breaths per minute is what they were recommending for heart rate greater than, it doesn't make sense. And then if heart rate less than 100, they were talking, if no improvement, they were doing CPR resuscitated, with 30 breaths per minute. That was coordinating with positive pressure. Which I still don't know how you coordinate that rapid of a rate anyway with trying to do synchronous. Good. Okay, what was your, what did you guys have? RIP 10%.
What number again, sorry?
10. I shoot for higher. I shoot for higher, but you're gonna get what you're gonna get.
You said one of them was 30?
So interestingly, what they have on the BEMSTS, which, and I looked on NRP, and if I want to say it matched, was they have for heart rates greater than 100, monitor for respiratory distress, BVM with room air at 40 to 60 breaths per minute, which is pretty damn quick. But then it says evaluate for heart rate less than 100. Then they're talking about if you're doing your BVM, and then if not, if they're less than 60, you're doing compressions, but you're doing a 3-to-1 ratio of 90 compressions to 30 breaths per minute.
Maybe what they're saying, what people are actually probably trying to, are bagging it unintentionally because they've got a neonatal resuscitating. People hyperventilate. I mean, all joking aside, that there's probably, people are going to tend to hyperventilate. So if we tell them 40 to 60, they're probably going to go faster than that versus saying 20 to 30, they're probably going to go more at that rapid rate. So it sounds like there isn't great. We want them to bag them. 40 to 60 is probably not a realistic rate to expect someone to bag at and have a good seal as well as their bagging. So let's propose a number. It doesn't sound like there's any good signs.
20.
Agreed.
So.
Yeah. I mean, look at actual NRP. Well, that was a while ago. Okay, forget it.
This is Dan. I couldn't agree more. And by the way, everyone always manually bags faster than we're supposed to in every emergency setting, in everywhere we've looked. And then the other thing is if it's really stacking breaths like that, that creates such increased intrathoracic pressure that you're basically wiping out venous return to the chest. So I have no idea how those numbers got there.
Thank you. All right, so next, if there's no further recommendations to that page, we'll go to the next one. Oh, yes, Ryan.
There's a reference down in the EMTI paramedic to a laryngeal mask. It's in the second bullet point on the second to the last sentence, part of the sentence.
So change to supraglottic airway.
Supraglottic airway.
This is kind of, the way this reads, so it's a little bit goofy because it's saying epinephrine, the way it reads is indicated partially through an endotracheal tube or supraglottic. I think it's on reading that, telling me to fix that wording.
So I found that somewhere else. I thought I found that somewhere else.
So
Because you don't put it down as.
Yeah, epinephrine indicated blah, 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 that loose or at least 30 seconds of positive pressure ventilation that loosens the chest. And then maybe in parentheses would be better. So it's clear that this is referring to the actual ventilation, not the medication going through it. And take out preferably through. So via, the parentheses, via a properly inserted endotracheal tube or supraglottic airway. And parentheses, and another 60 seconds. Does that make more sense? Because it's kind of reading like put the med preferentially.
I feel like it still does.
How about do the via phrase right after PPV? So of positive pressure ventilation via blah, 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 that moved the chest. That was actually my question, not changing the laryngeal mass, but deleting it from that line.
Yeah, I thought we just deleted.
Because it doesn't, you don't put drugs down through those that I've ever heard about. And then,
To Amber's point here, this seems really overcomplicated. Can't we just say epinephrine after positive pressure ventilation for 60 seconds and then list the dose of epinephrine?
Yeah.
There's a lot of words here to say give epi. So epinephrine is indicated.
Wait a minute.
After.
Oh, I see what it is.
60 seconds of
60
property
seconds of
ventilation.
positive pressure ventilation, colon, and then the dose of epinephrine.
Yeah. Do you want to include if the heart rate remains
Yeah,
60
probably.
beats per minute?
Yeah.
Yeah.
So give epinephrine if the newborn's heart rate remains
Take your colon out, says we're
less
after.
than 60 beats per minute.
There you go.
And, yes. Right where you are, just type and. Not that one. I'm sorry.
Not sure, but kind of.
So right now, epinephrine is indicated.
Right where we were looking.
60 seconds of PPV.
Let's change chairs, everybody change chairs.
Sorry, Shelby.
Okay. So I think I did it after 60.
Are we doing 60 or 30? Because sometimes 30 seconds is all I'm saying for.
Yeah, it's
positive
30
pressure.
seconds, yeah. If the heart rate remains less than 60.
So before we go there, can we help Shelley?
Sorry.
Sorry.
Just like delete that whole section. Just delete after PPV, that whole, after 60 seconds of PPV. Just delete that whole thing down. We're deleting pretty much all of that. Just delete. And then, so epinephrine is indicated after 30 seconds, or 60. And heart rate less than, and heart rate remains less than 60 beats per minute. And then we just go to the epinephrine. Get rid of that second one, right? That's what we're saying.
And then to make it even simpler, should you just say give epinephrine? Yeah. Do it.
So epinephrine is indicated, you say give epinephrine after 30 seconds. Or, yeah. Give epi. Or,
Yeah, or give for simple language with shorter. Yeah.
Take off the indicated. Are we good with that?
Is there any reason we don't just put the NRP algorithm in there?
We actually, we should have it.
Sorry.
Whatever, but it's, and we were supposed to update it. We had it in the last ones, and it was supposed to get updated to the AMDP. Because we've had it previously, in the old one.
I don't know if we have a motion, but.
The flow sheet.
Or flow sheet.
So we can, when we approve this section, we can put that in the motion. All right, so yeah.
One other technicality before we move on. Under AMP, second bullet point, supervised devices and intubation should be utilized, and we need to delete and intubation from the AMP level.
Thank you. I just say the box above this, I'm confused. I didn't understand that. I don't know. Yes or no.
table totally, the whole table.
A yes or no means whether or not there is central cyanosis present, back valve ventilation is indicated.
The way the whole box table reads, those a little bit confusing, not just that section. So it's like heart rate less than 60, I don't know.
If we just use the NRP algorithm, it has the SPO2s with the associated time frames, and so maybe it just seems very user friendly to read.
Replace this page with the NRP.
Yeah.
And that's what we said, like, that's what we've had previously, is with the NRP.
Yeah.
The algorithm. It just doesn't touch that scale at all.
So, that would be a motion to replace page 2 with the NRP flow sheet that's updated. Let's go to this section before we go to the next. So this is kind of our pediatric specific one. So PMD, anyone opposed to the changes as recommended for P section, say nay. Any abstentions?
This includes adding the algorithm, right? Yeah, okay.
All those in favor say aye.
Aye.
MVC, anyone opposed to the updated P section, say nay. Any abstentions? All those in favor say aye.
Aye.
Let's do functional needs, and abuse maltreatment. We're going to skip it after that.
We didn't need to do anything else to get that flow sheet in, correct? Pardon? We didn't have to do anything separate to get the flow sheet in.
No, part of that. Yep. All right, so functional needs, I don't think there was any, I think we had made some changes last time, but I don't know that they're highlighted on this.
No, this was totally.
Okay. Oh, we didn't do any of that.
Did we do K already?
We're gonna come back. We're gonna come back.
Sorry.
And then the abuse and maltreatment, this is a question that comes up. We have highlighted here for notify law enforcement and one of the following. If I'm not mistaken, I believe statute says it's law enforcement for mandatory reporting. So I think I was just looking at that because I think that's being a question as to what qualifies for a mandatory reporting requirement. I thought it was.
You can't, like, you're a mandatory reporter yourself. That notifying law enforcement did not negate your responsibility to notify.
Notifying the hospital. I think.
No, it is DCS.
The hospital's not adequate.
Yeah, the hospital.
Yeah, but I thought law enforcement wasn't either, because you can't confirm that they're going to make a report, right?
Well, Scott, A.R.S. 133620A and 133212.
I just looked it up. The way I read this is 13-3620. It says, shall immediately report or cause reports to be made to a peace officer, to the DCS, or to a tribal law enforcement or
Yeah,
social
I see that here.
agency.
Yeah, I see that here now. Yeah. It's also on the DCS website as well.
So because I think, law enforcement's gonna be involved in that point, but I think the concern was people historically were telling the hospital and thinking that that qualified, and that specifically does not qualify.
Yeah.
So just because we're referencing statute, that's, you want to make sure that we are correctly doing so. So I would say law enforcement or one of the following.
Yeah.
I just want to make sure everyone's the same way I read that.
One of the following.
Yes,
Yeah, they're
I like that. Notify one of the following.
Instead of 1A, 1, 2, 3, or ABC.
Yeah, so
1, 2, 3, 4.
So law enforcement, DCS would be number 2, number 3 would be APS, number 4 before we tribal law enforcement. That's a nice segregation of that. And I think Dr. Woolrich had previously updated the 10-4 bases. We had that updated one. I think you had added that in for us, Dale. You can scroll down a little bit to see.
Yeah. Yeah, the validation and the repeat validation was with the FACES acronym, which was just the addition that I suggested. And you can see in the purple box what the acronym stands for.
Everyone good with those amended changes? So we'll just say we would notify one of the following entities, and then we'll list out 1, 2, 3, 4. Any further discussion on those? All right, we'll do a PMD vote. Anyone opposed, say nay. Any abstentions? All those in favor say aye. MDC vote. Any opposed, say nay. Any abstentions? All those in favor say aye.
Aye.
All right. Next, we will go to pain management.
My only comment is that I think the inclusion of aspirin in this particular location doesn't really reflect,
Agreed.
typical practice.
Yeah, agreed. Well, that was, I think I thought I may have asked that question, because everything I found was because you're talking about like rise or, because that only happens in fever, or just not giving aspirin to kids at all.
Correct. My only, I think just from a pragmatic standpoint, you know, if EMS is an extension of a medical director's practice, typical physicians are not going to use this pattern.
I would never give aspirin for pain control.
Yeah, like that.
I would never give aspirin for pain control.
No. And then the other thing is.
Period.
Yeah,
Period.
period.
I would say take
Period.
that out, and then after ibuprofen, take off every 4 to 6 hours.
Agreed. Yeah.
Hopefully you don't have a patient for 4 to 6 hours.
No. Might have had some transports out of Tucson to Flag in the last couple of big snowstorms.
Okay.
But they can call.
Yeah. Okay.
So,
Take off the aspirin, and then take off every 4 to 6 hours.
and I found a typo I put in here yesterday, under ibuprofen, for the pediatrics. The last line says 1 year old, 300 milligrams, that's supposed to be 11, and then at 12 you go to adult. Okay, that makes sense. Yeah, that's supposed to be 11.1.
One thing in the exclusions, so the top box excludes allergies to morphine or fentanyl. We need to get rid of that, because if we're now including acetaminophen and ibuprofen, it wouldn't be as applicable.
I think
So it's allergies to the
isn't that like a given for any medication that you
No,
give?
for sure, that's why I was wondering if we can get rid of it.
Yeah.
How about hypoventilation
Yeah, I would remove that as well.
and hypotension?
Mm-hmm.
Is active labor, why do we have that in there?
To dissuade providers from treating labor pains with opioids.
No, we don't have it. That's specifically excluded from the management too. Yeah, but that's orders for active labor. Well, any pregnancy or abdominal pain, so it covers whatever reason. Whether it's just active labor or not.
And when you say excludes, you mean exclusion criteria for pain management?
Well, and I was just mentioning that in our case, it's not just active labor, any pregnant female, you have to patch for pain management. It's not part of a standing order set like this stuff is.
I just think that if we have all these exclusions in here, it basically excludes them from getting Tylenol or ibuprofen in all those cases as well. Right, so if you have hypertension, then you can't have Tylenol.
Correct.
And if you have, okay.
And so hypotension, allergy, hypoventilation would be contraindications generally to giving opiates anyway, right?
Right, but not the OTC medication.
But by deleting them, we don't have to worry.
Yeah, we already deleted.
Right.
Right.
Are we deleting them all?
Yeah, we already
Oh, okay, well, sorry, that's where my,
So, in the chat, Dr. Woolridge put ibuprofen has a relative contraindication in 6 months old. So we should say,
Carrying liquid
6 months
ibuprofen
to
and all.
6 years. So that
Yeah.
goes then.
Yeah.
6 months old to 6-year-old.
Well, and I don't have anything less, or ibuprofen, less than 6 years old. And then 1 year old, or then it would be 11, 6 to 10 or 11.
You don't,
So I don't have anything, there's nobody in there less than 6 right now in this.
You have less than 6 years old.
under ibuprofen.
Oh, less than 6 years
Yes,
old.
so it's
Oh,
not
okay.
down to birth, so yeah.
And do we want to change that one from 2, on the acetaminophen from 2 years to 5 years? And maybe put down, like 3 months or 6 months old for acetaminophen?
I mean,
So this is a pain control, we're not doing.
Oh,
pain
sure.
control.
Yeah, you're right.
these are drugs that would have to be stocked on the ambulance, right?
Mhm.
So they would require them to have a liquid acetaminophen or Motrin, but not maybe right, and maybe a pill form of each of those.
Right.
Just make sure I understood.
And the only other suggestion is, just because we're going, for the ibuprofen, we do 6 months to 6 years, and then we do 6 to 10 years, and then 11 years. So we're going ascending order of ages. I would do ascending order of ages for acetaminophen rather than reverse older.
So we should fix the acetaminophen to
6 months.
flip those around, 2 to 5 years.
Yep, no, that's my suggestion.
And then 6 to
Yep.
11, so that they're ascending.
Yep.
So, I volunteered to do some drug profiles because we added over-the-counter medicines for pain and fever.
We won't have time to get.
I'm not, I'm just, so when I was getting ready to do those, and I was like, well, but if we're doing treatment guidelines, we should have those in there. And that's the reason that these over-the-counter medicines ended up in here.
Because otherwise, people would be like, oh man, I wish we would have put them in.
Later on, yeah.
This is Dale on the chat. The acetaminophen is listed 2 to 5 years, kind of excluding the 0 to 2 age group. Can we just say under 5 years? If you have a 1-year-old with pain, can you give them acetaminophen?
So less than 5 years old, Dale?
That would be my suggestion, yes.
Sure, less than or equal to 5 years old, perfect, thank you.
Thank you for that, Dale, I need to go.
Do we need to add anything for AMT area administering morphine, a caution about hypotension? I know we have that at the top, I think, exclusion.
We took it off.
We
took that off.
The hypotension at the top, right? We took it off. But do we need to talk about it prior to giving morphine or?
Like under the AMT?
Yeah.
No.
So
So then we're gonna have to be putting contraindications and a whole bunch of these things.
Because we didn't put it on anywhere else.
Because that's a contraindication to the drug profile.
Yeah.
Yeah.
Any further discussion on this one? All right, PV, anyone opposed?
Before we pay for the second dot under morphine, additional analgesics per local protocol, is that is that adding any value?
Yes. People that had different, some people didn't want additional combining the types of meds, so it just gives people flexibility is what they do with that. PMD, anyone opposed, say nay. Any abstentions? All those in favor, say aye.
Aye.
Any opposed, say nay. Any abstentions? All those in favor, say aye.
Aye.
All right, that's your graph. Okay, Frank.
That's it.
All right. Time for a bathroom break. I have a funny feeling it's going to go on for a while. All right, so trauma general management. Any questions, suggestions? As I was looking through this, the occlusive dressing initially stated partially occlusive dressing. Just to simplify with what's stated for, in the trauma chest management section as well. I raised this question just to raise the question of the traumatic brain injury, epic TBI. Is that, if we want to simplify that in regards to just saying traumatic brain injury and leave off epic TBI, although I think that Dr. Spade is still on, so I would highly suggest keeping it. I just wanted to bring that up, just so if somebody else had read that and said, gee, why are we referencing that as well with the protocol? I think we ought to keep it. We are Arizona, and I've done for practice.
Yeah, that's kind of a provider request.
Yeah.
No, just like keeping the term refusals. It's just something that triggers the provider.
And absolutely. And if not this state, I don't know where.
So I have a comment on the primary survey, and if I may, this has a go back to the universal care page. So a lot of, and the SEMSO does point this out as well. If we're using something like March, a massive hemorrhage actually trumps airway.
Yeah.
And then the reason why I bring up universal care, the SEMSO specifically reminds the provider, if they start on the universal care page, we have the ABC, but in a sense, so it actually spells out, you know, depending on the nature of the call, I'm paraphrasing, CAB or March may be appropriate. I forgot to mention it on that page, but
I think that's a good idea.
It's going to be a tight fit on the universal care, but at least for this page, putting hemorrhage control above airway.
Does that have to be added to the universal?
The universal care page, I mean, I don't know if
I
we.
don't think we would be able to fit it on there. I mean, I think it's appropriate for this one, because it's Thomas.
Yeah.
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 Hemorrhage
I think
repair.
it's a good idea.
Maybe then just delete my initial universal care?
Yeah,
And just go right to,
March.
or March or CAB, whatever.
Yeah.
Oh, but we need the initial care for insert ID and all that stuff,
Yeah.
so. Oh.
There's IDs down here.
I think it's easier fix it just to say move hemorrhage control line above the airway.
Yeah.
That's an easy fix.
Yep.
Not because I want to open this can of worms, but because of, the request sent to me was to the ACTXA as listed as an optional agent. We added to the general trauma management guidelines.
That's in my notes.
Yeah. And I wonder for exsanguinating hemorrhage.
Where else do you have it?
About 3 or 4 shots.
Great, no, it's heart rate greater than 90, BP less than, for heart rate greater than 110, BP less than 90, and we're not using suspicion,
Presumed.
presumed.
Or potential.
Potential.
Quoting Dan, and I'd suggest that too, then for the traumatic brain injury, Paul. Instead of if clinical signs of traumatic brain injury, I just say the potential for traumatic brain injury. We said we'd use that throughout. There's no suspicion here, so we wouldn't find it with the word search. But.
Yep. And that would be an EMTI paramedic with paramedic only after it, if we add it.
I mean, TXA to the paramedic?
Yeah.
Okay.
So I think we need to feel emotional if you want to add it or not first. Yes.
Yes.
Okay. We're going to add TXA, which is ENT paramedic, TXA in parentheses, paramedic only. And then you want to call out a dose on that.
It's 1 gram and 100 mLs over 10 minutes.
Our local trauma surgeons have requested that we up it 2 grams. Our local,
Things are going, so.
So 2 grams.
And we should change, I think.
So right now, the
we should change
minimum is 1.
Is 1.
So the minimum is 1, but the
I want to
recommendation.
say 1 to 2, 1 to 2 grams.
Yeah, we thought about that.
The 1 to 2 grams.
Yeah, it's gonna be what?
That's fine.
He was asking, not offering.
Over 10 minutes.
Yeah, so over 10 minutes.
And 100
Yeah.
mLs over 10 minutes.
So we want this 10 minutes.
15.
Yeah.
Just run it in. It's pretty much running. Yeah.
Yeah. And then,
What's that?
I thought, yeah, this is military.
I guess you just run
It's going in.
You just run it in.
Yeah, instead of over what I did, then put a bolus.
Yeah, there's some,
There we go.
like, theoretical risk of hypotension, and so they
Yeah.
say you should push it, slow IV push, but
Over 2 minutes. So this will work for everybody. 1 to 2 grams TXA.
So then it's gonna be 100 to 200 milliliter bolus.
How about if we just did 1 to 2 grams bolus? Yeah, because then whatever concentration you get in, whatever.
and your peak dosing would then be either 15 or 30 per kilo.
Can we do bolus infusion? Or are you doing an IVP down there? We do it as push.
Right, so I would just leave it as 1 to 2 gram bolus and then leave it up to medical direction to, I think it's what it is.
100
Yeah.
Yeah.
So the TXA, the 1 to 2 gram bolus, and then on the pediatric side, it's 15 to 30 milligrams per kilogram, max 1 to 2 grams.
The military is
Yeah.
bolus, correct,
Yep.
does not show that.
Okay.
Crash one.
Yeah, absolutely. Yeah, I think it shows it. Oh, yeah, 2.
Isolated.
Yeah, so maybe where this,
All right, let's focus our all-in-one
And
conversation,
they
just
should be
to
using
people
it.
online.
So maybe with the TXA where it says paramedic only, and then put, let's get within 3 hours of injury.
And everything else will be in the drug box, kind of in regarding that stuff too, so only we need to add too much more.
Do we want any other criteria in terms of when to give it? Yes. So we need to have that on here.
The heart rate greater than 110.
We don't really put any specific criteria with our other drugs though, right? Like that's all in the drug profile itself.
So should we say class 3 or 4 shock rather than a heart rate? A lot of people are gonna have a heart rate or.
No paramedics can remember that.
To the point from the medication from before, we just defer to the fact that you need to follow the drug box. I'm just curious why this would need to be different from TXA.
Or concern for ongoing bleeding. Did we put that in the drug profile? I don't have the drug profile downloaded.
Medic ought to be able to recognize hemorrhagic shock.
Yeah, so if I may, the Central Arizona guidelines already added this to the page, so we have verbiage already. We do include if transport time exceeds 15 minutes to a trauma center. And so we added that. And then we do have injuries that meet the following criteria: severe hemorrhage and vital signs, and as well as a suspected TBI with motor less than GCS less than 5.
We added GCS to the criteria.
We added a GCS motor subscore.
So should we just put that in?
Should we just?
Copy paste?
Yeah, I mean, that's, you've already done verbiage, it sounds good to me.
Or should we just say if they're in hemorrhagic shock?
Because that's not well, I mean, it's not pretty well defined, fire in the heat of the moment, I guess. And it gives them a little bit.
Why want to do the motor score?
Yeah.
So we list the criteria of within, so 15, when your transport time exceeds 15 minutes, we have TXA 1 gram, which we've adjusted here, and then patients who meet the following criteria: severe hemorrhage and a heart rate and a blood pressure parameter, suspected TBI with a motor subscore of less than 5, i.e. not able to follow command.
That's what the Committee on Trauma has in their verbiage. It's something similar. Committee on Trauma says, or the COTCCC group says, in TBI, if a casualty has signs or symptoms of significant TBI result or mental status associated with blast and verbal trauma, they also advise that the inability of the patient to follow commands is reasonable pre-hospital threshold for TXA administration. That's what COTCCC says. That's what he said out.
So really, it seems to me the easiest answer is use what you guys suggested for the adult dose. We use the 15 mg per kg for the peds dose, max 1 gram. We can change that, and then copy paste the rest.
Just to offer a different perspective, I totally fine doing it that way too. Please don't get me wrong. We found that the biggest, our medics just forget to give it, and having a long list of exclusion really results in our medics not giving it hardly ever. So we simplified ours dramatically to be a positive shock index and suspected hemorrhage. So if your shock index is greater than 1 and you suspect hemorrhage, you get TX. Our protocol.
Which is why I say hemorrhagic shock.
Yeah. I think that simplifies it.
Yeah.
Referring to a shock index measurement or calculation.
Again, that doesn't have to go in here because that's on the drug profile, right?
Yeah, it depends on our style and the
Shock index and shock section.
The whole TBI thing is kind of like going on, right?
More in here, or embedded.
If I'm getting confused.
Yeah, exactly.
And then you call it shock. I might not even say anything about the shock index since we don't even reference shock index in the shock section. And we don't, in the trauma, we don't either. The only place that you could even find it is on this, and they don't even call it shock index. They just say,
yeah. Going back to Frank's suggestion, I mean, I would just say, for hemorrhagic shock, give TXA.
concern for hemorrhagic shock.
Yeah, but you know, simple to let them know what it would look like if they're off by a few numbers on their shock index, and they gave it.
We don't want to have people do math,
Right.
even though it's simple math.
They say,
They look like they're in shock and they're bleeding to death. Give it to them.
yeah, keep it simple. I like that.
Yeah. All right, so let's make the final recommendation, the verbiage for this. So
Administer if consider administration if hemorrhagic shock and what was your thing?
Injury within 3 hours.
And injury within 3 hours.
And what about transport time greater than 15 minutes?
I would say,
Yeah,
you know,
everywhere I have it's more.
back when it was, you know, it's 10-minute infusion and things like that, maybe, but I would just say, if you're concerned about it, you know, I would say, gosh, you know, we were 10 minutes out and gave it, that's wrong. I don't think that's wrong.
So it's going to say, consider administration if hemorrhagic shock and within 3 hours of injury, and then the dosing.
If it's suspected hemorrhagic shock.
Yeah. Selected.
Potential.
Potential.
Yeah, look what you started. You're not even here, but I know you can hear it. I hear you in my head all the time.
By the way, we are spending a lot of time wordsmithing something that the answers. I don't think the answers are in on this. So, but it sounds to me like everybody wants it. I think it should not delay anything else, and if it's going to be in, it should be incredibly simple.
We can take it off.
Are we saying consider, or are we just saying give it? Send it.
Definitely consider. No, definitely consider. I don't see how in the world we've gotten that far to make that the state. Basically, we're saying this is the order. There's plenty of literature that could have a thoughtful medical director not feel like they want to comply with what's in here, and then we create liability for a thoughtful medical director who doesn't think the answers are in. And there might be one of those in Arizona.
Next, external hemorrhage management. I have a quick question about the tourniquet. We don't specify on here. It looks like an old version said 2 to 3 inches proximal to wound. You know, so the more specified type. Should we specify that on?
Professional rescue.
So should we just leave this as a applied tourniquet and just leave it as is.
Can I want to go back? Maybe for, to make things even simpler, there's a bullet point under hemorrhage control. I don't know if it has any value, because it's just go to the hyperlink and everything's right there. Apply the right pressure tourniquet, delete that. My suggestion is to delete that line. One second. It's bullet, apply the right pressure. It's all embedded in the external measure.
So, you know, maybe you want to say, apply tourniquet till bleeding, you know, apply tourniquet till bleeding stops. We're talking about external hemorrhage from an extremity. You can see it. That's our criteria for the military.
Yeah, I mean, I think if you're doing everything else in the trauma one, then maybe someone go to another guideline back and forth for no reason. It's not a big add to take it off. See the first one. External hemorrhage. So I just want to bring that up because I have some questions regarding the tourniquet. Any thoughts on that one?
So the professional rescue literature is still 2 to 3 inches. High and tight is for lay people.
I don't know, we get comments from our trauma center no matter what.
Yeah.
The providers are constantly like, I'm so confused about what we're supposed to do.
Apply tourniquet
Well, a
proximal
lot of
till
times what
bleeding
happens
until it
is they
stops.
get comments because the police will put on the tourniquet and the police will put it on high and tight. And then the EMS brings them in and the trauma center questions why it's on there. You know, I mean, there's no right answer, I don't think.
So I'll say this. So the teaching for the professional rescue also includes adding a second tourniquet if the first is not effective and is supposed to be placed proximally to the first one, side by side.
So totally agree. We're doing that in the military all the time, and also we're doing contaminated trauma with nerve agents, et cetera. And we're not saying high. We need some options.
Yeah.
I agree. If you want to get that complex, you just apply it until bleeding stops, and apply a second one if it doesn't. Really easy to take the first one.
So we're just going to leave basically apply tourniquet period.
That's what I would do. Is
Is
it a training issue then?
Yeah.
I'm fine with that.
For clarification, or just simplicity, on the 1, 2, 3, 4th bullet point, tourniquet applied, second dash, I think we can delete that because it's just repetitive. Use of tourniquet at extremity, strong tremendous, if direct pressure is not effective. You said that, we said it previously. Perfect.
May I also propose that the first 2 bullets be changed to a number 1 and 2 because this is kind of a stepwise approach. Step 1, step 2.
And then I question the third dash below the third, or below the 4th bullet. We already say if a tourniquet's applied, use commercially available, blah, blah, blah. They already applied the tourniquet.
Right, that doesn't make sense there. The way I was going to suggest fixing that is that don't make it a sub bullet, make it its own bullet.
And put it above the tourniquet applied. You want to say, so put it under the second bullet is what you're saying, Bronco?
Hold on a second. So I'm just saying step 1, step 2.
I wouldn't do step 1 and 2, because that's very purposeful. There might be times where you don't have the ability to do direct pressure if the tourniquet is next patient.
Yeah, you got it. You're one person. Yeah.
My understanding of this educational process is that you use, kind of like airways, you use the least invasive approach and that's really appropriate.
So, but what Gail's saying is, if you got one person, they may need to do a lot of other things than just apply direct pressure. So they're just going to have to throw the tourniquet on and then manage the airway. And that's without a multi-cache.
Yeah.
And then if you got a multi-cache, you're going to throw it and go.
So where do we want to put the commercially available?
I just say increase its indentation to a dot and then leave it where it is. Don't make it
Or put it up where you say apply tourniquet.
Yeah, that's what I suggest. Yeah, I agree with that.
Would anybody want clarification on what you're applying the tourniquet to?
because up until this time, it could be just wall.
Extremity. Or no, no, you're right.
Yeah, and all of these tourniquets are gonna be extremity. That's all we got.
I don't think it needs to, but, you know, we're telling, if you got bleeding, first put pressure on it, and then if that's ineffective, apply a tourniquet. Well, wait a minute, where is it bleeding from? Apply a tourniquet if it's an extremity amenable.
Right, we're not doing junctional tourniquets here.
Right. Well, then that's the next bullet point. You know.
So should you say if direct pressure ineffective or impractical for exsanguinating hemorrhage from extremities or extremity hemorrhage? You want that?
I would say, you know, if I'd have to say if direct pressure ineffective or impractical, related to the first one, apply a tourniquet if extremity hemorrhages from extremity.
Yeah, okay. So apply a tourniquet to,
but otherwise, you know, we're
extremity
starting
hemorrhage.
off so general, and then the next thing is as if we're only talking about extremity.
Yeah.
So you can do a direct pressure ineffective or impractical, and then apply a tourniquet if an extremity wound on that line.
I think it's fine if we drop down, if hemorrhage is not controlled, well, obviously if it's from the chest wall or something, it's not controlled, obviously the tourniquet's not doing it, then apply the topical hemostatic agent, I think would be fine.
Then I have one other thing at the very bottom of this. Do we want to reference if the patient's hypotensive to go to the shock guideline or not? Is it a standalone or?
The general trauma guidelines.
Do you want to open the floodgates on, permissive hypertension and trauma?
No. So, I mean, one of these days, we want to meet. So.
Exactly.
So, I'm sorry, also utilize improvised tourniquets only if no commercial devices available should go up.
Yeah, so we.
Under the apply the tourniquet. Okay,
Yeah,
great. Okay, thanks.
Yep, so let's take a quick look and see if this is better there.
Yeah, thank you.
And then actually,
Go ahead.
if tourniquet applied, we don't even need that, we can just take that out, that last bullet.
Yeah.
That's underneath.
Yeah.
So do not release the properly applied tourniquet until patient reaches definitive care.
Just make it its own
Just move
bullet.
the bullet above.
Instead of
that.
Just, and then after, where you put the other bullet, cut, and then utilize this one and put it in there. And then we can just take off.
And then I suggest change and utilize to use for brevity and clarity. Word search it, change it throughout the document.
How about this, what did the capture guides is, the third bullet, apply a tourniquet. How about for extremity wounds? For extremity wounds, apply a tourniquet.
Bleeder. Yeah, that's fine, bleeding extremities. Or extremity hemorrhage. Yeah, extremity hemorrhage, I like that.
Well, I thought that was going in after the second bullet point and apply a tourniquet.
For extremity.
Yeah, apply a tourniquet for extremity wound. Then you don't need to double it up down on the next tourniquet line. It's already clear higher up. And then if hemorrhage not controlled for junctional injury, it's got that.
Yes. Great. Is anybody, just for my information, is anybody using junctional tourniquets here in Arizona in the EMS setting?
Not that I've seen.
Okay, not that I've seen either. Do we want it in here or not?
I wouldn't.
I wouldn't either. Unless we're, if we're not using it, I take off that last bullet.
Even the TCCC military side has removed their, they make no recommendations for the junctional.
Yeah.
So may I make a suggestion for,
So do we want to delete that?
Do you want to delete it?
Yeah.
I think that's okay.
If we're not,
It is
we're
hard to-
directing civilian care in Arizona and we're not using it, and it's not available, I would, but I'll defer to the group.
I wonder if the group agrees that the, under the, if hemorrhage is not controlled junctional section, rather than using the term topical hemostatic agent, be a little bit more specific to a hemostatic agent in gauze format suitable for direct wound pack, delivered wound packing.
Are we teaching our medics to explore and pack wounds in the civilian setting?
No, but we are teaching them deliberate finger over finger, hand over hand, deliberate wound packing techniques.
But that's only, I mean, that some of those things you can just apply logically and fit sure you're not tapping them.
But I'm talking about specifying the agent, because there are other agents commercially available that are not gauze format. And at least in my crews, we're only purchasing and utilizing gauze format hemostatic agents as opposed to like powder and
Well, quick clots come that way, but I don't think they make it that way anymore. They did, I think they did away with that.
Okay, so everybody's using gauze.
Yeah.
Yeah, I think
Yeah.
so.
Great.
I haven't seen that for a while. And I apologize, back on general trauma, we need to move the pain management on that up to EMT.
My apologies, I have a shelf start lead for attendance purposes, and I drove these with me in the car, so for attendance purposes, we'll all join from the phone for the next 2 hours, so.
Thank you.
Safe travel.
Your girl's 10 minutes.
Again, Gail?
And Shelby, obviously.
Thanks for coming down.
This question about the Thomas A.R. that just comes to me, several people, is there's two national position statements. There's something for the withholding of the consultation and the termination of the consultation. We have one guideline that is kind of so wanting to know, the question that has come up from crew for the criteria was, are we actually starting with resuscitation? Because our interventions listed are kind of, if you get there and they're cardiac arrest, kind of not much of anything. So we have position statements, they're both very lukewarm. I think just the data shows there. So I just wanted to bring that up of, is there a way to potentially reword the exclusion to make it clear about how much, if any, resuscitation is needed?
And that has to be done through the eyes of the changes we just made to the obvious apparent death protocol, because that appears first now.
Not necessarily, because this is trauma specific. So like you come up with a motor vehicle crash and trauma, like a cardiac arrest, that's actually the key part of it. There would be decapitation and decapitation, but just like you get there, there's also some trauma and they're cardiac arrest.
So at least like for us, if we arrive on scene and they're traumatic and cardiac arrest, you feel a pulse. If you find no pulse, then we don't begin resuscitation at all. What are others do?
Yeah, that's an excellent question. I don't know.
There's pretty much no evidence.
When they arrive at my hospital without a pulse, I can tell you we still work. So, but
Right.
that means, you know, if you, depends on how long, if you know, you know, from the time of cardiac arrest, things like that, a lot of information we don't know.
What is it that others do?
How long do you, I mean, like, I understand like a loss of pulse is on the way in, but I mean, are you working on if they were completely down for a while at speed?
It depends on, you know, it depends on how long they've been down for, and is it blunt or is it penetrating? Blunt trauma, dead in the field, is dead. Penetrating trauma is stab wounds, you know, up to 15 minutes, you know, if we have a possibility. So this is going to get unduly complicated if we try to address those types of things, unless they are previously addressed in the obvious apparent death. I'm guessing that it's not the case.
Yeah, we have like decapitation,
Yeah,
things
so,
like that. And we do have penetrating, considered transport.
yeah,
Less than 15 minutes.
I think that's okay.
Yeah.
So we're,
Pardon?
For some reason, it's crossed off. I was wondering why that went away.
No, that was my edit just for, consider.
My understanding too is it's 15 minutes from time of injury to hospital.
That is correct.
So it's a very short pre-hospital time to achieve ever, even in the valley probably, when there's a lot of hospitals.
Usually, so, there's oftentimes even in the Phoenix metro area, the EMS crew stage, and so it's seen as clear or safe, and then the EMS coming in, so often they've already bypassed that 15-minute injury time.
For sure.
In my edit, I'm the one who took that away. To discuss it here, it's something that we really I would want to include it, right? Or do we want to word it for from time of injury or other times?
I think the request, because most of the regions have kind of adopted from this, is that the inclusion says the house receives resuscitation, but it's not responded. And so they're like, well, what does that actually mean, resuscitation? Does that mean we have to do compressions first? And then it gets down to the blunt versus penetrating. And so that's why I bring that up. Is there potentially a simpler way to word this?
I think I throw out kind of what we have on our setup, because we had a similar discussion for some period of time. If you arrive on scene and patient's in cardiac arrest prior to your arrival on scene, patient does not have a pulse, confirmed by 2 or more providers, withhold anything else. If patient codes after you've arrived at the scene, you then begin resuscitation with the objective essentially to perform bilateral needle decompressions. And at that point, you can consider airway. If no ROSC, termination. And that's kind of like our main decision branch point. And then, of course, if you're on scene and they're not, if it's the A.R.S. during transport, you just bring them to the hospital. That's kind of our 3 main branching points for that.
That's basically ours too.
Yeah.
And then especially because we're kind of in the same boat where we're at, we don't have the facilities, so if they're either dead or they're not. So if they're dead, we're not going to try to do anything more.
And I'm not pre-hospital, to that extent. So I completely agree that it's a blunt trauma, and you use it that way 99 times out of 100 or 100 times out of 100, they have to be dead anyway. So with penetrating trauma, as long as we reference, for if penetrating trauma, if you're within,
right,
whether it's geographical or a time limit or something like that, we should reference that or have a clarification point for that in there. I think that's perfect.
And that's what I like too, because like for us, even if someone seems like if they try to call the rotor, it's going to be 30 minutes before the rotor shows up. You're like, right. Right. So we don't even want them activating the rotor because they're like, it's not going to make a difference.
You want it to, I'm sorry,
so let's, it sounds like there may be consensus to utilize that type of verbiage. So let's look at the, at the top for inclusion, so should we just say any traumatic cardiac arrest in the field? That's easy, not around the hospital, so there's the field.
On scene or upon arrival.
On arrival.
That's one of the big criteria for us.
So any traumatic cardiac arrest upon arrival of EMS.
Yeah.
And then take off the rest of that sentence. There's kind of confusion, confusing.
I like your server.
And then when we get down, as opposed to having, we have blunt plus penetrating, and then we have penetrating separate, because it's a little confusing.
Yep.
So let's maybe just say what we want to have listed under blunt trauma.
I feel like for us, we don't separate the two, blunt or penetrating.
Okay.
I understand what you're saying about the 15 minutes. That's just almost never realistic in the pre-hospital.
Our treatment guideline does have, though, to consider transport if it's less than 10 minutes. And, when they arrested it in front of you, but it's just a consideration too. It's not a.
Right. So, I mean, you could just take those 2 bullets under blunt and penetrating and put it above the termination. To say, hey, as a medic, you could try an OPA and MPA, you could try needle thoracostomy, but then termination under the following scenarios.
But if you get, the question though is if you get there and they're already dead from blunt trauma, do you need to see those things?
Not if they're already dead.
Yeah.
This is if you're already
This is if they arrest them.
Because your inclusion was upon arrival of EMS. That's your inclusion. So they are in cardiac arrest upon your arrival.
Yeah, I think if upon arrival, you confirm that they're pulseless, you don't put them on the monitor, because they're probably gonna be in something, so you just confirm pulselessness, and that's it.
So, but then this suddenly became a withholding protocol.
Well, that's, and so when you look at the
Yeah.
national guide, so there is the withholding
Right.
and there's termination. And if you look at the two, there's a lot of overlap, the two national position statements with a lot of wishy-washy, very uniform language that's in there.
I mean, the other option too is to go back to the obvious apparent death and add that trauma sentence to that. And you know, that's like the withholding, and then make this the one.
I think any withholding should live on the apparent death page.
Yeah, I mean, I would be on board with that too. That seems like another place.
We just did that with the medical. We just did that with the medical. It's probably what we should do here as well. And then make this an exit ramp once you've started efforts.
Sure. Okay. I can see that too.
I'm okay with that.
Yeah.
All right.
Well, so we already closed that one,
Yeah,
didn't we?
so this gets a little bit wishy-washy if we start doing it that way. So let's clarify what we want this to look like, because trauma, termination, or resuscitation.
To me,
What if we renamed it and we said withholding and termination, and or termination of resuscitation effort, and then it includes both?
That would be a good.
That might, because otherwise,
Then we know.
we already closed the other one.
Right.
withholding
And or termination.
slash, withholding slash, there you go.
Yeah.
Can I ask you a question? Kind of what we're mentioning in the sense that upon arrival, patient has no pulses. Can you imagine any of your colleagues would have significant pushback against us moving forward with this? I'm just making sure that it's similar to keeping our paramedics safe as well.
Sure. You know, where I practice, I'm very close to, the streets, and, you know, we get a lot of patients from very close to where we are. So in a situation like that, if that, you truly came upon them, and, you know, it was a 5-minute transport, granted, take that as you will with loading and unloading and everything else. You know, there are potential people who have lost vital signs in the field who we could get back.
Right. Okay.
That's penetrating only.
Yeah.
Blunt is not. I don't think anybody would say, yeah, you did the wrong thing, you should have worked that person, even if you're 5 minutes away. I mean, they lose vital signs in the parking lot as they're rolling in. You know what? We're gonna open their chest and guess what happens?
Yeah.
So and that's
I mean, I think for you guys, it'd have to be like right in downtown Flagstaff, because anywhere outside of that, park, anywhere else are done.
And there's my
No, like,
my branch.
to your point, the reason I kind of bring that up is like, because if we put it on the obvious apparent death, it becomes just kind of like, ooh, we don't touch them whatsoever. Yeah. Versus like our discussion here, then maybe keeping it here because it's, we can have the thing, consider a transport time less than 10 minutes. So I want to make sure everyone feels about it.
Amber's hand up online, so I'm just gonna go to her quickly. Amber, go ahead.
They really are on.
Sorry, it's the car group that, our comment from Southern Arizona, we do have the 15-minute mark in there, and we have had some positive outcomes in patients who lost pulses and had a transport time of 10 minutes or so. So for penetrating trauma, sorry.
Yeah. I think we need a bifurcation for penetrating, and one, the literature supports it, our practices support it. So I think there's a significant difference between the two.
So then the question is, how do we format this to have the withholding and an off-ramp for termination of resuscitation?
So I think we don't need to even bifurcate it. We can just basically say, like, let's do penetrating, because that's always the easier one. So penetrating, we're gonna basically say, consider transport to trauma center if transport time less than 15 minutes, if less than 15 minutes from injury.
Well,
From arrest.
from cardiac arrest to the injury, not the injury itself.
It does happen. One of my trauma nurses in the past had an ED thoracotomy and was obviously a survivor.
Yeah, no, I mean, we've all had one.
He liked to show his scar.
It was nice, pretty nice.
It was not pretty. Not on his body.
From time of arrest.
15 minutes.
From time of arrest.
And do we need transport time, or are we just saying if less than 15 minutes?
I would go with B, just because what works in Phoenix may not work in the rural areas. It's just, that's gonna be up to the medical director.
So if less than 15 minutes of time is correct, without transport.
Yep.
So it'll be transport time.
Yep.
Or it'll be transport.
Yeah.
Yeah.
Less than 15 minutes from time of birth. If hospital, less than 15 minutes. And I would put cardiac arrest too. Not respiratory arrest.
Yeah, oh, yeah, good point.
I mean, we understand it here, but that's a good point.
Yeah, key point.
Yeah.
So then I have a question now, going back up to our inclusion criteria. Because right now we just with the protocol.
Right.
And so I would ask first that we change the first bullet, or just add to the first bullet, any patient found in. There you go. And then, so now we build the withholding. How do we build the off-ramp?
Then you right underneath to consider termination right after that. Because you've jumped into after that,
But
after
it's
termination.
not a patient care box.
Oh,
And this is just your inclusion.
This is, but I would differentiate, I would say found in blunt traumatic cardiac arrest would be my suggestion.
well, except that has both protocols on there.
Yeah.
I mean, it
So
has
then
both.
we're gonna, so this is just your bound, and then you go down and we would separate one. So basically you're saying if your inclusion is if you're any patient found in traumatic cardiac arrest.
But then we also need to have an inclusion of alive patients who then arrest later. How do we do that?
So it includes any patient found in traumatic or found.
So I think those are gonna get transported, that's not a.
No, but we have language down below that includes initiating care on people who are found to be
So we have provide resuscitation, so you're gonna work.
you're gonna work.
So it's already in there. It's already in there.
I see,
Basically,
okay.
you're going in your cardiac arrest. So I think the inclusion is any patient found in traumatic cardiac arrest,
Right.
period.
Okay, so patients who are alive are not on this page.
Right.
Yeah, 'cause that's a cardiac arrest person, not a.
That's just a general trauma care.
Right. Well, and then if they happen to arrest on the way, you're gonna keep going most of the time.
But if they arrest on scene,
You might not even load them.
Right.
you'll work them,
Right.
Right.
but you wouldn't load
But
them.
you wouldn't load them.
Right. That might be like a medical direction thing, because we would have them call us, like call for online medical direction. We'd say, go ahead and call it or something. I mean, that, because you can always find a situation that's not gonna fit this, so.
Do we need the second bullet under includes?
So we have a withholding, we have now a withholding and termination, right? So on the first one, up in the top, have,
Yeah, because I don't see us withholding anybody yet.
yeah, when you arrive on scene and they don't have pulses when you get there, then you,
So then when we get down to blunt, then we can specify a little bit more what we're gonna do. That's what I'm saying, that's why I think we just say, let's keep it simple at the top, and then let's go down, because penetrating, you're getting less than 15 minutes, you're going to the hospital. Blunt, now we can be a little bit more nuanced.
Okay. And I would put the one you're gonna treat first,
Yes.
the penetrating above the the blunt. And I would also delete that second bullet at the top. It has nothing to do with inclusion criteria and
after termination.
so, you know, and why do we even need it? I mean, that's kind of a given, or is it an educational thing?
It's an educational thing.
Yeah, I don't think it belongs here.
Okay.
No, I agree with you, Paul.
Please don't agree with me, though.
Whatever you say.
So let's talk about blunt. This is now where we can get into a little bit more of, do we initiate or do we not? So we can get into some of the nuances. So I heard a few suggestions before.
And then we should put penetrating trauma above termination of resuscitation.
You're doing it right now.
Okay, thanks. No, but termination's at the top there.
So, and those are all down in ENTI and paramedic, but some of these are gonna be appropriate at the,
So let's work on the content first, and we'll get to the formatting later.
Okay.
The content is more pressing.
So if it's blunt trauma and they arrest, are we even gonna do any of this?
That's what we're getting at now.
So that's what I think.
I think for blunt, if they have a cardiac arrest in front of you, you should still consider bilateral, bilateral needles. I can't talk right now, sorry.
Agreed.
I think that should be included in there. Anyway, like, does anyone feel otherwise?
there's the potential for.
If it, yeah.
Right.
So maybe.
Yep. I'm good there. Yeah.
So question, arrest.
Witnessed,
Yeah.
blunt traumatic cardiac arrest.
But it's gonna be witnessed by who?
EMS will be with
EMS. EMS
With
witness.
EMS on scene.
Yep, EMS witness.
Yeah,
EMS, witness.
Under one.
And then I guess my only question is, rather than consider, perform.
We did consider, because a lot of people thought this is becoming a skills lab. Like, it's really indicated for everyone, there's not great data for that.
Okay.
And that was the debate that we had the last
Yeah.
time.
I argued for just do it.
The rationale for us for doing it is because, like, you're likely gonna call it, and for a lot of people, it's just like, we've done something. It's very difficult to watch someone pass in front of you and then just do nothing, versus, hey, we know that this may be the one thing that can help them. So that's why we advocate for performing it, but I very much hear what you're saying, so I just wanted to.
So could we, like, we were recently told,
Leave these two as they are, the penetrating blunt, and then where it says termination of resuscitation is appropriate, move that below the blunt trauma. And then that way we've done, okay, you've done something for penetrating, you've done something for blunt, now you're going into termination of is appropriate.
Yeah.
Period.
So the question, it sounds like what you're hearing you say is really there's three things. I show up and they're dead and I'm not doing anything. I show up and maybe they just died and I'm doing something, I'm seeing. And then I showed up and I'm transporting this patient.
and then they died.
Right,
And then they died.
Yeah, and they died away.
Right.
Those are like, that's our three.
And we could actually put, in the exclusion criteria up here, then, any traumatic patient who goes into cardiac arrest during transport, and that would just become an exclusion criteria.
That means you're just gonna work them.
Yeah, right.
That's fine.
And then maybe medical direction or something like that to the side if they're 45 minutes
You
out.
don't want to turn the engine
45 minutes out. If they're pulled over to the side of the road, then, you know, or the ambulance can get a number 6 hours later, so.
Okay, so there's a lot of good comments there, so just to make sure we captured all of that. So under the EMT paramedic section, we're gonna have penetrating trauma with the new verbiage. Then we're gonna have blunt trauma. Do you want to still keep everyone to give the first bullet under blunt trauma, and then do you want to consider or just perform?
I advocate for perform.
I would support perform.
Okay,
And then,
and then the third bullet would be the termination resuscitation is appropriate in the following.
Shelley, for the second one, rather consider perform.
or you would just say something like, if no return of spontaneous circulation, termination of,
If pulse is not restored.
if the pulse is not restored, termination of resuscitation is appropriate.
Shelley, white wine or red wine? What's your preference?
We're taking out bilateral?
No, you leave that there. So then you go to termination of resuscitation and go, and in front of termination, you put, if pulses are not restored, then I guess comma or whatever, termination of resuscitation is appropriate.
Shelley, you're awesome.
Yeah, I think that's what we're trying to say.
All right, and then now back up to the exclusion, because I think someone made a very good point in that, the exclusion, patient meets criteria for obvious apparent death. The other part is, patient.
Patient arrest.
Patient,
I've got a suggestion.
Patient
So I'm
arrest.
gonna say this second bullet, we can capture it in there. Patients who, lose pulses in transport. Yes, patients who lose pulses, or are, who, you know, are found in shock abortion or whatever. These patients should in general have done resuscitation.
And continue to the emergency department, yeah. Because then it becomes a logistic thing too, because we had one crew who called it in the field 3 miles from the hospital, and they sat on the side of the road for like 4 or 5 hours waiting for the ME to come and everything else. And we're like, why didn't you just bring them the rest of the way?
So capture that one.
we have a policy that says don't.
All right,
We
so
changed
the
it
second
for that.
bullet, patients who
Common
lose
sense,
pulses
But then
and routes
somebody does
to the
it and you're like,
hospital.
or
Really?
while under, while in EMS care, while, or during the incident, yeah, or like while under EMS care. Or no, EMS witness, EMS witness.
Patient arrest, witnessed by EMS.
But but that's, then we're talking exclusion, right?
Right.
That's one of our interventions is not.
So for that,
it's
it
not
is
just that term.
For that
It's
one,
very specific, it's someone codes in route to the hospital, so it's not mixed.
during EMS transport.
Yeah,
That's right.
during
Yeah.
transport.
During transport, comma, and then comma after, so it's shockable rhythm. Right there. Yeah, full resuscitation and transport.
Just here to continue.
Okay, so now I apologize, but what we've done now is say that you have to transport anyone who had a shockable rhythm at any time.
Yeah, that's.
I don't have a problem with
Like a colon or semicolon or something after shockable, these is not that's not an exception.
I'm kind of confused why we're even going into cardiac rhythms here for traumatic.
Yeah.
Well, I'll tell you, we
Okay.
just had a pediatric patient back during the summer who got hit by a car and was found in VF and shocked 3 times and walked out of the hospital when it was all done. Because he had a bunch of chest injuries, so
Okay,
you know what
so,
he had.
yeah, just like the guy,
Just like
the football player.
And
Okay,
we've had,
okay,
we
fair
have
enough.
a couple of other
Okay.
young people who get hit.
Most of the time they're not the shockable.
Most of the time, you're right.
Okay.
This is Dan. I'm not sure that case is pertinent to what we're talking about here. I agree with Frank that when we're talking end of life trauma, primarily blunt, and they arrest at any point, the likelihood of their survival is incredibly remote, and the likelihood that the rhythm that they're in when they are in arrest would alter their outcome for the group that we're considering here, I think is incredibly remote. I think, so I agree. Complexifying this with rhythms when we have essentially no data on traumatic rhythms it just makes it more complicated as far as I'm concerned. It's a rhythm that's consistent with cardiac arrest and it's blunt trauma. They're gonna die unless they're the exceptionally rare induced VF, which looks different than what we're talking about. My thoughts.
So just delete the shockable rhythm and a rhythm that changes to shockable and just have if they arrest during transport.
Yeah.
Yeah, just says patients
I'm
who
good
get
with that.
pulses during EMS transport should in general have full resuscitation and transport.
Yeah, I'm okay with that.
Take out that whole shock.
Yeah.
The whole thing all the way there. So after transport, so take out the SH all the way down and then go back to should and go back to should. There you go.
Yeah.
We can get rid of in general too.
Yeah.
Yeah, should have.
We can get rid of the comma.
Sounds good though.
Thinking about
By watching your feet. I can see you hovering right there.
All right.
So where do we capture patients who can have efforts withheld?
It's very common. Right?
Yeah, if they're found in traumatic cardiac arrest upon arrival.
With help.
Well, you could put that line at the beginning of EMT.
And I suggest we use right out in the senso. Resuscitation efforts may be withheld in any blunt trauma patient who is found pulseless, apneic, and asystolic.
The problem is the
asystolic
part.
Asystolic part.
Pulseless, non-pulseless.
I'm okay with pulseless and apneic.
Pulseless and apneic, yeah. Because we don't want to throw a monitor on.
No, because then you'll end up working.
Right.
So do it after that one? Do it after that one? This is resuscitate first, or this is?
Yeah.
All right, gonna read that again, that line.
above or below?
Below.
Right there. Resuscitative efforts may be withheld in any blunt trauma patient who is found apneic and pulseless.
I think you should say somewhere it needs to say in cardiac arrest, because they need a rhythm consistent with cardiac arrest, right? So just pulse is notoriously bad. So I would probably either add there and in a rhythm consistent with cardiac arrest, or you could just use the simple apneic and in cardiac arrest.
Instead of saying pulseless.
But then just for an EMT, that would imply putting beacon pads.
Right. And interpreting the strip.
And interpreting a strip.
Which they can't do.
No, I mean, just non-shockable rhythm, right?
You could put non-shockable rhythm, but once you, I mean, so EMTs they get a non-shockable, they stop, but every paramedic's gonna have to probably find a slow PE, and now they're gonna work.
Yeah, so I think the consensus, at least in the room, is don't put the monitor on.
Right.
Yeah. No, well, this is Dan. A person in with trauma can certainly have a blood pressure of 55 and have become apneic. That person may not yet be in cardiac arrest. So pulseless to me is not. So what I'm saying is if they're in cardiac arrest, we all know they die. And that, okay, case reports in the world literature, but they basically die. So to me, just apneic and pulseless in the setting may just be profound shock, headed for cardiac arrest. But I would not get into any rhythm issues specifically, just that their monitor is consistent with cardiac arrest, and it doesn't matter what the rhythm is.
But how do we remain inclusive of EMT basics?
They can't interpret rhythm.
Well, that's
somebody's in cardiac arrest.
Then I agree. In the basic setting, if they're apneic and pulseless and they have, it looks like they have massive trauma and they're dead, and they're arrested, of course. But so you may have to have a branch point in the setting of, where for providers, the providers at the level that can look at the monitor, they should have an arrest consistent rhythm.
But that would be most likely a PEA, right? Because if they're going to have a rhythm, like the majority of these traumatic patients are probably younger, healthy adults.
How about we just substitute efforts may be withheld with any blunt cardiac arrest trauma patient? Or any traumatic
if they're in cardiac arrest, I don't care what their rhythm is. If they've got massive trauma, if they don't have evidence of massive trauma, then it potentially was an electrical cardiac event that led to the injury. But in the setting we're talking about here, we're talking about patients with massive trauma who bled to death or have such a profound TBI that they're dying of their TBI in minutes, which happens. Go ahead.
So I was going to say, so I think that we're all saying the same thing here, which is essentially it's traumatic cardiac arrest. So let's just add the word traumatic, withheld in any blunt traumatic cardiac arrest patient, right?
Yep.
Sure. So
I agree. I agree. I was simply saying that when a provider can put a monitor on, then they can verify that their apneic pulseless patient is also in cardiac arrest. And it doesn't matter whether it's VF or PEA or asystole, they're in cardiac arrest and they're going to die. And I don't think it should then have electrical answers in a trauma patient. So I like that verbiage. It's just fine.
And then my thought would be that bullet should be above the other one. If they're dead, why should we provide resuscitation according to these cardiac or non-traumatic cardiac arrest protocols? Psychiatrist, say that again. So we're saying withholding or termination of resuscitation efforts. So that's why I put resuscitative efforts may be withheld first. And then the question is, why are we using these resuscitation protocols that are for primary cardiac arrest,
Oh,
or maybe, they're not primary cardiac arrest, they could be.
I think it's just because sometimes people will go in a trauma call and they realize
It's
clinical
a cardiac,
damage, I would
yeah.
do my cardiac arrest.
Okay, so leave it there, because we got nothing else, okay.
Correct, yeah.
Okay, I'm fine with that, yeah.
And
I just wanted a second, okay.
And we only have one of those now.
Yeah.
Yeah.
We've got that, already got that.
Okay, I can see we got nothing else.
That did need to be cleaned up. We spent, I think, 2 hours plus on just that one guideline for last round, so at least 2 hours.
I'm so sorry I missed it.
So, it's from me trauma.
Well, and I think that's okay, the gravity of, yeah,
Absolutely. I need to be sure.
yeah.
Extremity trauma. External hemorrhage management.
Do you have any recommendations?
I read this, I didn't make any changes to it. You know, the one thing that bothered me the most on reading this entire thing is the sodium bicarbonate. And that would have, you know, if I was gonna use a drug first, it'd probably be calcium. I wanted to say that, you know, to bring that to this point and say, you know, well, what would I do first? But that's me, and I don't know, what others feel.
I had the same thought.
You can move down.
For significant crush injury or prolonged entrapment, I would just say, consider, do we have that hyperkalemia treatment protocol?
And it's referenced in changes in hyperkalemia.
Yeah, and I don't even think we need to EKG changes in hyperkalemia. I'd just say hyperkalemia treatment.
But they have no way of diagnosing that.
Yeah, but just the setting here,
Setting one now.
you don't need EKGs. If you think you have a serious or significant crush injury or prolonged entrapment of extremity, you would probably start treatment well before releasing that entrapment. True crush injury. That's prolonged.
So are you saying this does not refer to the proper hyperlink? Should it just be the?
We don't have a hyperlink hyperkalemia treatment, so we basically just, because they don't have labs, especially we have a EKG output, like what it would look like for them, more educational.
Okay.
So that's the hyperlink for. The actual treatment for hyperkalemia is intervention at the bottom.
Gotcha.
So what we could do is move sodium bicarb down.
Below.
So significant crush injury or prolonged sodium bicarb, move that after the other treatments. Is that what you're recommending?
That's a good idea.
That's the easy fix,
Yeah,
right?
thank you.
And I don't know what is carried, gluconate and chloride or is it?
No, I think we had a gluconate because for a while calcium chloride was on shortage, so I didn't get it. But right now I think that both of them are options.
Yeah.
And did we change any of the gluconate or chloride stuff, or just discuss it? And just make sure it's the same everywhere, that's all.
We said 100 when from this morning.
Yeah.
For the gluconate.
Hey, Frank, maybe I misheard. To me, the treating of with calcium just for the setting doesn't make sense because, from my understanding, the reason to give calcium, and the few times I've done it, the reason I give calcium is for its membrane stabilizing attributes for patients who are having the cardiac changes. That just giving calcium is not in itself a treatment. The purpose of the treatment is to prevent potentially hyperkalemic arrest, right? Am I missing something?
Oh, no, I think you're correct.
It seems to me like without EKG changes, I don't see any reason to give the calcium even if they have a crush injury.
Well, I guess I would say this, and this is from talking to folks who did extensive work in China with crush patients. They would apply tourniquets before removing the crush. They would start treatment for hyperkalemia before relieving the crush, because when they relieve the crush, they would go into cardiac arrest within a minute or two. So, you know, you're talking to somebody who's
I
in their
agree.
cardiac arrest.
I agree
But-
if you're planning on doing something, but just saying if they have a functionally, how's this going to play out in the field? Oh, this patient has a major crush injury. I'm going to give calcium. I think that if they don't have cardiac changes yet, and you're not imminently going to markedly, dramatically increase their K in the next few minutes, that's going to go away. You know what I mean? The effect for which you are giving it. That's what I was saying. So it seems to me it's perfectly reasonable to link the giving of calcium to the EKG changes, or if you're going to release tourniquets. But to me, I would be just the idea of, oh, crush injury, I give calcium, doesn't make any sense at all to me.
Yeah, no, I'm okay with that, Dan, and I think the way people as are suggested in here, and I think it's an educational thing. If somebody has a truly severe crush injury with prolonged entrapment and/or tourniquet.
Well, I think, you know, there's a lot of literature that's come out of Israel over many
I'm
years.
gonna go ahead and move this along.
So,
Yeah, I'm okay. Yeah, I'm okay.
I love the theoretical debate, but we have got a lot.
Yes, I'm okay.
So. All right, anything further? So
sorry.
we're gonna move the sodium bicarb statements down to the fourth drug to give. Yes.
Under calcium chloride, 1 ml a minute has its own little dash mark. I think that's just an extension of the sentence above it. You have to, and it's the same thing on the
Like it
feed side.
the version, so there's something funny.
Oh, okay. Never mind then. So then,
Yeah, there's something where.
You can tell me to be quiet, but just on the top there, the list of deformity, neural, pallor, pulse, just to capitalize the first letter for each of those. At the top. Evaluate 4, and then let's all use have the first letter be capitalized. Thank you. OCD kicks in there.
All right, anything further on that one? And some more, were there any recommended changes to that?
It had reference to the step 3 from the old field triage guidelines that needed to be removed. And, do we want to say anything about, you know, GCS? I'm saying no, I would just leave it as is. Any alternate mental status, GCS less than 15. Just to keep it unless somebody's got, let me give that a gap, but, you know, it's fine, but.
Anything else on that one? Okay. Next one should just be the ADHS algorithm.
Right, maybe 2021. Is this new as the current field triage up here like this? Because this is also in the appendix, I think.
Yes. So we moved it here as well, just because it's with the trauma algorithm, so if people are going to general trauma, we figured it's okay to have it here. The doc section for students. Burns.
One thing I changed was the oxygen and monitor oxygen saturation and provide supplemental oxygen as needed. However, for people who are in a confined situation, they deserve to be on oxygen regardless of what their oxygen saturation is to drive off the carbon monoxide type of situation. So
We should probably word it as administer high flow oxygen.
and the high flow is how we refer to it in other places. So
So place on high flow oxygen.
high flow, or the patient rescued from confined state, or inhalation injury suspected, or something like that.
And then how do we want to handle the bottom bullet under EMTI paramedic? If thermal injury, airway is suspected, refer to airway management. That probably needs to be bumped up higher to a different skill level.
We can just initiate universal care, refer to airway management as indicated as well.
In EMT, if the assist respiration is needed, you could just say, okay, you could just do that last bullet point up there.
maybe have to just, we can kind of refer to airway management as indicated, so we can probably.
Yeah, do like things that like.
Do we want to have a specific call out on the thermal burn to airway, concept, or no?
Taking out black.
So in the setting of airway burns, they have signs of airway burns, they're getting hoarse. Is a supraglottic airway an adequate replacement for intubation?
No, it's gonna kill
So it's not right.
It's not right.
So we could put, if thermal burn, airway burn is suspected, consider intubation down in the paramedic IMP slot.
The one thing to keep in mind though, so the majority of the state's not in RSI. So unless you're in respiratory failure, performing endotracheal intubation, they're not going to be able to perform that. So same thing, I think vagueness is probably better because the majority of the state does not have RSI. And so if there's still a way to some degree or somewhat airway reflux in place, you're not going to be able to intubate them.
Well, but it needs to drink in, but
maybe we ought to say avoid, maybe we ought to tell people not to use the supraglottic airway.
well, in that case, we need to move that up
To avoid potentially fatal intervention, you got a partially obstructed airway, and then you shove something down there blindly and obstruct it completely.
yeah, we should move that up into the EMT section then, so they're not using SGAs under STR then.
So that we can use the exact same verbiage we have throughout the document about refer to airway management, and then period, do not utilize supraglottic airways for burn management.
Yeah, for airway burns.
For airway burns.
Yeah, period.
Done.
Or use.
Yeah.
Do not use supraglottic airway for.
Yeah. I like.
We're doing research on that one.
So, just some real simple stuff too. We say exclude chemical and radiation burns, and we ought to say it in the same order. Refer to chemical burns and radiation exposure as needed. So just reverse those two. And then in the middle under EMT, it says refer to cyanide poisoning, carbon monoxide smoke inhalation. I would reverse those two and put carbon monoxide smoke inhalation first and cyanide second. We've got some people getting cyano kits that really don't need them. I don't want them to forget about it, but I want them to manage carbon monoxide and smoke inhalation first.
Flip the order.
Yep, that's all.
Okay.
Real simple.
Flip the order. Okay.
Yeah, those two just.
Okay.
One of the other things that came across was under AEMT, establishing IV access, avoid placement through burned skin. But that, if feasible, it's
Yeah, no, I like that.
You can, if you have to, if that's all you got.
You
that's
got
what
it.
you do.
Is it worth putting something under paramedic about being aware of the need for a surgical airway? These are certainly like the high-risk patients. You don't have RSI, their airways failed. Innovation isn't going to necessarily work if their airways swollen shut. This is like the high-risk population that you're going to be breaking.
Maybe there's something at the very
So
bottom that
just something
says,
to the bottom, like be aware.
prepare for a potential surgical airway if indicated. Or something like that.
It's down here, right?
Not surgical, I don't think.
And then we just changed it too. We got rid of that line. So just
okay,
with something else. Okay, I think you don't have to. Just to.
Yeah, I would rather say, if it was me, I'd rather say something like, consider intubation early.
Sure.
Than to say, this could be a surgical airway. But I know in situations consider going that direction, but that's just me.
Fair enough.
Just to clarify, because we've had lots of different discussion, make sure we capture it. So we have at the very top, it said initiate universal care and refer to airway management as indicated. Do not use supraglottic airway for airway burn, period. At the bottom, are we getting rid of the thermal burn bullet to confirm? The bottom.
The last line at the bottom, yes.
Yep. To confirm that.
Because we covered it way up above. Just a real quick point, we talked about removing jewelry here for burns. I think we ought to have that in the extremity trauma too. We don't want people coming in, or we want the rings off early.
I don't think it's as much of an issue when you have bleeding from the extremity as opposed to, the swelling you're going to get from the resuscitation. But that's, I don't.
Oh yeah, That's a big point. No, and I'm talking about the extremity trauma here rather than the extremity bleeding.
Okay.
So like, yeah. I mean, we can't get the rigs off usually at the hospital, but if they can get them off in the field.
I think it becomes an issue when we're starting to remove text jewelry, people lose it, and becomes a complaint to EMS.
Okay. We're gonna cut them off at the hospital. Okay. Thank you for that reality.
Personally, if it was me, I would remove it from both because it's a little thing compared to.
Okay.
So that's just me.
I hadn't thought of that.
Trust me, you get the.
No, I get it. Where are you at?
One chair that's there.
Lost it, right? It's your life,
I reference with the latest, trauma center burn.
Okay, so it's in the red, okay.
I can come across anything that was.
The only thing I saw in the green box, I pointed this out. So this says that the homeowner rule does not include the fingers. Just need to.
You know, I've heard it both ways, and I'm no burn surgeon, so I would refer to.
My research is clearly, it's the patient's entire palm, including fingers.
Yeah, we updated the Central Region 1 from that, so the palm of the person is.
On the website right now.
We will match.
The people who did it just move on palm hammer and switch exactly.
Yes.
That's in your home.
Okay, I'm just gonna, I'll understand.
So ramp, just to kind of clarify, this is something that the Central Region has adopted. We have not had any previous triage guidelines in our CPDs before. So if the group said scratch it, we can scratch it, so that was.
And, you know, when I looked at this, I said, who's using what? You know, is it the start, is it jump start, is it ramp, is it salt, is it, who's got what? We're talking about one, do we want to say there's one's out there and you ought to train for it, and there's no way to make a page worth of training that's going to matter.
Right.
So to me, I would leave it off unless we really, really wanted to get into a situation where we tried to explain why this and here's that and here's some other options, and nobody's ever shown that one's better than another. And so,
Yeah.
well, a number of years ago, and every region adopted it, was called the Arizona Start Triage. And Downtree even made kits for the Arizona, and every region, and I think the state has adopted it, but I know a lot of it has fallen off. So, and maybe, you know, because who knows, but some of us older folks.
And the big reason was, I think they wanted to try and simplify it as much as possible, recognizing that you're going to have. So if we're not doing it, please move on. Okay.
Well, wait a minute, before we do that, spend a good 15 minutes. I'm sorry. All right. Remember, you invited me.
Welcome.
You're welcome for me not showing up, you know, the other 2 times.
I had comments on the thoracic one.
Yeah.
So it looks like, we have several edits that Dr. Dabrowski made.
So they just, what are yours, and we'll get.
I was mostly thinking, you know, none of our other protocols really have like step-by-step per procedure. So I don't know if that stuff is really necessary. You know, I think it's simply like, this is the indication for the needle thoracostomy performance. But I don't think we need to add all the other bits, even though it's valuable.
This was added in the Central Region because people felt like they didn't do this a lot. It was a useful tool.
Yeah, and I'm
something they don't do frequently.
I would actually like to keep it in for that same reason, is because, you know, we do their skills, you know, quarterly ideally, but how often are they ever, or if ever, going to do it? So it'd be nice with a quick reference.
And certainly in the last 10 years, there's been a lot of looking at, you know, needle decompression of what we thought needle decompression did and how frequently we thought it was successful when we missed the chest completely, and et cetera, et cetera. So point of fingers or costomies and things like that. And so I think it's a reasonable tool. However, it might get a little down in the weeds regarding this is a procedure type thing and how to do it. And every organization is going to say, well, this is how we want to do it. And this is where we would expect you to go first and then second. And I don't know. That's not me. So how do you guys feel about that? Yeah, guys and gals. I think, Dwight, at least under paramedic, we need to add EMTI there. Down to procedure, doesn't, there's reasons to do NBC like we have in a lot of other places, but leaving off the procedure. I mean, who's going to rip this thing out on scene with a patient? If you think needs a needle decompression to make sure you're reviewing, this doesn't seem, they should be picking that up somewhere else in airway skills labs or whatever.
Maybe that's like an appendix. Some of the other things.
That'd be pretty good.
Yeah. The only thing I would add is maybe the gauge of needle for the adult, because you referenced it for pediatrics. We don't put a gauge for the adult.
I like the idea of reference, because then if there's at the station happen to be looking through it, it's a good, quick, easy reference. But then when it's time to do the procedure, right, they're not going to be moving out.
So we're gonna say from procedure down to go to the appendix.
Yeah, but that it was maybe a link to it, so that if they needed to, they could link to it.
Should we keep needle size?
For them? I think so.
Yeah. For needle size, Gail, the latest data is to recommend, to remind the providers that the standard 1 1/4 inch needle length is appropriate for pediatric.
Okay, so we've got two, so the adult one, we don't have a gauge. We have a gauge for peds.
The minimum 14 gauge for adults.
Yeah.
Is that a manufacturing issue? Like, aren't these 7 centimeter ones all the same size or no?
No, because you get 3 inches and 10 and 12 gauges, which was what we were buying years ago.
That's not appropriate.
What that?
That's not optimal, right? It's too small.
10 or 12 are way bigger than 14. They're what? Yeah, we were using. Bigger for economy will be coming soon, probably.
All right. So
For pediatric, I'd just say 1 1/4 inch.
And IO needles are not long enough. Yeah. I mean, they're, except for maybe the yellow one.
Yeah.
The yellow one is, what, 45? And, but all the rest of them are like 15.
Right.
They're short. And they're just not gonna be enough.
I'm sorry, do we want to specify a gauge for adults, yes or no? So what number minimum gauge do we want to put?
I would say no. Personally, it's good. It's more dependent upon the length of the needle, and I would let people figure that out for their own.
All right, and then peds, we've added the 1 1/4 inch, move this section to the appendix and have a hyperlink to appendix.
Yes.
Correct?
Just a quick question, is anybody doing needle, I'm sorry, not needle, but finger thoracostomies in the field?
Only nerve active and flying.
Okay.
Yes.
I didn't think so, but I wanted to ask.
Soon coming, but anyway, not from me. Just a couple of times if we go back to that other one, just we'll make sure people were okay with it. I can't remember what assessment said before I changed it to assessment, but
Signs and symptoms. It said signs and symptoms, which I was going to advocate going back to.
Okay. I don't think mine said signs and symptoms. I think it said like treatment or
It says management of suspected tension pneumothorax.
So that's really not. It's really not management.
Expected change to potential everywhere.
Yeah, signs and symptoms.
Word spiffing, and then stabilizing flail segments. Anybody do that?
Yeah, I would take it out.
Back in the day, and then code 3.
Right.
That should. If that's gonna be there at all, it needs to say lights and sirens. That's what we need.
Rapid
Rapid transport.
Yeah.
And then
And then, just below paramedic, the first bullet point, these signs include increased respiratory rate. I don't remember what it was. I think it was like 15 or something.
Can I suggest that we just remove all of that with the rate and just change to respiratory distress or difficulty with BVM ventilations?
We also have hypertension, deteriorating loss of consciousness, and we just delete all of that, we use that verbiage.
No, I know, just the part that says increased respiratory rate greater than 29. Replace that with respiratory distress or difficulty with BVM ventilation.
I think respiratory distress is fine.
Okay.
I would leave it at that simple because there's a lot of different reasons you could have trouble with vague valve mass, acute blood.
And shock's an important one too, I think. So,
Yeah.
Between the respiratory distress and shock, this is the real reason that they need a needle.
And then this is an adult and pediatric, so we need to get rid of the SBP 90 and put hypotension according to age.
Yeah.
Oh, this is hypotension, and read off the number.
I think it's fine.
Yeah.
Okay. And then to your point, under the includes criteria, under signs and symptoms include blah, 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 blah. Somehow decompensated shock / traumatic cardiac arrest fell off. And that goes to what you were saying, but that's the biggest, that's one of the biggest of all. So that should be added back. And then I was going to also suggest agitation / restlessness, but there's probably semantics at this point.
I don't think I took it off, but I don't know
I don't know
how.
about agitation, think about how many, I mean, then would we need to look at, how many patients who are just hypovolemic, hemorrhagic shock or agitated?
Then I would just add back to that with decompensated shock / traumatic cardiac arrest. That's right out of an essential.
Sure.
All right, would you do the second?
Yeah. Ball injury, minor injury, lift assist.
So this I will just put out, this is a central region guideline that had been in place for many years, so for those not in the central region, before we get into big discussion on adjusting this, do you even want this added in? I think that's the question number one.
Hard no. The pseudo diagnosis that that is a way to bypass critical thinking.
So I hear do not keep, so rather than debating it, we'll just.
The only thought I had on the perhaps secondary management, these that develop more rapidly in patients on a ventilator, or should we just say positive pressure ventilation? Because most of these patients will be on a vent.
Oh, yeah.
They'll be in bag.
Back to thoracic trauma.
It would be the second bullet under paramedic.
These signs develop more rapidly in patients undergoing positive pressure ventilation.
Commonly leading to sudden cardiac arrest.
They're undergoing positive pressure ventilation. Good catch.
All right, last page. Trauma, brain injury, epic TBI.
I think that the state had made some of that Shelley had made that we went to PMD and MBC before.
I didn't understand, I crossed out that entitled CO2, SDR for, because I didn't understand what that meant, but if that needs to be there, by all means, it needs to be there, I was like.
Yeah, no, it needs to be there, and everything the AMT's gonna end up in the EMT.
I was like, well, there's just too many letters for me.
Abbreviations.
So, the other things I found along the page was the down under AEMT, systolic blood pressure approaching. The numbers used to read 90, and it's really the recommendation is 100. Certainly 90 is what they use for the inspector space, or what they use for the initial description for shock for the epic. but really the recommendation is 100.
And we're saying.
Dan, can you hear that?
Yeah, this is Dan. Yes, the new guidelines will be published. They're in press. The new guidelines will be published soon. And the new traumatic brain injury guidelines from the Brain Trauma Foundation and is now defining hypotension in the setting of traumatic brain injury, potential traumatic brain injury as less than 100. So that change would be consistent with what the new guidelines will be in a few months. And the reality is, in our probably the biggest study in the world so far has been EPIC, that links pre-hospital data to in-hospital outcomes. And the reality is there's no evidence of an inflection point of altering the impact of blood pressure between 40 and 120. You have to go all the way out to 125 or 130 before you start seeing any evidence of flattening of the mortality curve. So the move to 100 makes sense. It will be consistent with the new Brain Trauma Foundation guidelines that'll come out in a few months. And my only comment is the less than 100 down in the AEMT box is correct. We should put greater than or equal to 100 on the one for the repeat, just so we're not excluding the number, the systolic blood pressure of exactly 100. And then my other comments are, I would strike on the second bullet in airway breathing under EMT. I would strike the word near from right before 100%, and would suggest the target be 100%. That's based upon, for those of you who were at NEMSP and saw the plenary presentation that we did, it is really quite striking that there is no hint of an inflection point for the lowest EMS saturation and versus mortality, even in the model. So adjusting for all of the relevant confounders until you get to 97, not 90%, not anywhere near 90%. In fact, if you have a single pulse ox documented in the field of 89 or less, it independently triples the likelihood of dying. So the reality is there's nothing magic about, oh, good, we're at 90 and we never drop to 89. The reality is all the way until you get to 97, there's no inflection point. And then the other thing that is particularly important is that those patients who always had 100% oxygen in the field, they were 2.5 times less likely to arrive at the trauma center hypoxic, meaning a sat less than 100%, than anybody who had any saturation other than 100% in the field. So everything in that, plus the Hobbit trial, which is randomizing early patients now to actually hyperbaric oxygen during the acute resuscitation. A lot of you are familiar with that trial, I'm sure. All of that put together, it would make sense to press toward moving the idea that they're not okay if they're just at 93%, because what that means is it appears that what that means is they're not pre-oxygenated for the next crash, and they're much more likely to get hypoxic if they crash and if they have to be intubated. So to simplify that, I would personally recommend that we strike near 100% and let the target be 100%. I don't think we're in a, go ahead.
I said, you told us already, Dan, it's deleted.
You have us at hello.
Okay, great. By the way, I would suspect if we had been able to write the papers as faster than we have been, I suspect the less than 90% would have dramatically changed. But at this point, I don't think we have enough time to talk about all the reasons why we should do that instead of the Brain Trauma Foundation guidelines, which will say less than 90%. But I suspect the next Brain Trauma Foundation iteration will be that you want it to be 100%.
Very good.
The problem with
Dan, sorry, we're going to have to keep moving. So you have us all sold on the data here. So if you're good with that, you got us sold. Keep the blood pressure up, keep the pulse ox at 100%.
And a quick change, just for AMT, for systolic blood pressure, get rid of the word approaching, just say less than 100, just so it's consistent.
Yeah.
Actually, approaching is exactly what we taught in EPIC with the 90. The idea is you don't want to, if you have a single blood pressure below 100, you have a adjusted odds of death of almost twice than if you're above that. So the concept is not to wait until you pass the magic hypotension threshold and then treat. The idea is to prevent them from getting there, and that's what the guidelines say. So approaching there is actually specifically the guideline verbiage. It's prevent hypotension is the recommendation, not treat hypotension, but prevent hypotension.
Two simple changes. The word search for suspected won't catch suspicion of. Way at the top under includes, and it just say with potential for traumatic brain injury.
Okay.
And
Pick up,
then,
Frank. Way to go.
Yep, no, you've inspired me, Dan, as always. And then under the second bullet under airway breathing, I would say rather than at 15 liters per minute, I would just put greater than or equal to. And I think that's consistent throughout.
So, non-breather instead of at 15, greater than or equal to 15.
We said high flow everywhere else,
Yeah.
and we wanted to say.
Or, yeah, if you want to say that, yeah, I'm fine with that too. But again, since our goal is 100%, we want it as high as possible. Yes. And that's greater than or equal to 15 or high flow, if everybody understands it as that.
Yes.
Dr. Spate, on the pediatric side for IV, it says greater than or equal 10 years with the SBP at 90. Is that appropriate, or should that just go ahead and become the adult one also?
You know, the bottom line is at this point that level of detail we don't have from what's going to be published. So at this point that leaves kind of the strange thing of if you're 11, then your cutoff is 100, and if you're 10, your cutoff's 90. I would suggest we not get into that nuance yet because we don't know what the guidelines are going to say. I would have recommendations, but at this point, I think we should just wait, leave it there, and have people recognize that there's going to be almost for sure will be a change. But for right now, we just don't have the guidelines to do it, and I think it'd be way too long for us to work it out in this setting.
It looks great. Keep it going. Okay. Any further comment or discussion? All right. PMD goes first. Anyone opposed to the recommended changes, please say nay. Any abstentions? All those in favor say aye.
Aye.
MDC votes. Anyone opposed, say nay. Any abstentions? All those in favor say aye.
Aye.
Next for environmental, there's a proposed, this was a request that come in. I think Southern Arizona has something similar. Central Region adopted this. So the question is first, do we even want to include this? This is an emergency rehab operations guideline, kind of for essentially fire, PD, EMS. So it is an operational guideline, but it does because many of these rehab encounters were including IV fluids. That is a patient care encounter. So I just bring that up for discussion before we debate this. Do we want to even include that? That's kind of question number one. I see head shaking no to not include it. I see one yes.
I think it's useful, but I'm fully either way on it.
It can be certainly remain regional, so I just want to put that out there so everyone knows where this came from. So does anyone want to include it? Hearing none, we will not include, so we will delete. Right. Hypothermia, there was a couple things that I've highlighted in red. There is there's really a lot more data supporting high staff devotion and kind of staying on scene to do that, rather than kind of scooping and running with this patient population. Now, it can be very specific to if you have a setting where that's actually being performed. So that is some of the verbiage that's being added on here. So just, and then also the subset had a little bit more clear language in regards to, if ISAP emergency is not available, consider the following. And then they talk about some specific interventions. So what's red is added.
The tarp-assisted cooling oscillation, I claim ignorance of that. Is that even something that anybody knows here in Arizona? Is that defined somewhere?
I wasn't sure what that was. TARP is just cooling with oscillation. The idea is they just want to keep making sure there's cold water next to the body. Like, I've never utilized it, but I've read about it as well. The oscillation is just, again, because otherwise you make a little more bubble around yourself.
Right.
But the biggest thing is like, and it's kind of sort of the next one, rotating ice water soaked towel sheets. You're not like putting cold on, leaving it on. You need to keep removing it, taking that off. So we could strike the TARP assisted cooling oscillation. Okay. And then under the dose for the shivering, which I think would be very rare, we're doing this at repeat, but I put in red, Nasumsa's dose is different from midazolam and diazepam. So in red is what is in the Nasumsa. So I don't know where these current doses came from. I just put this out as a consideration.
Was the original dose in black, was that what used to be in our guidelines?
That's what's in the current version, is what's in black, and red is what the Nasumsa has listed. So I just,
For this indication?
Then I would go with the Semso. And that might,
and then we just need to do a max dose, would be the biggest thing for that.
Frank, does it make sense that the IV dose of midazolam for a pediatric patient would be higher than the IM?
Absolutely not. It doesn't make any sense to me. So you're saying give a 10-kilo kid 5 milligrams of midazolam?
Well, you could max it out. So we could max it to the adult dose. Right now, there's no max listed at all for peds, which is probably an issue to begin with. So the current dosing does not have any max listed. So the census is 0.5 milligram per kilogram, max single dose 2 milligrams. For the IV, or 0.2 milligram per kilogram IM, max single dose of 10 milligrams. Again, I don't know that I've ever seen this given for shivering in a adult or pediatric patient, so I don't want to spend too much time, but just want to point out that the dosing was different.
I almost wonder if it's a typo on their end to be 0.05.
Because I'm thinking about that, like, so a 4-pound baby would be getting a full milligram of it.
Yeah, like that. It doesn't make sense.
Maybe we stick with our old one.
Well, yeah. I'd rather have shivering than apnea.
Right.
Once I did the calculation, I was like, wow, that's a lot of drugs.
Just saying.
So let's maybe at least put a max dose, because right now there is no max dose for peds.
So
But you got it right there, max 1 milligram.
Not for the IV, that's next to the IM.
But it's read this or that max 1 milligram.
You could go
No.
so you can just put 1 milligram on both, I guess.
I don't know.
Yeah, I'm okay with that.
Something weird on how this, there's only a max next to one of them, the IM
We could
one.
put the same on both.
Yeah, so just put max 1 for both.
And then the diazepam, Nasumsa had a lower dose, they had 0.1 milligram per kilogram.
And I'm sorry, are we getting rid of the, for midazolam, 0.5 mg per kg then?
Yeah.
Okay. Cool, thank you.
And so the diazepam, the Nasumsa version for IV is 0.1, we had 0.2.
I'm okay either way. And since it's for shivering, let's go with the lower dose.
So
0.1 mg per kg.
They make the max, they have 2.
Yeah.
I think it's reasonable, but it's going to be an exceedingly rare indication.
Yeah, and then do we want to put anything like you're saying, how long the lines of the cold water bath immersion? The stuff that I've read is, you stay there till their temperature gets to a certain level and you don't actually transport. Do we want to even go down that way or leave it to the medical directors to give that kind of direction?
How are we measuring their temperature?
Core temperature is what they're supposed to, I mean, this is all theoretically when you look at the marathon ones and all the other stuff.
What we did in the central region to kind of, we said, consider maintaining cold water immersion if already instituted, so it gives you a little bit of vagueness to be able to.
Okay, so just kind of leaving it a bit vague, and then
Yeah.
they can always call in.
Because the data is definitely pointing to that, but I think it's, the vagueness kind of gives people the opportunity for that.
Okay.
Yes,
Under the third from the bottom under EMT, you always read this continually missing the exposed skin, and you see these people with these little spray bottles, and then you have the fan, and the spray never gets on them. So I don't know how we should say it, but I say keep them sloppy wet with a fan on them. So I have usually a medical student who's very compulsive, bringing out a towel, a cold wet towel on them, with the fans going up, one at the head, one at the feet. I mean, if you have a misting tent like they do at the Hajj, that works, but in practice, these little squirt bottles don't work. I don't know if anybody has better. Continually soak patient's skin while fanning.
I think it's gonna end up being pretty specific to the agency. You know what I mean? Like what resources they have are gonna dictate what they're able to do.
So you think an education thing is worth?
I think that's an education thing, because like for us, I couldn't even imagine being able to pull this off. Like we have no resource to do it.
You don't have fans.
I mean, not in our.
No, you don't have a fan in your truck.
No.
No, I get it.
Yeah, and we would have a pool to put them in, you know, to make a cold water bath. So it would be pretty much.
If they're in the house, you put them in the tub.
Maybe.
Yeah.
Yeah. Well, I think it'd just be specific. I think the general idea that's there is clear enough, and then they're going to have to figure out. The provider will have to figure out how to make it work.
I'd say continually wet the exposed skin. Get rid of that misting stuff.
Yeah,
continually wet.
Sure.
Yeah.
Yep. Opposed to fine mist, we're going soaking you.
Yep.
That makes
We're going to do evap cooling, and we're going to make sure the water hits you.
Brings us to drowning.
Yeah.
let's see, drowning, which is next. The only thing that I considered to put add in there under AEMT, which could also then be STR, is consider CPAP and avoid patients with respiratory distress. So that would be STR, we need to move above, but we just didn't have that in there. So I think kind of recognized we wanted to have that.
I'm okay with that.
Has anybody ever gotten a question during educational sessions about PEEP valves for this patient population? Because that's not mentioned anywhere here. PEEP valves on a BBM.
Yeah.
Probably ought to be using those anyway.
Yeah.
Okay.
On everyone.
Then the only other thing was I would further open the line that says consider possible spine injury to remove C. Yeah, and remove C dash in this case. We keep it as spine injury.
To your point, under the, as if you go back to NTI section. So under escalate, we could do a sub bullet under the first one. What we added in the central region was consider PEEP and indicated to support oxygenation.
Sure.
So that is a question I think has come up. And then the question is, do we, the central region has 5 to 10 centimeters of water as indicated. You want to have that as a range. So we consider PEEP 5 to 10 centimeters of water as indicated to support oxygenation.
Sounds good.
So you could just put centimeters H2O. And then is that a paramedic EMTI skill?
Oh, I'm looking that up to see if there's anything, I don't think it says anything specifically about PEEP, but we might be able to say it falls under like CPAP or NIPPB.
Right. Because even those PEEP valves where they're at 5, right? Like this, and that's I've always told them, our crews, that's an EMT basic skill. Yeah.
Because they're operating with DVM.
Right.
It's part of a DVM.
Yeah, honestly, it's safer, you know, in some ways. Yeah. Yeah. It's part of the device.
Yeah.
Right.
So I think that's EMT.
Okay.
Yeah.
And then, yeah, and it would move up and all the other stuff move up. Yeah.
So then really the first 2 or 3 bullets, so escalate airway management is indicated, as ventilation is indicated, sub bullet, consider PEEP 5 to 10, and then the next one, initiate cardiac entitled CO2 monitor would move up.
Right.
Cardiac monitoring is not a EMT skill.
Right. Let's
got an EKG, would be done with. Yeah, but it wouldn't be
No,
on
cardiac monitoring.
Yeah, right.
Josh, I see your hand up.
I'm sorry, it's been up for a while. I have something on the drowning to go, I'm sorry, the hyperthermia to go back to, but finish the drowning now.
Okay, sorry about that. We missed you there.
So are we deleting the escalate airway from both the AEMT and the paramedic and moving it up to the EMT then?
Yeah. Yeah.
And then just scratch those off the alarmants.
So we could say initiate universal care and refer airway as indicated at the top.
Yeah.
Or, because we've had that anyhow, that you can just refer to that one, and then we can still have specifics in here for drowning, which is that consider CPAP and await patient's respiratory distress, and then also the two kind of drowning specific things.
Yeah.
So we have a line up here that says assist ventilation is needed. Are we going to have the escalate airway management, or are we just, where are we going to move the PEEP to?
PEEP will get moved to EMT.
Right, but is it going to be after administer oxygen? We could put escalate airway management as indicated, assisted ventilation, and then with a bullet point underneath, if BVM use PEEP valve 5 to 10
Why don't we
centimeters.
just go right where Shelley is right now, assist ventilation is needed, period, and then add the PEEP part right there. Just call it a day.
If BVM use PEEP valve 5 to 10 centimeters. And then we just delete those two lines down below.
Okay. Yeah, so take off the word use, and then you can say consider PEEP 5 to 10 centimeter H2O with BVM.
PEEP valve.
There you go, yeah, PEEP valve, and then you can take off the F from centimeter.
Do we need to initiate pulse oximetry down at the bottom of that spot? No, I mean, that should be. I think keep that at 94%, but
Yep,
consider
yep,
O2
yep.
that's for.
Yep, delete. So then we can delete escalate airway management up there under AMT.
Yeah, because everything from AMT is going up. Just have to consider IO.
And then what about the NG too?
Yeah, NG is.
Yeah, we'll need to leave that down there.
Yeah, AMT, or ENTI, yep.
And then we have a line up there that says consider hypothermia, and then it says and treat as indicated. Should we reference that to the hypothermia guideline instead?
Yeah, consider hypothermia and then refer to hypothermia.
And then we just need to finish up the end title to EMT somewhere.
So that's a global,
Oh, that's right.
yeah, the end title, anywhere there's end title feedback that will also be the global. All right, anything further on that one?
What was the one you said, Brian, you said NG, or you said one more for paramedic?
Yeah, the NG and OG are in the EMTI and paramedic. So that line is.
That's right, but there was one other one you said for paramedics, should you get put in there? Paramedic skill, IO.
Oh, no, consider IO for the AEMT. That'll be the only thing that'll be left on that line. Well, that was part of the big change earlier.
All right, Josh, back to you on hyperthermia.
So I think we have two comments. My first one is on the ice water bath submersion. We have a manuscript in peer review currently that's a case series of 22 patients with severe hyperthermia treated with ice water submersion. The real take home from that manuscript is it's virtually impossible to tell when the patient gets too cold. And it's very, very, very easy in ice water baths to overcool patients. The initial patients in this case series were all cooled to about 90 degrees Fahrenheit inadvertently. And without active core temperature monitoring, it's super hard to figure out when to stop ice water bath submersion. I'm not saying it's not something we should do. I would recommend that at the end of that sentence, we say discontinue ice water submersion when temperature reaches 101 degrees.
I'm okay with that, Josh, and just from personal experience, yeah, it's hard to tell. You got to have active core monitoring. I don't know how to do it in the field without rectal thermistors. And anytime I do it with a temp probe pulley and a rectal thermistor too, because you can have a bad read and agreed with issues I won't go into here. Overcooling.
I would be curious.
And we're okay that the standard practice is going to be there using non-invasive temperature checks.
Well, that's what I'm wondering. I'm curious how many agencies even carry a rectal thermometer.
No, I'm not saying that they should. I'm just saying I don't think this is practical.
Yeah.
How are you going to practically measure it? I don't know how. I'm just echoing Josh's concern.
So where this has come up, there's been some large marathons where they have big cooling, like it's set up on the site, they have physicians monitoring this. And so the question is, are we pulling someone out of the cooling when there's appropriate cooling going on scene to just load and go versus when there's appropriate devices? So that's why it's kind of very vague, continue maintaining. It's already instituted because it was kind of for that very specific setting, because 99.9% of the time in a pre-hospital setting, this wouldn't be there. It's really for big special events in a football field, like the trainers started to.
So why don't we say medically supervised ice bath immersion? Right there. Yeah. Is that fair? So you're saying there are physicians present?
Or PAs, or like athletic trainers or whatever.
Well, that's
different
than what I might be proposing.
They're not having temp probe physicians.
They're not always physicians.
So again, even a physician on scene can't provide medical directions, so you're still going to have to patch, right? So
but they would be a physician intervener, which most places require you to patch, and then the physician can make a decision whether you stay there or leave.
So where there's a trainer or a doc, anyhow, that's why it's kind of a vague discussion, because there's been a push as to when it's medically being performed. Are we stopping the right treatment? But that's going to be such a rare scenario.
So should we have it in here at all? And as we go back, should we have it at all?
I don't know, the stuff that I've seen, it's really is dramatically different on the extreme hyperthermia. I'm not talking like 102. It's like people who are like 105, 106, way high. It's not going to be the normal ones, but the case outcomes are dramatic.
There's one of the LLC articles.
Yeah, I think that's where I read that. I went down the rabbit hole of watching them.
Or EMS.
Yeah.
How are they monitoring their temps? Core. They can't do.
It's core,
it's all
so
core.
it's like an on-scene for a special event. It's not like a.
So are they putting a temporal Foley or a rectal thermistor or an esophageal?
I think they were rectal from what I remember. Yeah. And so, they cool them down to like normal temperature, and they said actually they were treating and releasing from the scene after they got them down to normal temperature. But that's not what we're going here. But they just showed the difference in outcomes. Because
I know I'm all for rapid cooling, but I've overshot too.
There was an article in the pre-hospital journal a few years ago about this, and our paramedic program sent all this stuff to me and said, "Are you guys looking at that?" And I went to the medical director at the time. And when we looked at this for for EMS doing this, it's just not very easy, and very, very few people have the capability, and I wonder why then we're writing this based off of some other medical situation when this is, where do we intend this to be geared towards EMS or not?
I think that, if we add in the medically supervised and then at the end discontinue immersion when temperature reaches, and I think the number recommended was 101.
Yeah.
I think this becomes a very specific, you're only doing this in the rare scenario where they're getting the appropriate treatment on scene, which is.
Do you want to say core temperature, which means it's going to be medically supervised?
Core temp, yes.
Okay, so core hyphen temp. And then I want to rephrase what I said. I only did this once and overshot, and I've never done it again. I was a senior medical, so that's been a while. You do it once, you won't do it again. And to your point, Josh, with your paper.
Call medical direction if needed.
I'm sorry, Frank, was that a question for us? I couldn't hear it.
No, I was just echoing what your paper found. As a medical student, I participated in the care of a patient. We overshot because the core temperature probe that we had was bad. So that's why I always do two core temperature probes now, either esophageal plus Foley or esophageal plus rectal, because you can get into trouble.
Got it. If it's appropriate, I have one other comment on this one, if you guys are ready for that one.
Yes.
I think, and maybe you guys addressed it, I couldn't see it on the scrolling down. Did you guys leave in the treatment of shivering? So that's not something that we at least have, after this case series, recommend. The reason they're shivering is because we've overshot and made them hypothermic. In that case, ironically, I mean, yeah, rhabdo is a consideration, but treating their shivering isn't really going to help their hyperthermia. You've just caused their shivering by overshooting. Yeah, and Dr. Rice says wilderness medicine also has removed this from their practice guidelines as treatment of shivering for a hyperthermic patient is not indicated anymore.
I'm fine with removing it. We talked about the risk of apnea versus shivering, and they're hot because of their extrinsic heating of their bodies, not due to excessive shivering or excessive exercise, not due to shivering.
So we could essentially just delete that to say refer.
I'm okay with that. I think that's a good idea, John.
Remove the drugs and then leave the seizure comment.
But we put the seizure comment back up under the, as a third bullet point for
paramedic. It doesn't have to be split onto both sides. Yeah.
Laser conducted weapon. The only thing, again, I don't know how we did a word search, so we must have missed this. So just getting rid of the, just updating the verbiage to delirium with agitated behavior to match the national language.
Sure, sounds good. And then just moving the EKG. Well, do you want the EKG or not even worry about it? You have it determined. Yeah.
Just be under, one question, should this be under trauma? I asked this in all honesty, I mean.
Oh, you mean like as a referral?
Yeah, I mean, I see this more in the trauma room, but then I don't, I assume in the emergency department.
You just use it in the senso, whatever the senso it is. Yeah, what categories it is in?
This is under environmental.
Electrician.
Yeah. Oh, because I guess it's an electrocution sort of thing,
The question
Cost and environmental.
Yes.
Okay. I would say leave it wherever Senso has it, that's so we can find it when we're doing updates.
Just a question about verbiage, and if people are okay with it, we can leave this. But the first bullet for EMT, just getting off stuff in the news. Once the patient has been appropriately secured or restrained of assistance from law enforcement, initiate universal care. We just want to say when seen as safe. Because a lot of times, right, you shouldn't be caring for a patient because law enforcement said you need to care for them. You should care for them because you need to care for the patient. I don't know if anyone feels that way. I'm not too strongly opinionated about it, just throwing it out there.
So once seen as initiate universal care.
Right. I don't think we need to.
Or when safe to initiate EMS care.
Exactly.
You know, because it's not the scene, it's really the patient himself, so,
There was safe.
yeah. Well, that, what's safe to do so, or something like that.
Well, just to be clear, universal care already has a line set to scene safety. So it's implied in universal.
Just reinforcing it.
Okay.
Because like we're assuming the patient is, agitated.
And then,
If you're the patient's the risk, not the scene itself.
the next one is just riot control agents. This is one that we did not have in the PTDGs. This was added in the central region. It just is kind of talking about the conflict instances. You're having a large volume of patients and what can we do on scene?
I like this. Because I get questions about, it's not all the time, but every now and then, especially the ones who get pepper spray from the police. And if they want to take them to jail, it'd be nice to be able to clear them and then not have to come to the
They're not coming to the ED? I don't.
Pardon?
No, but I mean, it's potential. I mean, if all they say is, hey, I got my skin irritated, do I have to come to the ED for clearance versus going to jail?
We can talk in this actual version.
My only thoughts would be under excludes. I think it's fine to say exposure to chlorine, phosgene, ammonia, or agents, because chlorine, phosgene, and ammonia, they're just hazardous materials. They are not necessarily intended to hurt anyone. They could be accidental exposure, so I'm not sure the right verbiage there. Where is it there? Exposure to chlorine, phosgene, ammonia, or chemical warfare agents, etc. Period. Exposure to these agents to result in call to poison control, and I make it the universal poison control number 800-222-1222.
So, exposure to chlorine, phosgene, ammonia, or chemical agents. Chemical warfare agents. And then,
Comma, etc. Period.
et cetera, period, and then take off the intended cause.
Yeah.
That's where you pick up.
Yeah, because we're more likely to see non-chemical warfare agents. Right.
I was just saying that chlorine, phosgene, ammonia, hazmat, hazardous materials exposures or something like that.
We could. You know, chlorine is very common. Phosgene just got released when they burned up the vinyl chloride. We just had the spilled nitric acid with nitrogen dioxide. Whatever you all think is better, whether we say specific agents and then et cetera, or hazardous materials, gases, I don't know. But I don't want somebody thinking hazmat are esoteric things, so that was the only reason.
Yeah, I kind of like having a few of the common ones right off the bat, so if they're going, is chlorine considered this? Well, it's right here.
Yeah, and chlorine's definitely dual use too.
Right, and ammonia. So like even in household
Warfare
poisoning.
agents, hazardous materials, et cetera.
Well, I wouldn't put chemical warfare agents first. I put that last. I think that's highly unlikely, or I hope it's highly unlikely. Hopefully, here in Arizona.
So your chlorine, phosgene, ammonia, hazmat, hazardous materials.
Comma, other hazardous materials or chemical warfare agents.
Got it, perfect.
Okay, and then we can put a period because that's kind of all included when we say hazardous materials. Thanks, Paul. Then we don't have to put comment section.
All right. Okay, that is the environmental section. So we'll do a Q&A vote. So if anyone opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
And then EC vote. Any opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
So Dr. O'Connor is out of town. I did meet with her and go through all of her recommended edits, and then I will lean on you, Frank, to also weigh in on some of these as well. So I do have kind of her the things to discuss. So under the general poisoning and overdose, her recommendation was to record and obtain all medications as opposed to all involved.
I agree.
Just because
because we're not
don't
sure.
miss something, so. Under EMT section, so, and, 1, 2, 3, so record and obtain
Yes, they're from the bottom.
all medications or products on scene. And then when we have the decon, her point was that really when decontaminating anyone, you want to prevent hypothermia, so it's not necessarily pediatric specific.
Agreed.
So kind of moving that line up.
And that could go across for adult and.
Yes, so we moved up to that, yep.
Also adult, who does the drug.
And then the other two are very pediatric specific, so those stay there.
I recommend tagging that wet decon sentence to the line that says remove clothing and decontaminate skin if contaminated, period, and then the wet decon sentence right after that.
So is it underneath that?
Just with it.
We teach the whole concept of dry, wet, dry decontamination through AHLS worldwide. It's really well validated, so dry decon, take off clothing or other contaminated things, blot away your liquids, surround and pick up adherent solids, and then wet decon, and then dry again, and that dry helps prevent hypothermia and remove seizure material. Also up above, I would put the Poison Control Center line above the opioid assistance and referral line.
What's the order in that?
Yep.
So we're going to say, remove clothing and decontaminate skin if contaminated, period. I would do the next line, wet decon.
Yep.
Next bullet point.
Next bullet point.
Yeah.
So that hypothermia.
And dry patient, after wet decon, dry patient to prevent hypothermia.
And then after remove clothing and decon, do the line after that one, and then the bullet, and then it wouldn't be a substance. It's I know. Forming. Yes.
Do we need to say wet instruments are slippery, or just wet patients are slippery and generalize it?
It's weird verbiage from Necento. I don't even know that it's necessary at all. I think, unless you think we need to include patients are slippery.
I thought that. I don't know. I'm sorry that I can remember that. I'll just refer to the wisdom of the group.
I think we laughed and kept it the last time because we thought it was funny that they felt that they needed to specify that. The other recommended change that we also put was to add the poison and overdose because we have a link to other top guidelines. So, like we have this is kind of, she said, this is your universal care if you don't refer to any of your other top guidelines. So, like education, opioids, stimulants, at least
Do we have room?
we have none except for agitation at the bottom.
No, do we have room to add all of them? Or
You could do it one line and just say,
refer to this, that used?
yeah.
If you can fit it, that's fine. Yeah, I like that.
I think we can, because we're gonna take down a lot of this section, so we'll gain a little
Yeah.
more space.
This is your general guideline.
Yes.
Do your basics, do your universal care, and then do either behavioral or agent-specific care with or without antidotes.
I think we can fit that in, we can fit in
Yeah.
the hyperlink
Sounds
to
good.
that top line. And then at the bottom, her question was why we are doing diphenhydramine specific as dystonia. She said, she feels like, if we're gonna just have this undifferentiated dystonia that we're given, should we be doing benzo as a better option? I gave them history that historically this is kind of used to be its own standalone guideline for many, many years, and now it kind of got wrapped into the universal guideline, which is something to consider.
So what's her point, is to switch out and use benzos?
The point was that in some of these patients, given the diphenhydramine commitment more, and that benzo would probably be a better choice for the pre-hospital medications available.
Does that make her to, so then we have to live with all the benzos? The real estate policy.
Do we want to address acute dystonic reactions here, or is there a better place for that? Do we have?
We don't, so we used to have its own standalone guideline
Yeah.
many, many years ago. We don't have one any longer. So in the sensor one, it's kind of buried in their universal.
I have no problems using diphenhydramine, and this is low dose, you know, up to 25 milligrams. I usually give 50 actually, quite frankly. And we use diphenhydramine for, you know, anaphylaxis, and we're not scared to use it. So if you could give the option to use diphenhydramine or benzodiazepines, you know.
And then, looks like Amber, you have your hand up.
Yeah, I was just going to ask if it was really even necessary to treat dystonic reactions in the pre-hospital setting in the undifferentiated patient, or if this is something we can just leave. And if they don't rise to the level of acute agitation to necessitate behavioral treatment, do we need to even treat it in the pre-hospital setting? That's my question.
And so this is a poisoning and overdose, but that's not necessarily the case that it's an overdose, is it?
No, it's
You
an
get those kind of
adverse
reactions with certain kinds
yeah.
of drugs.
Yeah, it's an adverse
It
drug,
seems
yeah.
like, just take it out. The reference to it and the treatment.
I'm okay with taking it out.
And that was kind of her point was,
Yeah.
was it needed?
Yeah, no, I'm
And
okay
even,
taking it out.
even the description of it.
Yep, I'm okay taking it out.
Okay, so we would take that out of both adult and pediatric.
Yeah, the dystonic reaction.
Yeah.
So you just take out that. By taking out that whole bottom row, then it opens up all the poisoning specific links.
All right, anything further on that one?
And then you're taking out the chemical sedation also?
Yes, we're gonna do pharmacologic management.
Yep, perfect, and change all that verbiage. And, yep.
Next, agitated violent patient. At the top, she said that we have excludes, and she said it made more sense to just strike excludes and just start with, because we're saying excludes, so then consider the following, so just start with concluding, consider, just striking excludes
Yeah,
at the top.
and should we take out considering if they address underlying medical conditions?
It says, yeah, so just start with address, it makes
Yeah.
sense.
I would recommend moving it down one space, one line, just for clarity.
And then, down kind of at the bottom area, just what we had done earlier with seizure, we had added just the not indicated post-tick location, to consider that we add that verbiage in here. So maybe as it's just under the ketamine, just not indicated post-tick location to agitation, just the red verbiage that's there, just capture that again.
That's fine. I mean, also up above under the, you know, what we deleted for consider, I would probably change the verbiage from acute head trauma to potential traumatic brain injury, just to make it consistent throughout all documents. And rather than metabolic disorders, I would put hypoglycemia and hypoxia like right up front as the main H's, and I would highlight them. And as we're
And then hyperlink, the hypo, yeah.
hypoglycemia, hypoxia, hyperthermia.
Hypoxia won't have a hyperlink.
No, but the hypoglycemia will with the
And hyperthermia.
and TBI.
And then, and we can give room for those so that they stand alone and stand out by shortening up
you know,
I want that.
And drug intoxications of non-denied.
that's true. It's not a complex or compound adjective.
Yeah.
All right, that was,
If you scroll down a little bit, Shirley, where it says place stretcher in sitting position, the one below that, if in police handcuffs, must be in ambulance with patient at all times. PD never leaves the car on scene, so something about like, or have the key to the handcuffs, something like that.
that's right, that's there. Go ahead, Amber. Amber, your hands up?
Oh, it's for down lower in the medication section, so I'll wait till we get to that.
And then we have 4 spaces where we have chemical restraints. We can change all 4 of those to pharmacologic management.
Yep.
All right. And then you had a question about the medications, Amber?
Yeah, I just wanted to ask the group what their comfort level was with keeping ketamine in as a sedative in this setting. I think just given the risk of the medication and my concern also with our providers and are we putting them at risk by having them use this medication for sedation in a high-risk patient population, so when there's a bad outcome, I feel like it puts them at a little bit undue risk potentially.
Okay, deleting it.
I guess I would say that ketamine works far better than midazolam or lorazepam to sedate these extremely combative patients, and it's safer than both of those other drugs from a respiratory point of view. I know, at least in the news, it's gotten a bit of a bad rap lately, but I don't think we should let that sway us. Like, of those drugs listed there, I think that's the safest of them.
Leave it to the medical director.
Yeah.
And then,
I mean, I guess as a state, are we comfortable? I mean, I don't know that the Colorado situation has changed the standard of care across the United States. So I think as a PMD chair, I'm personally comfortable leaving it as a recommendation.
I think it's safer
We
for
have
our medics.
We're not there.
I'm okay leaving it as an option, and it's up to the individual medical directors. And I mean, you look at John Cole's data and lots of other data around the country too. And I mean, things are going to happen with any of these.
Anything's.
There was when you look at that Colorado case, there was a bunch of bad stuff, so I don't think it's a problem.
Let's not delve into all of that kind of decision. Are we keeping or not keeping?
Yeah,
Keep it. Real quick question too. If we're giving midazolam 10 milligrams IM for a seizure, should we give midazolam 10 milligrams straight out of the chute for this?
So many of these patients have alcohol on board, and so you give them 10. So I think the data on seizure dosing came from Rampart.
Right.
And was very specific to that, but with many of these patients, they get too high of a dose, they will just stop breathing.
Okay.
So is there a difference though? Could we break that out to IM with a higher dose and then do IVIO if they're in place when they go off on you, I guess, then do the smaller dosing because of the alcohol issue? Is it going to be a great deal of difference if we're giving 10 milligrams and it's intramuscular or intranasal versus might really be concerned about that with getting IO or IV doses?
Ours at least says midazolam 10 milligrams IM, 5 milligrams IV.
But again, it could be up to each individual. So.
I think it's kind of, when we debated this in the past, we kind of left it vague in that, and it doesn't have a dosing frequency, so it just has a max total dose, so you have the flexibility to.
Do you want to have 5 to 10? I don't want to give 10 IV necessarily.
Yeah, and I think that's why we stuck with 5, because you can always do more.
Okay. Yeah, no, I'm okay with all.
Let's give more.
Go ahead, Josh.
Just going to support the lower dose. I think these are
To emphasize Amber's point, these are ultra high risk patients for everybody in our system. Using a lower dose with an escalating or repeating dose is probably a safe option for everybody in our current environment.
Everybody agrees. Thanks, John.
This is more a comment about no prone position.
The question was, should we add a comment of do not prone the patient, not place the patient in prone position?
I think we like to put there with the place stretcher and sitting position, that little area.
Yeah.
Say stretcher and sitting position, do not prone patient.
After recent events, it may be necessary, but you hope not, but it's.
I think we, at least on the record, it's in our guidelines, not prone patient. That's the safest place to do it. And
No prone patient.
Thought we wouldn't have had to say that again, but apparently.
Yeah. Is it too strong to say never?
I think do not.
Saying do not, I think.
The comment about post-ictal and ketamine, I missed why did we add that at the bottom there? Because it already says post-ictal above. Well, in the very top, it says.
Because many, I will tell you that this is being used a lot in patients who are post-ictal and agitated, because they're separating out in their mind. They're like, they're just super agitated. And some of those post-ictal patients are very physically agitated and aggressive. So it's just kind of another safety cue, just kind of recognizing.
But just for ketamine or for all of them?
Just ketamine.
Okay.
Just ketamine.
Okay.
All right, anything further on that one?
Wasn't I had somebody, one of our agencies that brought up, do we want to put anything about alternative destinations or leave that more for like a transfer type thing? Like if you're going to go to consider alternative destination or.
I don't think we're for this also agitated, because this is somebody like agitated versus just your normal behavioral health.
Okay, I didn't remember.
I don't think any other behavioral health system would take them.
No, I just wondering like your psych ones, or, yeah.
Let's see. So, yeah,
that's really, and this might be my own ignorance, so why do we have specific ones for these next couple types of poisonings and drug ingestions? Like, do we need all of them?
so we've always had them. I don't know if that is.
Okay.
I mean, just because otherwise we don't have any other place for these treatment interventions. So, but, I mean, just because we always had it, doesn't mean we have to keep it, but.
Right.
So for the incident 103 inhibitor poisoning or nerve region, there's only one D in the dumbbell acronym, so she added as a second one.
I would add a third, bradycardia.
What's in there?
It's in there.
It's the broncho/bronchoria.
Dumbbells.
Oh, yeah, I just put them all in one line. Okay.
If we can scroll down just a little bit, you'll see in the red, so we have hyperthermia, which is incorrect on the adult side, and then the ped side we have about avoiding hypothermia. So we just need to, and that should be for both. I don't think we need to have it separate. We can merge this and just say remove patient's clothing, wash the skin with soap and water, avoid hypothermia.
Should we just refer to the general poisoning, overdose universal care? Isn't that where we covered the dry wet dry decon stuff? Yeah.
So that's avoid hypothermia, because there are some others, and we just did that first one where it said prevent. If at first it said attempt to, and then that got scratched out to prevent hypothermia on the very first one. When wet decontaminating children, prevent hypothermia. It's the same one.
Same thing, preventable. I mean, essentially, you just don't want to use cautious pure pouring copious amounts of fluids on something they don't.
You want to just simplify this and refer to that initial care? The only thing that's unique here is these are not water soluble, so do we want to get in for a wet decon? You can just use soap and water for all wet decon if you want, then you don't have to go about whether the agent you're decontaminating is water soluble or not. That's why I put that up front in your initial poisoning overdose universal care. Wet decon with soap and water.
So we'll do wet decon with soap and water on the universal. And then this one, we will just initiate universal care.
Right.
And then instead of the remove patient's clothing, we're just gonna go for decon refer to.
Yep. Yeah. That would be my suggestion. Let me get the wisdom of the group here. So we just had a nitric acid spill that everybody's aware of. That, you know, is highly water soluble, so you wouldn't need soap and water. But do we want to get into those nuances? And
Frank, are you asking a question of us?
concern. That's why we specifically picked some of these.
these actually antedate 9/11, 2001.
Yeah.
And my suggestion would be to keep them because we're getting more and more toxicologic and drug-related problems, not less.
Right.
So, and many of these do have specific antidotes, some do not. But my suggestion would be to keep. I don't think they've caused problems, have they? Yeah.
Yeah, I think we should keep it.
Yeah.
So,
Okay, to your point, because I get what you're saying right now, with like, for example, the nitric oxide spill, I think having what you mentioned, having soap and water as the broad kind of universal one would be appropriate, but maybe also say consider early medical direction, because like you're saying, like it's so specific that it's worth getting extra brains on board sooner rather than later.
Yeah, and if we use soap, which is a reducing agent, with nitric acid, which is an oxidizer, or should we just leave it wet decon as directed by poison control or medical?
And I would defer at this point to the people who know more about poisons, kind of, that'd be my ask.
Yeah, because I want to do simplicity
Frank,
here. But
Frank, this is Dan. I would stay with simplicity unless there's unless you think they don't have access. And I think everybody knows how to get in touch with poison control, and they do it early.
okay, so we'll just say wet decon, Dan, with early medical control or poison control. That would be my, yeah. Okay, and we can put that throughout then.
Will that make sense, sir?
all right, so we're saying we're leaving out the soap and water, and we're saying wet decon.
Yep, and I would say with early contact with poison control, because I think even, not to sell medical directors short, but I don't think most medical directors would think about nitric acid as a big oxidizer and soap as a big reducer.
If they called me, I would say, please call Poison Center.
Yeah, we have that at the top. It's called, before any intervention, we have called poison control.
Wonderful.
So just kind of going a little bit further down, Dr. O'Connor wanted to point out the atropine dose. She said, if you go to the 2 to 6, if someone starts with 6, your repeat dose is going to be 12. She said that atropine is very high unless you know it's someone that is like a known intentional agricultural. So her recommendation was just to consider a little bit lower dose of 2 to 4, but then also kind of specifying which assess the resolution of bronchuria, improving vital signs of drying of airway secretion. So it kind of makes you, before you're just repeating that, you're actually assessing the patient. So the red font on here has an assessment resolution.
I'm okay with Aaron's suggestion. If you're doing ID or IO, you start at 2, and then there is data that doubling to 4 and then 8 is reasonable.
This technically they could start at 6 and then their next dose
Yeah.
is 12. So she felt like that was high.
Again, there's reasonable data, and you could say start at 2, double the dose every 3 to 5 minutes until the patient's breathing is easy or they're easy to bag. That's simple. Real simple. But I'm going to defer to the group there.
So if we did 2 milligrams and then,
I would get rid of the rage. Yeah.
and then repeat as needed.
Until the patient breathes easily or is easy to bag.
And then,
Yeah, if they're awake and alert, they're going to say, hey, I can breathe easy. Or if they're not and you're trying to bag them, you can bag them easily.
So are you keeping the 2 times each previous dose, or just doing the 2 over and over again, 3 to 5?
So it would be, you would double it, 2, 4, 8. And then maybe we ought to say a maximum of 3 times, because that would be a fairly high dose.
2, 4, 8.
Yeah, and then I would stop.
14 milligrams, and there's only 20 milligrams in a big vial, so.
2, 4, plus a couple.
total dose.
Would be 2 plus 4 plus 8,
Well, there's
14 milligrams.
still
Yeah.
Yeah.
Yep. So you double it and every 3 to 5 minutes. Until it just, resolves, so the patient is easy to bag. Keep it, something good, let's see what you're doing.
So repeat 2 times initial dose is needed every 3 to 5 minutes, max total dose, 14 milligrams.
Until the patient's dyspnea resolves, or the patient is easy to ventilate or bag, whatever term we want to use for a verb. Period. Yep, and then we get rid of all the other stuff.
So get rid of the resolution of secretions.
I would, because then it's real simple. Hey, it was hard for me to breathe, which was the indication to give me the atropine. Now it's easy to breathe, or if they're awake, or if I had to assist their respirations because they're unconscious, unresponsive, it's easy to bag. My mask isn't slipping off because it's all sweaty, full of snot and saliva, and I don't have huge airway resistance due to bronchorrhea and bronchospasm. That way we don't have to get into those terms, but I'll defer to the wisdom of the group.
That's nice and simple.
Sounds great.
So I'll make sure the piece matches that, and then.
But don't we have that in the next line down? Clinical improvement should be based upon drying the secretions, improved respiratory rate, and improved oxygenation, improved ventilatory, yeah. And that covers both lines. It's the first line in the last box.
Yeah. Or you could.
Then why don't we just leave it there for covering both of them?
Because I think they're looking for repeat doses. So if they're doing repeat doses, they may not be looking down. So I think it's okay to have it in both places. We've got room for that.
Just out of curiosity, why do we have a max dose? Use whatever you need to use to get the symptoms under control, and if you run out, you run out. But why are we stopping if you still have atropine and they're still symptomatic?
I'm okay with that.
Like, I mean, that's my question. I mean,
Yep,
you're bringing back organophosphate and
We
it's
could.
a drug.
Yep, we could. I'm okay with that, Chair.
Because I hate to have them stop and still be like, well, I still have a little bit I could give and not give it because we maxed them.
Yeah.
And then, the only question she had was, do you want to consider prilidoxine?
We should.
It's not on here, so.
Yeah.
It's cosmetics only. And we
Yep,
don't
we
have it on
should.
there. Anyone that gets before?
Well, we've got it on other places for specific levels, so if that's on their table forward list or whatever.
I don't know how it dropped off, but the central region is on there, so we have.
Yep.
I can read it and then just see if the group wants that, we can add it in. It's, prilidoxine, 1 to 2 grams IVIO over 10 to 15 minutes. We constitute with 20 cc's of still water, in parentheses, toxic paramedic only. And consider 2 PM group for severe cases after initial dose. That's the adult verbiage. The pediatric is 30 to 50 milligram per kilogram IV/IO over 10 to 15 minutes and otherwise the rest reads the same.
Yep, I'm okay with all that, and it's been there before. And I'm okay, with Sherry's suggestion too. I only maxed out at, 14. So does anybody carry more than 20?
Well, you'd have 20 in your multi-dose vial, and then you might have a few of the code atropines.
Okay.
So,
And
we can get rid of the max dose. I'm fine with that too. I'm fine with that.
And the 8 milligram vials are optional now.
Yeah,
You don't even
I'm fine with that.
So.
Yeah,
you may
because
get-
our endpoint is easy to bag, or they're easy to read.
Right.
Yep, I'm okay with that.
All right. Anything further on this one? So we'll add in the language that I have in my notes
Yep.
from the central original one. Okay?
The data regarding pralinoxine dosing too, at least in the military, we're just giving 2 grams straight out of the chutes, but I'm okay with the range here for general civilian use.
For the radiation exposure, she said just for what she says, really the majority of calls that their poison control gets is about the medical, like people with medical procedures and exposure to the call, which we specifically exclude. So she just said, at some point we should probably consider what does the EMS need to do for that. So I'm just putting that on the record. And she said this specifically excludes that patient population, but that's the majority of the calls that actually come in for radiation exposure. And then again, we have wet decon only on the children, on the pediatric side. That should be for both. So just
We'll carry that whole decon thing all the way
just
through.
add decon, and then this will get rid of the ped side. So we'll do this. Universal care, folios, which includes the decon, the universal care for decon instructions.
And I would probably get rid of dizziness as a sign of acute radiation syndrome. And then confusion, altered level of consciousness, or seizures. I get rid of seizures. If you look at the hematopoietic syndrome, it's going to be nausea, vomiting, and diarrhea. It's going to be the signs and symptoms early. And then even GI. And if you got exposed to a huge source, you could lose consciousness. Headaches, okay.
Probably don't need a comma between initially there, asymptomatic initially. Most patients will be asymptomatic.
I don't even know if that's important for an EMS setting. I don't think it is. I just delete that whole thing.
Where is it?
I think it's just an
The first
educational
paragraph,
thing.
yeah.
So I think it's just more that people like, you know, if EMS sometimes thinks nausea, vomiting is like a not severe clinical presentation, but it's the same. Like in this, it's appropriate.
And if you want to keep it in, say emesis due to acute radiation, emesis within 1 hour due to acute radiation syndrome has poor prognostic. It's a poor prognostic indicator if you want to keep it. Yeah. Or you can keep it if you want, yeah.
Anything further this before we go to dermal burns? So a few things on this. She said that the irrigation that is listed on here, especially for hydrochloric acid, is insufficient. So recommended was in red there. So we have, it says, after irrigating with water for 3 minutes, her recommendation is this is a minimum of 20 minutes, can continue in route. So kind of recognizing that you may not, we're not telling them to stay on scene, but that implies that they irrigate for 3 minutes to be done. So for so
20 minutes.
after irrigating with water for minimum 20 minutes, can continue in round.
My suggestion is not to do that because what we're teaching worldwide for HLS is 3 minutes irrigation, break blisters in the field, irrigate, and then put on the calcium gluconate gel. Because if you put on the calcium gluconate gel, you just wash it right off.
Right, but they're saying you apply it after you irrigate.
So maybe you need to put that after irrigating with water.
So take that first part of the sentence, but at the end.
Right.
Irrigate with water.
Yeah, and the reason we said we limit the time here is the longer you wait to put on the calcium gluconate gel, the less effective it's going to be. So that's why we're not irrigating with 20 minutes here. That's the reason for this exception and this change.
Okay.
So for all other chemical burns, you're going to irrigate if they're acids or bases till the pH is 7 at the base of the wound. So it's going to be continuous irrigation throughout, and it usually takes hours.
So, I don't think this is the right verbiage then, so,
I would leave it the way it was.
yeah, just undo it all.
I would say after irrigating with water for 3 minutes and breaking chemical burn blisters, apply generous amounts of calcium gluconate gel to exposed skin sites.
And that should be if available, because how many people, you know, this thing was originally written for Honeywell to do their own pilot project, and then it got put in, so.
So,
Yeah.
we're gonna so after irrigating with water for 3 minutes, comma, apply.
Apply calcium.
Generous amounts of calcium gluconate gel. to exposed
Yeah, or you
skin
can just say apply calcium gluconate. You can make it up. They've got KY or Surgilube.
They won't, at the EMT level, they won't have calcium gluconated in any other form but the gel.
And that's just at Honeywell, right?
Well, that was where this whole thing started,
No, I
and they
remember.
put it in, right?
Yeah, no, I
And I don't know how many people how many EMTs are out there running around with
So,
calcium gluconate gel, I don't know.
so I think this is just, if they carry it, it's under the EMT, they can apply
Okay.
the gel. So after irrigating with water for 3 minutes,
Apply generous amounts of
Apply
calcium.
generous.
Yeah.
If available.
Yep, that's fine.
Yeah.
Yeah, so it's basically the same initial verbiage, but just
just flip the order.
flipping the order of the clause.
And then,
Do the first thing first and then the second thing second.
Blisters.
Do we want to tell them to break the chemical, and really all the chemical burn blisters should be broken in the field because they contain the chemical burn agent. I don't think we've done that in the past, but that's true. So
That's specific to chemical burns, right?
specific solely to chemical burns, the only exception is sulfur mustard. But I hope we never have that here.
yeah, I guess
Yeah, I gotta
that's
stay away.
a scope of practice issue, so we've
Yeah.
had things that
I'll
kind of,
defer.
yeah, we've had
I'll
questions
defer to the
about that.
group. That's interesting. That's curious.
Um,
Yeah.
And then under the
So
EMT,
delete break blisters, yeah.
yeah,
Where does it say that?
no, that was just added now, and we're not, that's not
Yeah.
a scope of practice.
No.
Under EMTI and paramedic, recommendation to remove the Morgan lens. I think there's a lot of I think most people are moving away from using that and just using irrigation,
What's the reason?
just for corneal abrasions and comfort of tolerating it.
A lot of patients just won't allow it.
Even after you numb them up?
Gets washed out is the problem, so you know about it.
Yeah.
Well, then do we need to, yeah, but you did, because you gave them proparacaine or tetracaine and then put in the hands-free irrigation device because Morgan Lens is brand name, but, so if that's going to go away, then what are we putting proparacaine and tetracaine in for anymore?
It was still used for irrigation, yeah, but you can it's easier to reapply the drops when you're just irrigating versus when you have the Morgan
They
lens on.
can't keep their eyes open if you don't, even if you're using nasal cannula or whatever. Any reason to take it out if we just, since we're saying consider?
Just take that line and just leave copious irrigation with water or saline, just leave it like that.
No,
You think put back the hands-free irrigation device?
yeah, consider hands-free irrigation device, whatever you want to call it, or just eye irrigation device, or eye irrigation to facilitate decon.
And then if somebody's carrying it, they can use it.
Yeah, yeah. Because I'm more concerned that somebody's going to have a irreparable eye burn because we didn't adequately irrigate, than some corneal abrasion from putting in Morgan lens. Yeah. And then it's going to be continuous irrigation throughout pre-hospital care.
we have, to copious irrigation, so just change copious to continuous.
Yeah, continuous. We've had to irrigate, like if you get, base burn in the eye, like cool, liquid like pH 11, we've had to irrigate them for like 11 meters. So, it's gonna be continuous irrigation.
Okay. So, continuous irrigation with water or saline.
Consider use of high irrigation lands to facilitate decontamination. Is that comfortable wording, Brian?
Yes.
That's not a proprietary need.
And then the
Yeah.
fluoride, the next one.
And actually, in the, I just looked up the scope of practice, and it says sterile
Sterile irrigation lands.
sterile eye irrigation.
Yeah, I'm okay with that wording.
Hands-free eye irrigation.
And then I would also say reapply proparacaine or tetracaine drops as needed to relieve pain. They can do it as often as they want.
And then may reapply as indicated
Yeah.
at the end of that sentence. May reapply as
Yeah.
indicated.
And they're gonna need it because it'll wash in and wash out, as you all know.
May reapply as indicated.
And even if they don't have the lenses, then they won't have blepharospasm.
All right, so, let's see, the only other thing for this one, which is just a formatting thing, is that we've got the hydrofluoric acid exposure and hyperkalemia EKG changes, but then the hyperkalemia is kind of its own section. So just recommending moving both of those into that box below. So just moving that, so it's clear that we're not just treating hyperkalemia for this, it's specific to hydrofluoric acid.
Sure. And Dan, we should do that actually probably, prior to EKG changes for systemic burns, large systemic burns. Well, they're not gonna be able to figure it out on the field, we can just, yeah, leave it as suggested.
Let's see, stimulants.
Oh, there is, let me say this too, you also get hypomagnesemia. So should we say treat with 2 grams of magnesium sulfate for ventricular dysrhythmias or polymorphic VTAC or?
Question with the group, do you guys want to add that to this, or just assume that they would be in their tachycardic?
It's worth maybe just putting like in follow like the protocol, because I think we have like that kind of, I see what you're saying specific to that, but.
Yeah.
You could just say, refer to cardiac arrest page as indicated.
White complex tachycardia. Consider mag sulfate for white complex tachycardia or something like that.
Yeah, that's fine. Or Tersad.
Yeah.
The reverse tachycardia guideline for white complex tachycardia.
And do we specifically say mag sulfate in there for
Or
Tersad?
magnesium.
Yeah.
Right, yeah, because you don't want them to go into like amiodarone or something like that.
Okay, yeah, we definitely don't want to do that. Yeah.
Let's see, the stimulant, the only thing she was saying is refer to agitated or violent behavior. She said just really, the patient population she feels is better treated with benzo. She didn't know if we should specify that on this guideline.
Agreed.
So.
And you saw my bias towards that.
Yes.
And
with
then-
the agitated layer patient.
1 gram
But I
space
understand.
right after med and before the MDMA, this should be a space after the comma. After the methamphetamine. Yep.
And so then one way to refer to agitated or violent patients as needed, comma, benzodiazepines prefer over ketamine for this patient population. What do you
Yeah.
think about that?
I like that.
Yes.
At the, no, not at the bottom. So refer to as needed, so paramedics, comma, benzos preferred over ketamine for this patient population.
And we could remove methamphetamine at the top since we have, under includes cocaine, amphetamines. Yep. And this is kind of what we were referring to in the other place too. Do we want to make that verbiage the same both places?
I think it's okay to have
a little more here just because.
Okay.
Yeah.
Feel I'm good with that.
More interested in it.
Let's see, next for suspected cyanide poisoning.
Could be potential cyanide poisoning. You hear me, Dan?
So should we just say cyanide poisoning, take it off? I mean, that's.
Yeah. I will say this, that the package insert says, suspected, and that's because nobody's got any cyanide assays in the field. So, might want to leave it potential. We could say cyanide poisoning. I'm okay with that.
And then if you want to scroll down on this for the dosing, somehow we got this for the cyanogen as 2 minutes, but it should be 15 minutes of the packaging recommendation for that.
Yeah, and it's really whether they're in cardiac arrest or pericardiac arrest. We're just going to push it. You can. I won't say it. Anyway, the benefits of rapid use would outweigh the risk of cardiac arrest if they're in arrest or peri-arrest.
And then, the sodium nitrate,
That should be longer. I'm just gonna pull up my book here.
so then this, clarifying here should be toxic only, should be on there.
Yeah, you need to either put that by both of them or make a line with toxic only and then, and again, the sodium nitrite and thiosulfate.
For consistency, I think we've done it next to the med.
Yeah.
So I would do it there for most.
Sodium nitrite should be over 5 minutes. That's straight out of Daily Med, the package insert, and our textbooks.
And then the other
2
part.
minutes is too fast.
The other part in red is what she recommended adding, that sodium nitrate should not be given if hypoxemic and can worsen hypotension.
Yeah, there's a black box warning for hypotension, that you can have fatal hypotension. Is anybody carrying the nitrites and thiosulfate, or is everybody transitioned over to cyanokit?
I think there are a few people still carrying it, because not everyone can afford the cyanokit.
Okay.
So I think that was the concern of if we are in, like, because not everyone can have the cyanokit, that we should at least have the precaution of when not to give it.
Okay.
So her recommendation was should not be given a hypoxemic, because that will worsen that, and can worsen hypotension as well, just as a strong precaution.
Yeah.
And hydroxycobalamin is like really expensive, so there may be some people keeping the other kits.
Yeah.
Yeah, and the sodium nitrite has all the sildenafil, et cetera, phosphatidylserase 5 inhibitor concerns too. I don't know if you want to put that here or not, just like nitroglycerin. This is an IV nitrite, or is that, should that go in the?
Like for an acute life-threatening event?
Yeah, because they can have acute life-threatening hypotension. You're robbing Peter to pay Paul.
And I think that's why she said it should not be given. Her recommendation was you shouldn't give this if they're hypotensive or hypoxemic.
Yeah, I would say, in the field, I think that's reasonable, yeah. Avoid if hypotensive or hypoxemic.
Should not be given a hypoxemic or hypotensive. It's an anti-worsen.
For sodium thiosulfate, just for the ped side, we need to put in a max dose. What it is, I don't know, but it's just, we should list one in there. For sodium thiosulfate, will the max dose just be whatever the adult dose is, 12.5?
We've got 0.2 mils per kilo up to a maximum of 10 mils.
That's for the.
So for sodium nitrite?
No, for the thiosulfate.
Okay.
250 milligrams per ml, 1 milligram per kilogram, comma, max dose 12.5 grams.
That would be an adult dose?
Yeah.
Okay. Yeah, and it was 10 minutes for the administration of the sodium thiosulfate.
Sorry, can you say that again?
Sodium thiosulfate's over 10 minutes, not 5 to 10. And then the same for
That's
adults.
12.5 grams max.
Yeah.
It's just over 10 minutes for both adults and kids, but.
Yeah, just take off. Yeah, there you go. And then should we say should not be given or just avoid if hypoxemic or hypotensive? I'll defer to the wisdom of the group there. We listed it as a relative contraindication, not absolute.
Concern in the pre-hospital setting, if they're really given this and they give it and it's catastrophic, then more harm than
Okay.
benefit.
Keep it as it is.
This is not my realm.
No, I'm fine with that.
Anything further on that one?
Any reason there's an and in there? Other than just after the.
Again, policy.
Okay.
Sodium.
Oh, so you want to give them both? Okay, I got that. Is that clear?
Clear to me, but.
Okay.
Yeah, because there's an or at the bottom, the hydroxycobalamin.
Okay. And then everywhere else we've used the Boolean operator, capital OR, capital AND.
We did pick one.
Okay.
Let's see. Carbon monoxide, smoke inhalation. She really didn't have any recommended edits to this one. Hydrogen sulfide. Next, she said to read the comment on hydrogen on the sodium nitrite. She said the role is unclear, and I realized she's got a comment about that on the side. If you show more. She said in this scenario she doesn't recommend the sodium nitrite. She would think she actually recommends removing it. I think the treatment for this is really removal from environment and provide oxygen. So her recommendation was to strike that.
I'm okay with that. It's an area of controversy, and you've got to give it almost immediately. Others too would give the hydroxycobalamin, but it's completely off limits. So, I think supportive here. I'm okay with that.
So are you giving us specifying first remove from environment and provide oxygen?
Absolutely. The other issue is it's a significant risk to rescuers too. So there's a whole scene safety issue there.
And that's already noted up on the fourth bullet point under EMT. Remove from toxic environment to provide high flow oxygen, so.
So we can actually strike that whole
Strike
section.
that whole
Yep.
All right, very good.
And do we have them call, and we got them calling poison control, and that way the poison control can weigh in on sodium nitrite or hydroxycobalamin and that kind of thing.
So what we should, we got the there, but. Let's see, the hydrocarbon one, the propanol, she just said we should, recommended that we move the seizure up. So, for the seizure management, it's above that section, it's not specific to propanol, somehow that hyperlink there. So just moving that up, and then she also put in there, specifically, her recommendation was, you're really giving this in the setting of no something with loss of consciousness, tachyventricular dysrhythmia. So this isn't just make it very clear that there's
Yeah, I would say for ventricular, for PVCs, multiform PVCs, uniform PVCs, VTAC.
So are you good with that verbiage?
Tachyventricular dysrhythmias. And I wouldn't say in the no and huffing, we've also seen in people trapped in vehicles for a long time, inhaling gasoline, that kind of thing. known huffing or, prolonged exposure to gasoline or something like that.
Okay.
Yeah, it's usually road crashes, they're trapped in the vehicle and.
Gasoline fumes.
Yeah,
And then the
gasoline vapors.
Refer to seizure for management of seizures. How about refer to seizures as needed, like we do.
Yeah.
Refer to seizure as needed. We don't need plural. Yeah. There you go.
And I would put the indication above the dose. Should only be given a setting of known huffing or, for example, known huffing or prolonged exposure.
Yeah, that was your concern, with making sure that we're not just, people aren't seeing profanity.
Yes, yeah. So the indication first.
So above the whole title for propranolol, or?
Yeah.
Okay.
I'm okay with that, yeah. And I would get rid of with loss of consciousness. They don't have to be unconscious. They can just have tachydysrhythmias. We've seen it many times. And I would change fumes to vapors, because there's a specific confusing industrial hygiene definition of fumes. We don't call it fumes.
And then we'll make sure the P matches
Yeah.
the dose.
And I would put comma, et cetera, after vapors. Because there's a lot of other hydrocarbons. We've also seen it, people that like are cleaning out instruments with different hydrocarbons.
So, suggest the vapors, comma, et cetera.
And I don't know that if we could repeat it times one in 5 minutes. Should we say, if tachyventricular dysrhythmias continues? The other thing we got to make sure is that they are not hypoxic before we give propranolol. We want to resolve hypoxia.
That's high flow to up in the EMT.
Okay, so we're covering their things, right?
And then should we have a reference to the airway management guidelines?
Initiate universal care, implant pulse oximetry monitoring, refer to airway management as indicated.
High flow to, yeah, and then refer to, maybe take out the BVM ventilation and just put refer to airway management guidelines.
I think it's okay to have both, because, I mean, sometimes we don't want people having to go back and forth multiple times, because your airway one's not going to take you back to this guideline. So you have to go searching for this one again, so. All right, let's see. Anything further on this one?
Yeah, so just to clarify the verbiage down below, when we did all the surgery on the huffing stuff, can we say, for the setting of known huffing, blah, 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 gasoline vapors, et cetera, instead of should only be given, and then below that a drug?
I think it's,
Am I making sense there? Instead of should only be given, it's like, well, what should only be given? Oh, propranolol, I guess.
how about just in the setting? And then just, there we go. I guess.
There you go. And then colon after dysrhythmia. Dysrhythmia, colon.
Or are we going to say, give propranolol?
Anything further on that one?
How do you feel about hot asphalt fumes? Causative agent.
It's possible. Hydrogen sulfide is also possible in that setting too.
That's just up above, so I didn't know if you wanted to change fumes to vapor.
Oh, yeah, let's
something
change the
that.
vapors. Yeah, no, that'd be great. Thank you.
Not noticing what you were referring to. Reference.
Where am I going?
It was just up higher, under the causative agents include, top section.
Okay. Yeah, just change that fumes to vapors. Yeah, thank you.
Where's, I was on my sheet, it looks like it's unchanged, so, never mind. I'm just reading off what I have in front of me. That's been changed.
Disregard, it's not on there.
I'm sorry.
All right, that's okay. All right, let's see. The methemoglobin, her only thing is she said, really, I don't know that this is, I guess I think you've done the also setting with, you should not get methylene blue if there's concern for hemolytic anemia, but then she said, but how would they know that in the field? So it wasn't strong. That was the only potential.
Okay, so basically unchanged.
James, yeah.
Yeah, I'm okay with that.
No.
And then,
Hey, Dale?
yes,
Dale, are you still on the phone?
I do not see him now.
Okay, fair enough.
For opioid overdose.
I got it. I have a question. This is the one where we fixed the airway connection a little bit ago, right, on this one?
Which one's methemoglobin?
Methemoglobin. I may have moved further ahead.
We haven't touched this one.
What's that?
We haven't touched anything on this one.
Okay, well then I'm on, PVM ventilation, admin, somewhere around there, the refer to airway management guideline.
I don't think we need to say reservoir mask.
How about we just say initiate universal care, including pulse oximetry monitoring, refer to airway management as indicated.
Perfect. Yep.
Where do you see reservoir now?
After high flow, there's no way to quite non-rebreather.
Non-rebreather reservoir mask.
All right. Now we are. Okay. So her point was that we had the signs and symptoms under exclusions that didn't make sense, so she just put that up there. And instead of altered, she said, we don't want to give it to us at an altered level of consciousness, it's for decreased level of consciousness. So, just because someone's a little confused.
Yeah, I'm okay with that. Is naloxone still an SPR? I thought we changed that.
I have to double check.
You remember, Brian? Is naloxone an SPR?
What's that?
Is naloxone an SPR still? I thought that, like albuterol, got changed to just standard.
Nope. Actually, I have one more question on that.
Naloxone.
It's still an SPR.
It's
It's not an SPR, so we could delete that line that says SPR.
Okay.
So we break it down into the pre-filled versus the syringe.
So one option is we could, realistically, we could just say the IN, the pre-packaged 4 milligrams, or the IM dose, and get rid of the 2 milligram pre-filled with mucosal atomizer device, knowing that anyone can get free naloxone from the state at this point in a commercially prepared device. So that's something just to consider, just deleting that. Go up a bit under the EMT section. So that where we have the IN dose, where we have or, what's after or, should we just delete that portion? So the standing order for the state got rid of that because anyone who wants that can just get free intranasal commercially prepared naloxone from the state. So I think that option was in there to see if people said they couldn't afford it, that you can get it for free, so. The delete. And then, just do one undo so you don't get rid of your dash. Okay. There you go, perfect, okay.
Keep going.
And then under assess for other etiologies of, she just recommended changing depressed to decreased mental status.
Yeah, decreased is fine.
And then keep scrolling a little bit further. So her,
And rather than including, I would say, yeah, no, that's fine. Or such as.
And then recommend transport to the hospital. So this is something where she wanted stronger verbiage. I said this is kind of one of those tough scenarios because obviously this patient's like getting naloxone and refuse transport. I said I don't know that. I said this is we don't have any the majority of our guidelines. The fact that it's in here is stronger, but she just wanted to go on record to say her concern of patients who reverse, stay on scene and then have an adverse event because they go back down and then 911 is called. So.
I think we've all decided that those people, just because they had an opiate, in this case, have decision-making capacity, yes, they refuse, and a lot of them refuse, and that's the risk that should be told to them, so.
Just like the hypoglycemics who wake up.
Like hypoglycemics.
So I think the recommend transport to the hospital is probably the strongest verbiage we have anywhere in the guidelines, but I just want to make sure I mention that.
Did we also say here assess for suicidal intent? Because if they suicidally overdose, then they fall in that whole different. You know, most of these people just get more than they wanted, but some people are trying to kill themselves.
Would that be true of our general poisoning protocol?
It would be, yeah, we could put that in the whole general.
Maybe we're putting in the universal, just assess intent of,
yeah, overdose.
Yeah.
Yeah. Suicidal ideation. Or transport patients who voice suicidal ideation, or the history indicates attempted suicide.
In the universal care network.
That is a very good
No,
point.
universal poisoning.
Yeah.
Universal poisoning, we've got a space there, so maybe what we should put in with, where we have a pre-aligned bullet.
Verbiage for suicidal ideation, you guys can come up with whatever.
You want verbiage. Transport to hospital for suicidal. Suicidal intent, something like that.
And yes.
Sorry. I was gonna say about the strongly recommended for transport, for the easily reversed opioids, there's a lot of literature that says non-transport is probably pretty safe, but the future of getting better service for those patients, they come from programs that, would leave behind locks on programs or referral to treatment centers. So it would just be something we have to get back on later, something.
Transport patient to hospital if suicidal.
Or,
Maybe just like assess for suicide risk. We can't always force.
I mean, there's a suicidal.
I know, but they have to, if they weren't specific about it, or if PD's not willing to intervene, or if, we didn't actually hear, it's not that easy to.
Yeah, I mean, there's a use of force statute still in place in Arizona for suicidal ideation.
Yeah.
And if it's in the setting of overdose, because this is the setting of overdose as well.
Right. Sure.
Well, but if you look at that use of force statute, which is where also our decision-making capacity issue comes up, that is more designed for the immediate stoppage of somebody attempting to commit suicide, not because you're taking them, because you assess them for suicidal intent and now you're going to transport it.
But in this one, this is a setting of overdose.
Right, because they've actually tried to do it.
Yeah, this is a setting of overdose, so that's an acute attempt to kill harm, right?
Yeah.
Well, but if you look at 13403, it's more like to immediately stop them, but they've already done it. Now you've reversed them and now you're trying to make them go. That would be under Title 36, not under 13403, I don't think. I don't think
This is for any overdose, not just opioids.
Yeah, this isn't just opioid, this is just.
And we're being very specific, transport to hospital if suicidal. I mean, it's if they're suicidal, they're suicidal. They're going. We don't have to assess intent. We don't have to assess what the scene is like or what somebody else heard. Can the paramedic make the assessment that they're suicidal?
Well,
I think I would say that we aren't going to get to a resolution that everyone wants on this. You can always patch. So again, the general recommendation if someone is suicidal is that they should go to the hospital. You can always patch if you want to do an alternative plan of care.
Right.
And that's what online medical direction is for in that scenario.
No, I think that's very wise.
So back to the opioid overdose.
Can we make one change to the hydrocarbon, please, real quickly?
Can we finish that?
Sure.
Yep.
What did you say?
So with the opioid one, there's just near the a little bit further down in red, just some So just some recommended verbiage that she put on the adult side, which is to use a lower dose if someone has, opioid use disorder, so that we aren't precipitating acute withdrawal.
I'm good with that.
So that was just the recommendation for that one, to use a lower dose. All right, so that was it on the opioid one, and let's say.
I may assist with patients on auto injector needs to go away. It's the second box for EMT, first line, second box, may assist with patients on auto injector. EMT. And scroll down, EMT, and it's right there in the start of the second line box.
Oh, there, thank you, okay. Thank you, yes. All right, hydrocarbon, back to that one.
Well, I would just, delete the repeat dose for kids, that's all.
Okay.
And then,
Propranolol, correct?
Yeah, for propranolol, so rather than repeat times 1 in 5 minutes, I'd just leave it.
Okay.
The package insert says repeat 6 to 8 hours. Any comments on that there?
All right.
and I have one question, I have a question on that hemoglobin E.
Okay.
Last line, do not administer in patients with known glucose 6-phosphate dehydrogenase. Should there be something after that, like
Disorder or something?
No?
Yeah, just you could put deficiency if you would, yeah.
Deficiency?
Yeah, that's fine, if you'd like that.
Does it mean they have too much? In that case, it would be too little, right?
Yeah, but no, you're right, Brian, with, so add deficiency at the end, you're right. You're exactly right.
All right, and then the last one that we will probably get to, although there's a decent amount that she wanted to just kind of consider, so we might want to just keep this simple. She said, especially in Arizona, we have this is a very general, broad guideline, but things that we have very specific in Arizona that we could do interventions for, scorpions, black widow, rattlesnake envenomation. So she just said this doesn't really cover a lot of those interventions. The one thing she really said was we should have hyperlinks to anaphylaxis and shock.
Agreed, yeah.
We have a shock, we don't have an anaphylaxis.
No, that's being for EMT.
And then,
So you could use it right there where it says refer to seizures, just list them all out.
And then move the shock one up.
yeah.
But still all of them. They are very well.
I'd put anaphylaxis before shock. Because shock could be a subset of anaphylaxis, and most likely would be an anaphylactic or anaphylactoid type of shock.
And then her concern was if we refer to pain management, if we are giving morphine in the setting, she would have to cause histamine type response. And so it'd be hard to determine, are you now in anaphylaxis, or is this just a histamine? The fentanyl would be the preferred drug, but recognizing not everyone in the state carries fentanyl. So maybe specifying refer to management of acute pain, but that would give paramedics large, but it's more of an educational, this is a very broad general that I feel like there's a lot more that could be put in this to make this more useful. Like fentanyl is preferred over morphine due to this for histamine relief.
I think that's fine.
I really didn't have a hypertensive case.
We have it to the pain, but if you.
Oh, there it is, sorry.
Yeah, it's
Okay.
under, it's up high, it's under the EMT section, so then you get into, are they gonna look at that? So one option would just be to list the bullet under EMT / paramedic, and just say
Yep.
fentanyl is
Yeah,
preferred.
you can use a sentence right after that, yeah, or a bullet. The other thing is, we don't want to be given any, platelet poisons like, ibuprofen to any of these patients that could have coagulopathies from snake bite. So, I would just put, ibuprofen is contraindicated and, or do not give ibuprofen to snake bite patients.
So fentanyl is preferred over morphine.
To avoid histamine release period. Do not give ibuprofen to snakebite patients for pain.
That's gotta go back up.
That would go under EMT section, under pain management.
Yeah.
And that's gonna rule, by that statement, is that gonna rule out morphine for AMTs because they don't have fentanyl?
Yes.
Well, we just
No,
say
well, it's just
fentanyl
saying-
preferred.
It's not, yeah, it's preferred, it's not,
Yeah, we're not ruling it out.
Okay.
So we're saying under the EMT section, we will add, do not give ibuprofen for rattlesnake invention.
That's correct.
And then she said, she felt like somewhere in here it should be stated that all rattlesnake invention should be transported.
I agree.
Oh, because she's had some cases where it's
Totally agree.
given quantity that looks good. We
Yeah.
actually called it
No,
out.
they're toxic time bombs.
Not transporting rattlesnakes.
That's what I said too, like, I don't see that in the population, they do see them, so.
Oh, no, yeah. And what online medical drive-by?
Yeah. And I think that's exactly the point, is that there's been a concern that it's a drive-by and then it's a delayed.
Yes.
With pretty poor
And
outcome.
time is tissue.
I think that takes a few hours to rule that out, doesn't it? I've never seen anybody with a drive-by leaving 4 to 6 hours from our ED, I don't think.
So we can go.
See them, okay.
We can.
They take 12.
Yeah, we can 12, yeah.
Alpha.
Yeah, under EMT, top off, just, yeah, if there's people in. And then the only other thing just to consider, she said, you know, for scorpion,
So transport all snake bites, right?
all rattlesnake invention should be transported.
All rattlesnake.
And should we say rattlesnake bites or envenomations? Because the bite's an incident, the bite's an event, and we don't know if they're envenomated yet or not. Most of them are, honestly.
So how about a rattlesnake bite?
Yeah, because then they're gonna say, oh, I wasn't envenomated, I just got bitten. I got a drive-by.
So
And they come in and, oh, you know.
How about regardless of presence of signs or symptoms?
I think it's,
I just say, if they're bitten, that's it.
so we have
Keep it
4 minutes
simple.
left, we need to vote. We are not gonna get through everything today, but we've gotten through a lot. The one thing I just wanted to clarify in here is just, she also mentioned with scorpion renovations, that you really wanna consider benzos and fentanyl. Do we add that in, or do we just leave this with pain control right now and just recognize this down the road probably needs a little bit more expansion?
I think you could leave it.
I mean, there's gonna be a subset of patients who get anti-venom and we don't want them hyper-medicated.
No, she said now she said that kids are not getting delayed treatment as they're waiting for the antivenom when they should have been getting benzos and fentanyl to get more comfortable to prevent seizures. I think that, I said the same thing, that was the whole teaching.
I would say you could do an agitation link. We've got agitation protocol, right? But you wouldn't give ketamine, you just give the benzos.
I think that's making sense.
Yeah, and for kids, we don't have the ketamine anyhow.
No.
Right. So, refer to agitation as indicated.
Yep. Yeah, because that's what they are, and then we're gonna give them high-dose benzos, and we already got pain management in there, and then we don't have to make up a whole bunch of new stuff.
Perfect.
And no
So
ketamine.
where are they gonna note the no ketamine?
Do not use ketamine for, scorpion envenomation. Or scorpion stings. They're not bites, they're stings.
I would put that under for just straight term, okay.
And the very last line, refer to shock, should get moved up to EMT.
Yeah, those are all,
That's
we're
all.
gonna figure that all, yes.
Okay.
So it's of an already. All right, so I think we have captured the formatting stuff that we've done offline. This is the top section, so I'm gonna do a vote on the top section. So PMD members, anyone opposed to the top guidelines as discussed, please say nay. Any abstentions? All those in favor say aye.
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 NDC members, anyone opposed, say nay. Any abstentions? All those in favor, say aye.
Aye. Aye.
So we got through really the vast majority. We had a few guidelines to go through, at PMD, which is in March. So, we are very close. So thank you very much to everyone. I really appreciate you.
Is it just childbirth and OB that's left?
No, and this one, appendix.
I was gonna say we can knock them out if.
Yeah.
Appendix is a dirty.
Yeah, they're not a free
Are they kicking us out of the building?
That's amazing.
That was great.
I'm impressed. We pulled out of the box.
Earlier in the day, we talked about removing the colon, and I was like, oh.
Hey, yeah.
Or the semicolon.
Yeah, okay. That's very good. Surgical, I was thinking of it a little different.
Motion to adjourn.
Some of it.
All right, thank you everyone who's been on the line, we appreciate it.
Semi-collectively?
I, that's more than I thought, maybe 30.
I don't know.